వేరే మొబైల్తో దేన్ని చేసుకుంటాను. నేను పంటలు ఉన్నాయి, గందరగోళంగా ఉంది, అందుకని పరిస్థితి. ఆ మెమరీ కార్డ్ అది ఇది ఒక్కోసారి మాట్లాడదాను. నరసింహం
Thank you, Harshini, Vaishnavi, Ram Vaishnavi, and Bhavishya Reddy. Thank you, it was really wonderful. All the children are from Ralabella School. They represent Ralabella School, and we thank our Sibadalai sir for giving this wonderful opportunity to us. I'm also from Ralabella School. Thank you. Now I would like to request our two of other children who take this event further. Kashika Rajnala, please come. Sidvi Nayak.
Good morning, everyone. A warm welcome to you all present here. I am Kashika Rajanala from Grade 5 Ralabella International School, and
I am Sidvi Nayak from Grade 6 of Ralabella International School. Now it is time for the lighting of the lamp. Let us call upon
Professor Shailesh Gaikwad, sir,
Dr. Uday Nayak, sir,
Lighting of lamp.
Professor K.V. Liu, sir.
Professor S. Gopi, sir.
Sir.
Dr. Rajesh Pati, sir.
Professor Ajay Kumar, sir.
Dr. Karunakar Pati, sir.
Dr. Hemant Kumar Mehra, sir.
Dr. Pankaj Mehta, sir.
Dr. Siva Shankar Dalai, sir.
Dr. Kahiralu Azmi, sir. Thank you.
Thank you.
Professor Ruchira sir, please join us for the lighting. Please, sir.
లాస్ట్ మిమ్మల్ని ఆపరేట్ చేస్తాడు ఒక హెల్పర్ని తీసుకురావాలి. బయట టీవీలు పెట్టారు
వచ్చింది చూడు ఒకసారి ఒక టీవీ పెట్టి చెప్పండి చెప్పండి
Thank you so much, sir. Now I would like to invite Dr. Sailesh Gaikwad, sir, ISNR President, for the presidential address.
ఖాళీగా ఉందా ఖాళీగా అదే ఒకసారి చేయండి సార్ ఇప్పుడే చేసేదాన్ని ఫోన్ చేశారు అమౌంట్ ఫోన్ పే చేసి
వస్తుంది ఫస్ట్
అమౌంట్ ఫోన్ పే చేశాను
ఓకేనా తర్వాత మళ్ళీ
Delegates, my colleagues, your friends, and representatives from the state. Good morning and very warm welcome. It is a matter of great pride and privilege to be standing here in front of you and delivering a presidential address in the form of President of the Indian Society of Neuroradiology. A little brief about the Indian Society of Neuroradiology. This is a society which was established in 1998, and the first conference was called the Neuroradiological Symposium. This was held in 1998 in Delhi in Fiji Auditorium. That had an attendance of 365 delegates. It was jointly organized by Dr. Harshmajan, myself, and Dr. Sandeep Karwala. Taking a cue from there, it was decided to have annual meetings. And since that day onward, we started having annual conferences. And beside the annual conferences, we also have something called a midterm series. The format of this scientific program is to have one national meeting, which is generally organized in the metropolitan cities with good airway connectivity. But we go to tier 2 cities where midterm CMEs are organized. The idea is to percolate, disseminate the information about the field of neuroradiology and encourage the budding young radiologists to join this mainstream. This is a platform which gives the opportunity to all the neuroradiologists, whether they are experienced, seniors, doyens, or budding, so that they can share their experiences of the attendees, and it becomes a model of mutual gain. Everybody gains from everybody's experience. Today the society has close to 600 members, and it has grown by leaps and bounds over the last 2 decades. It has made a tremendous progress, and we also have now a structured program, 3 years, DM Neuroradiology, which is run in Institute of National Importance, including AIMS, Shrijitra Trivandrum, NIMHANS Bangalore, PIJA MER. HGPJ Lucknow was trying to set up this program, but unfortunately it could not make headway because of their local issues. Yes, we have another private setup, I think the Delhi University in Chennai. Besides this, we are trying hard to get this program established in other state medical colleges. There's another parallel program which is called a DLE, which is set up in last 2 years. Right now there are some issues pertaining to the post curriculum, so we are working on it. And they have also included the MD radiologists in the eligibility criteria. So, coming to this place, this is my first experience that I'm coming to Vizag, and thanks to Dr. Siva Salai for taking the onus on himself and making this happen. This is a beautiful place, and unfortunately I don't have much time to go around the city, but I will prefer to stay here the whole day. Today, tomorrow morning I am leaving, but looking at the program which has been put forward by Dr. Siva and his entire team, it looks very promising. And I'm sure those who are attending this meeting, they will be benefiting a lot from the experience of the speakers. And the speakers are very well experienced, they are versed with the topic, which they are going to delve on in the next 2 days. So, welcome once again, enjoy the meeting. I'm sure you'll enjoy the hospitality which has been extended by Dr. Siva Salai. So thank you very much for calling me here. So enjoy the meeting. Thank you.
Thank you so much, sir, for sharing your thoughts. Now I would like to call Dr. Shivasankar Dalai, sir, to give opening remarks.
Welcome, esteemed colleagues and guests. Welcome to ISNR Vizag 2023. It's a privilege to stand before this august gathering. In this coming 2 days, we will dive into the most simplest to the most complex neurointerventional procedures that we do, which benefits immense number of patients who are suffering from neurovascular diseases And the audience has come from the entire region and the speakers from the entire country. Basically, the ISNR has given us a wonderful platform to come along with this meeting. So enjoy this upcoming 2 days of academic extravaganza, and let us start with the academic program right away. Thank you.
Thank you so much, sir, for your insightful words. Now let us move into the academic core of the conference. Our next session will explore acute ischemic stroke overview and current IV thrombolysis guidelines. I'm honored to invite our distinguished chairpersons, Professor G. Bucharaju sir, Professor K.V. Lu sir, Dr. Rajesh sir, Dr. T. Mohan Maharaj sir, and our esteemed speakers, Dr. K. Suresh Kumar sir, onto the dais.
She is the best. ISNR ఇప్పుడు కరెక్ట్
Good morning, everybody. The first lecture will be by Dr. Suresh Kumar, who will be speaking on acute ischemic stroke overview and current IV thrombolysis guidelines. Last decade has seen a lot of advances in acute ischemic stroke management, especially in thrombolysis. And the guidelines have been widened in the last few years. I hope Dr. K. Suresh Kumar will be covering all that. Welcome Dr. Suresh to speak on this topic on IV thrombolysis.
My name is Suresh Kumar. I'm working in Medical Hospital as a consultant neurologist with Professor K.V. sir and Professor Bucharaju sir. And thank you very much for inviting me as a speaker and the other team. And today I will discuss about the current guidelines of acute ischemic stroke management. Coming to the epidemiology, stroke is the second most common cause of death in the worldwide. India it is the fourth most common cause of the death, and most of the stroke affects the younger population, and there is severe disability, sometimes that also. And the life expectancy in the India also is increasing to 60 years. So non-communicable diseases like stroke and cardiac diseases are now increasing. Coming to the pathophysiology of the stroke, here is a deformed tissue, reduce blood flow. This is the ischemic area which has reduced blood flow but salvage the tissue. So coming to the first, initially there is decreased oxygen supply to the brain, and then it causes acidosis and it reduces the protein synthesis, and the glucose utilization will be increased, and later on excitotoxicity causes glutamate. Increased glutamate causes anoxic depolarization and ionic pressure. It causes Na+K+Ca+H dysfunction and increases the water flow into the cells, which causes cell death. So, coming to four broad types of ischemia: transient and permanent. These are focal and global. Focal is the one part of the brain is involved, mainly where the embolus is obstructing the one part of the circulation. Global is entire circulation is blocked. So it may be transient and permanent. Transient is like embolus is blocked and the interstitial occlusion. And permanent is if there is aneurysmal occlusion, that area supplies the blood, there is So pictorial diagram of the same thing. Increase the blood permeability, endothelial cell damage causes, increase the free iron radicals, and then increase the permeability of the protein form, and increase the free iron radicals, which causes cytotoxic damage to the mitochondria, and then it increases the glutamate, which causes reduced ATP secretion, reduced ATP synthesis, and then increase the permeability of the water to the cells and cell death. So, how to go about the stroke thrombolysis or stroke management? There are two components. One is pre-hospital component, one is the emergency department. Before attaching to the emergency department, we should check all this. Recognition of the stroke symptoms by the patient and family. Maybe BPAS, balance, any eye symptoms, loss of balance, any eye symptoms, double vision or loss of vision, and facial weakness, arm weakness, and speech. These are the recognizable symptoms which may need stroke management. So first contact with medical care and then the dispatch the appropriate level of pre-hospital care providers, pre-hospital evaluation and management and transport, pre-hospital identification of the stroke and pre-hospital notification to the ER department. So it should be like in the patient once comes to the ambulance, then only they can pass the information to the emergency department. In the emergency department, we have to triage the patient. Each patient is like whether it is like within window period like within 3 hours, within 4.5 hours, or within 24 hours. Then you can plan for the management, and you have to do the urgent imaging to determine whether it is like ischemic and hemorrhagic stroke. Preferably CT within the patient present within 4.5 hours, better to go for CT scan. If it is more than 4.5 hours, better to go for MRI scan. Then you have to see the IVD eligible criteria. Later I will discuss this one. Selection of the patients with acute ischemic stroke with large vessel occlusion. If large vessel occlusion means thrombolyze the patient and later on you can need endovascular treatment. So time is brain, as you know. So within nearly 2 million neurons die in each minute with laser treatment. Each hour without treatment of the brain loses average neurons of 3.6 years of normal aging. So before starting the treatment, we should not clarify the So this is very important. Whenever the patient is last seen normal, is very important. Once the time was normal, when the symptoms are started, what are the main neurological deficits? Whether they are improving, they are worsening. A relevant past medical history, any atrial fibrillation, or any allergy to the cancer, and the baseline functioning is the ideal time is door to needle time. Door to needle time must be less than 30 minutes. Once the patient arrives to casualty, thrombolysis should be done within 30 minutes. And if it is like we are planning for endovascular PT, should be door to needle time will be less than 60. So there are multiple ways of imaging studies. Ideally, within 4.5 hours, contrast CT plane is enough. And there is like out of the window period, there are more than 4.5 hours. Some patients you may thrombolyze or you may eligible for the endovascular treatment. For that, other studies like CT perfusion study and MRI with MRI diffusion weighted, their mismatch and proton weighted imaging.
ఇప్పుడు కొంచెం ముందుకు
CT perfusion imaging, cerebral blood. First one is cerebral blood volume. Second one is cerebral blood flow. Third one is mean transition. We see here the cerebral blood volume depends on the uptake of the code. Here we see it is cerebral blood volume is reduced.
అటు ఇటు ఒకటే కాబట్టి ఇలా పెట్టాను అటు ఇటు సేమ్ డిస్ప్లే కదా
Mean transit time is increased, so it is becoming red. So this area is infracted area and surrounding area is service area. So same thing in the MRI, diffusion weighted, the infract is there. So there is infract and surrounding core area also there is mismatch between the intra area, core area, and the current area. You can take up from the MT. And if it is more than 4.5 hours after the stroke symptoms, this patient may improve with the, there is large ILS upload, he may improve with MT. So principles of the treatment, 3 C's. One is collaterals, second one is core and penumbra, third one is clot. So address the clot with IV thrombolysis and intravascular thrombolysis. First is support the collaterals or augment the collateral support, mainly by the blood pressure management. Sometimes hypoperfusion, hypotension causes hypoperfusion and may increase the clot volume. So we have to maintain the blood pressure is more than 150. If there is any large vessel, of course, we have not yet thrombectomy was not planned at that time, but better to maintain the blood pressure more than 160. Core and penumbra, so we have to protect the main penumbral area because the core area is dead area, so penumbral area is about to die, so we have to protect that area. But the neuroprotection treatments are not yet improved. There are so many neuroprotective agents which reduces the penumbral area, but clinical trials it is not proven. So to reduce the clot volume, you have two options, either intravascular thrombolysis, IV intravenous thrombolysis, and
XLR నుంచి వాడతాం కదా.
But depends upon the time of the onset. If it is less than 3 hours, you can go for the IV. 3 to 4.5 hours also you can go for the IV. More than 4.5 hours, it depends on the imaging findings. We can decide about the say IVT versus EVT, but IVT sequence like IVT plus EVT. So mainly treatment is mainly depends upon the location, nature, and clot pattern of the artery. If the clot volume is more than 30 means 3 centimeters, may not be thrombolyzed with the IVT. So chances of opening up a vessel more than 3 centimeter clot is only 30%. You may need mechanical thrombectomy. So mechanical perfusion already we have discussed that hypoperfusion or embolism. So if it is hypoperfusion injury, you have to maintain the blood pressure. If it is embolism, large vessel occlusion, you have to target the vessel. So and composition and possibility of the blood. And the extent of the brain injury and the brain ischemic penumbra depends upon the penumbra. So always brain tissue is more, then you can go for the circulate mechanical thrombectomy. So coming to the thrombolysis history, it started in 1933. Translating the streptokinase. Later, urokinase in 1940. And the mass production of concomitant tissue plasminogen activated in 1991. And this trial has approved RTPA as ischemic stroke management in 1995. 1996 ESTA approves RTPA for the stroke and urokinase streptokinase trials are failed. In 2009, this one took place, trial was failed in 2009, and the 2015 combination of the trials like thrombolysis with neuroprotective and thrombolysis with MT and replace MT. This are published in 2015. So initially thrombolysis depends on the imaging findings. And then this meta-analysis like because IV thrombolysis works behind 4.5 hours. This all these time depends upon time limit up to 9 hours. It is proven, but depends on the clinical scenario and the imaging findings. And take-ups where there is diffusion clear mismatch, we can thrombolyze the patient. And coming to the basics of coagulation cascade. Here you see there is any endothelial injury. Endothelial injury causes tissue factor release. Tissue factor activates the factor 7. Factor 7 activates factor 7A. Tissue plasma. Once the tissue factor binds with the factor 7 activates, and it causes common pathway. Like it activates the common pathway, factor 9 and factor 10. So later on, factor 10 directly activates the prothrombinase with the factor activated factor 5. Causes prothrombin to converts the prothrombin to thrombin, and then thrombin converts the fibrinogen to fibrin. So these are the platelets. So tissue injury causes two. One is increase the tissue factor, and one more is activates the platelets. Platelet activation causes intensive pathway and platelet activation causes intensive pathway and tissue factor activation causes. And all these causes fibrin clump with platelets and blood cells. So why it is important? Because thrombolysis, it's like fibrin rich, whatever we are targeting, that is recombinant. Same thing. Once the recombinant tissue plasminogen is recombinant tissue plasminogen, once it's activated, it activates the plasminogen to plasmin. Plasmin it opens the blood vessel by clot perspective. It is like it increases the fibrin bonding within the clot. So fibrin and collagen is cut down into the pieces. So tissue plasminogen activator is inactivated by plasminogen activator inhibitor, which is binding with tissue plasminogen activator and is inactivated by the liver. So for the proper thrombolysis, it should be fibrin specific and it should lyse the clot and not the not to bleed the arteries. And one more drug recently approved is tenecteplase. Compared to that studies, it's like antiplase was 1995. It is approved as a thrombolysis treatment, and the tenecteplase was discovered in 1993, and second acute coronary stroke, coronary syndrome, it is approved in 1999. Norman price that tenecteplase in ischemic stroke, it is approved in 2005. 2010. Australian study has studied the 2010 tenecteplase, and Australian tenecteplase is published in 2012, and all other studies like Marcus, Attest, and extended TNK. So extended TNK 2 and part 1 and part 2. It's like TNK is better when compared to the antiplase. We are planning for the mechanical thrombolysis. Same thing. So head-to-head comparison of antiplase with the tenecteplase. Here, the tenecteplase is now fibrin selective because of mutations in the kinase 1 and kinase 2 regions. So here, it's like it's a mutation in the tissue plasminogen activator. Mutated tissue plasminogen activator is tenecteplase. So because of this mutation, it has longer half-life. Mutation, higher resistance to plasminogen activator inhibitor, so that the tissue TNK can be given as IV bolus because it has half-life and it is more clot specific. Then this is compared to tissue plasminogen activator, and fibrin specificity is more in tenecteplase. Thrombolytic potentiality also is more in tenecteplase, as you know, is the longer half-life and more fibrin selective. And is more in DNA, so means blood levels will be more compared to the tissue plasminogen activator. So fibrinogen depletion will be less in tenecteplase, so tenecteplase blood levels will be maintained, and the clearance is very low. Clearance is very high in tissue plasminogen activator, very low in tenecteplase. So theoretically, tenecteplase is better to place because of the longer half-life and more fibrin selectivity. In dosage, tissue plasminogen activator is 0.9 mg per kg body weight, maximum up to 90 mg you can give. 10% IV bolus or infusion. Then it can be given bolus plus infusion. 10% IV bolus first you should give, then the infusion is remaining 90% you should run over infusion over 60 minutes. So low dose also tested in Japan 0.6 mg per kg, maximum dose is 60 mg. Tenecteplase 0.1 to 0.5 they are studied, but our ischemic stroke 0.25 mg per kg body weight is better. It's like single bolus. So advantages of tenecteplase is easy to administer, one bolus is enough. Less room for dosing errors because only one loading depends upon the weight you can give. Increase efficacy, faster treatment and better. So if you are planning for mechanical thrombectomy, you don't have the facilities in your center, you can thrombolyze the tenecteplase and you should give to the better center. So once you start, you may not stop the execution. So coming to the contraindication, same thing when should we start this all this thrombolytic things? Whether time window or tissue window, already we have discussed time window is less than 4.5. Some patients with up to 9 hours also they will improve with the IV thrombolysis, depends upon the imaging patterns and depends upon the phenomenon. Absolute contraindication is only bleeding, any bleeding disorders or any hemorrhage in the brain. These are all related contraindication. History-wise, if there is any intracerebral hemorrhage, stroke or serious head injury and spinal trauma in preceding 3 months, any major surgery like 14 days before the cardiac, thoracic, and abdomen, these are all related only. Even after 14 days, you can normalize the patient. And any arterial puncture at non-compressible site with the last 7 days. Clinical examination, if there is any symptoms of SHA, we do the ABC, start the thrombolysis. So any symptoms like severe headache, vomiting, and then focal head shake, maybe chance of SHA will be more. And stroke symptoms is another non-ischemic cause like seizures. Sometimes seizures are supposed to palsy. So initially the NIMS guidelines, seizures was the contraindication because after seizures, patient may have focal head shakes. So now this is a related contraindication only. You have to see the patient improvement of focal head shakes and then the hyper and hypoglycemia, both can cause focal head shakes. Hypertension refractory to the treatment, less than 180, should be less than 180, which is more than 180. You should reduce that pressure to less than 180. And this also, Professor Sachira also will discuss this regarding this guidelines. Patients currently are taking anticoagulants. And then the lab parameters, there is an extensive infraction, science of extensive infraction. Even relative contraindication only, we can thrombolyze as a schedule. Like more than 3 centimeter clot, it may not lies with thrombolysis. Chances of rising of thrombolysis with IUD is only 30%. Blood glucose, hypoglycemia, and PKNR is more than 1.7, platelet is less than 1 gram. And the other stroke markers like we, as I discussed about hypoglycemia, hyperglycemia, and other things, we should, before thrombolysis, we should assess that. I discussed this thing, time window versus tissue window. Time window initially 4.5 hours, tissue window, if there is any infected tissue there, then we can thrombolyze the different. These are the different guidelines. NIHS is like complete resolution of the stroke symptoms and improvement in NIHS score less than 4 or less than 4, we cannot thrombolyze. NIHS is powerful outcomes at 3 months. Like if you thrombolyze within 4.5 hours or within 3 hours, outcome will be very good. So SCAS 3 means was the multi-center or randomized controlled study. Then it includes the more than 80 years of age, NIHS more than even the old people and severe stroke also they are included. But primary outcome and disability and other things compared to other things is unfavorable with the application. The same extent depends on the time increment. If it is less than 4.5 hours, IVT is better. If it is more than 4.5 hours, IVT with endovascular thrombolysis. If it is more than 4.5 hours, there is extensive thrombus and we may not be resolved with IVT, we can directly go for the EVT treatment. So if we 2010 pool analysis showed that this could be overweight the benefit of intervention, like it will give more than after 4.5 hours of the stroke symptoms. This will give more. But we use the MRI, so there is diffusion weighted and in fact in the diffusion intravenous thrombolytic therapy and endovascular therapy both have demonstrated improved outcome, especially in the patient with severe strokes. So the IVTP is ideally should give within 4.5 hours. Some patients up to 9 hours we can give, but it should be like combination with MT. Same thing. So diffusion phase signal changes is there. So it's like this area is like if you don't thrombolyze or don't address the clot in this area patient, he may develop a severe stroke. So now extended trial involving the patient with ischemic stroke despite of the late presentation more than 4.5 hours, less than 9 hours, had hypoperfusion but solvable regions in the brain. So the primary outcome of MRS 0 means good outcome. One is independent walking. Is only 35. So in selected patients, we can use up to 9 hours also. Depends on the this thing. So same thing in the tabular form. Intravenous thrombolysis less than 4.5 hours. All patients showing signs of any acute disabling stroke, we can directly thrombolyze the patient. Depends on the CT and CT angio finding. 4.5 hours to 6 hours. If there is any disabling, patients have disabling stroke symptoms, CT perfusion or MRI must, because 4.5 hours. So imaging suggests to any infarct tissue, salivary tissue can have 6 to 9 hours also same thing, CT or MRI imaging for the time. So endovascular is up to 6 hours is like much more than 6 hours if there is CTP or MRI imaging suggests to any salivary tissue, we can go to can TNK be used with EVT? Yes, it can be used with EVT and vascular thrombolysis. Can the ambulance? Yes. Or it may reasonable to choose the tenecteplase over IV altiplase in the patients without contraindication for IV thrombolysis. Tenecteplase admission 0.4 is not being proven superior because it may cause bleed also. These are the source guidelines. This really recommends the altiplase rather than the tenecteplase. And then tenecteplase, for tenecteplase only one you plan for anti. Canadian they are not recommended whether CT is better or TNK is better. You can use both. Australian guidelines, initially TNK is better for the early results, and then if you are planning for the MT also, you can go for the TNK. So early neurological deterioration, maybe it may be due to the bleed or angioedema, so depends on the scenario. We can, it's like if there is patient is after thrombolysis some improvement is there, and later on early deterioration on to 7 to 10% of the patient may develop this early deterioration after the thrombolysis. We have to see whether maybe because of the clot volume progression or edema or some bleeding. It depends on the bleed, we can go for the treatment. So if it is PAT-INR is more than 1.5, you can give the PCC and vitamin K. If the platelets is left, give the platelets. Same thing, early neurological deterioration, I discussed already. This angioedema also. Angioedema sometimes common with the patients who are taking basic inhibitors because it increases the bradycardia will increase after the basic inhibitors because factor 12 and later it comes to convert into bradycardia. ACE causes bradycardia, so bradycardia will be increased. So it may cause and assess the airway. Edema and complete edema is there, and then we go for the ENT consultation and require intubation and increasing the community awareness regarding the stroke symptoms, community education training and first aid and other things in the ambulance only, and they should inform the pass on the information to the emergency department, and then patient registration, post-treatment, and then maybe we can green corridor also can access. And it is once he comes to the hospital, we see the NHS scoring, and then it depends on the criteria, it depends on the CT finding, we can particularly we can take up for the IV thrombolysis. From the history, just streptokinase started in the 1950, and later on urokinase, and 1995 RTPA, now connect to place. So maybe in the future, better problem specific, better fighting specific, and less issue like this. And maybe in future, uroprotective agents, combination with IV thrombolytic agents. So summary, so pre-hospital notification of any serious stroke like FACR, limit and testing to last seen well within 24 hours, and enter about the blood glucose and plan for CT scan. Once the patient comes to CT scan, it should be done within less than 10 minutes. And if there is any bleed in there, normally it is contraindicated. If there is any infarct, and it's always going to be serious, then we can go ahead further.
Thank you, Dr. Suresh. The comprehensive presentation of the stroke and the thrombolysis. I think we have time for a couple of questions from the audience.
ఒకసారి ఇది లూజ్ చేయవా ఇది ప్యానింగ్
Is there any rationale behind that, or can you follow point to find? My second doubt is 0.25 mg per kg of tenecteplase is the dose that we all international guidelines suggest that.
Yes.
But Indian stroke guidelines, which were released in 2009 by the government of India, approved tenecteplase but at a dose of 0.2 mg per kg.
0.2.
Yes. That is my first doubt. My second doubt is when we have a specific scenario where we have a wake-up stroke and we see infarcts of different ages. For example, I had a patient with insular infarct as well as a caudate infarct. The caudate infarct was seen on flare, but the insular that was not seen on flare. So how do we approach such a case?
That's what I don't know actually. Do 0.25 milligram per kg body weight.
The study was carried out in ages with 2.2 mg and 0.25 mg milligram per kg body weight. And what we observed that if we gave a dose up to 0.25 mg, there was no hemorrhagic complications. So then the standard dose was arrived at was 0.2 mg for Indian patient. So this was the study carried out by Dr. Kameshwar Prasad at our place. That's maybe the reason I think Government of India might have taken that view and issued the guidelines.
Second one is taps are one sense you are telling. Like one is in the cardiac area, one is in the insular area.
They are of different ages.
Different
One
ages.
is seen on flare, but the other is not seen on flare. So can we still proceed with
With reservoir imaging is okay. It's like any occlusion in the
no large visual occlusions?
But once it is like there is in that scenario there is clear cut diffusion perfusion mismatch in one area, we can go ahead.
This is a practical problem that we face when we don't have perfusion imaging and we come across such a patient.
How old do you think is the so-called old part?
the patient is a wake-up stroke case, sir, and we see two infarcts, two acute infarcts. One is seen on flare, but the other is not seen on flare, sir. Both are not seen on T2. So in such a situation,
At least one issue is there, diffusion mismatch is there. I think we can go ahead.
I think you have to salvage the tissue at risk, and still we treat patient with heavy traumas.
okay, sir.
Getting happy.
See, we had cases similar scenario. So the second stroke is more disabling. Okay? And if you see the, if you calculate the volume of the first stroke, it is less volumic. And if you don't think it, more chances of hemorrhagic conversions are there. If you don't think any hemorrhagic conversions are there, and the second stroke where you have a mismatch, you think the disability is more, we still go ahead and traumatize. There you have to weigh what is the clinical scenario. See, if the second stroke is in the internal capsule region, and patient is more disabling. So there is a diffusion there mismatch. In the opposite side, there is no mismatch. Where you don't feel no risk of hemorrhagic aspiration, you still go ahead and do traumatization. That's it.
And we have to see the mechanism why it is happening, like cardiac and other things.
Thank you.
Thank you, sir. Thank you, the organizers for this opportunity. Thank you so much.
Thank you very much.
Thank you, Dr.
Thank you
Suresh.
so much. Thank you so much, sir. Now I would like to call Professor K. Satyarao, sir, to share his inputs on thrombolysis in acute stroke in patients on anticoagulants.
Side.
Good morning, everybody. Chairperson, distinguished guest speakers, my colleagues and friends. It's a great opportunity for us to be heard in this conference, and we are here to learn new things and improve our knowledge. In this phase, my talk is on thrombolysis in acute ischemic stroke, where the patients work on anticoagulants. My colleague has already described an extensive talk on the thrombolysis in acute stroke. Acute stroke is a masterpiece where you have to run, literally you have to run and treat the patient. The door to needle time, which is nothing but the time required and the brain survival. The earlier we receive the patient and earlier we put in the needle and thrombolyze, the improvement is far, far better. If we thrombolyze within 3 hours, the improvement is quite better, and the time is extended from 3 hours to 4.5 hours in the recent guidelines. After an extensive discussion, just I'll have a past scenario. I'll pass in the topic because there is a little overlap or my colleagues' slides. So let me talk something about this. And then the stroke burden in India. And almost 1.5 million stroke cases every year. And out of these, 7%, 70% are the ischemic strokes. And this is the fifth leading cause of disability and fourth leading cause of death in India. And what is it we are doing for these people? They think the important treatment of choice is the thrombolysis, where we are not able to attain. We are not able to get the patients within the time window. If we get the patients within the time window period, then we can do justice to these people. But what we are doing is just this one, that is 0.4% only we are able to do it. Now if you see the thrombolysis versus no thrombolysis within the period, take the MRS score, 0 to 2% score, the improvement is far better when compared to the score of more than that. Now, if you see the patients with an heterogeneous multiplex or the thrombolysis, the recovery rate, if you see, the functional independence occurs in around 62% when the MRS score is 0 to 2. Whereas functional independence is not attained and there is some disability attained in almost 35% of the people, and in death we see around 2 people. The various studies have done in attaining a particular dose of the thrombolysis. The first dose they have taken is the articulation. They have tried with various doses and the various time duration, and ultimately they have reached the duration can be up to 3 to 4.5 hours, and the dose of articulation attained at 0.9 milligrams per kg per weight. And the recent evidence of availability of the inactivation, which made us to use more frequently, because it's a single shot treatment and it is 0.25 milligrams per kg body weight. So this tissue transduction activator, NIMS trial, they have done this and attained the dose of 0.9 milligrams per kg body weight within 3 to 4 hours, 4.5 hours. ECA study also concluded these things. Intravenous artery is initiated within 3 to 4.5 hours after the onset of the stroke symptom. It's effective treatment for the patients with ischemic stroke who cannot be thrombolyzed within 3 hours, with no element increase in the intracranial bleed compared with the treatment within 3 hours. A viable therapeutic option for the many patients previously excluded from the thrombolysis by using the nano treatment diameter. The sixth criteria also they have used almost compared with the ECAS trial, and they have concluded that the 3 to 4.5 hours is the window period where you can use the thrombolysis. The same guidelines. Now, the recent trials, they came to a conclusion with the revision of the criteria which were laid down by the NIMS. These are the SPOT criteria. The simplified management of acute stroke using revised treatment criteria. What are these things? Because the NIMS have posed many contraindications where we are not able to thrombolyze the patients. Many things. So which were just neglected and ruled out because they are all not evidence-based. And the main thing which is an absolute contraindication is in heterosepal. They have posed many things like age. Age more than 80 years is contraindicated. Infarct size more than 1/3, it is contraindication. If the patient has hyperglycemia, a contraindication. A hypoglycemia, a contraindication. she is the contraindication. Everything, what not. The patient has somewhere at 3 months back, the patient had an intracerebral, head injury, or a bleed in the urethra, that bladder bleed. Everything is a contraindication. So now, the simplified criteria has excluded all these things because they come in the way. You are not able to traumatize many people. We are not saving the lives of the people. So, the simplified criteria make us to know the only contraindication where you cannot traumatize the patient is only intracerebral hemorrhage, nothing else. You can compensate all these things with the treatment of the traumatize and give a life to the patient. Now, the reduction of the RTBA exclusions. Symptoms must be disabling. This, I want to stress on this. It is not the size of the infarct which is a contraindication or the indication for the thrombolysis. It is the disability which is needed. If the patient is disabled, though the infarct is small, please thrombolyze. You are giving your life to the patient instead of having a disability, the hemiplegia, lying down on the bed. Though the infarct is big enough and the disability is more, or the infarct is small, but the disability is very high, please traumatize the patient when the patient reaches the hospital within time, within the window period. If it is unclear, should we treat, that is, stroke mimics? Here the confusion always comes when the patient comes with a stroke mimic. I will tell you only a few things for this. The patient has hemiplegia. You got an MRI done. The MRI is normal. So remember one thing. The manifestation in MRI is seen in 80% of the people, the MRI will be normal. So when the patient has hemiplegia, when you have a clinical strong evidence that the patient has an ischemic stroke, though the MRI is normal, please thrombolyze. The patient has a seizure, but the patient has hemiplegia. We may think that is a hard task, but the disability is there and you can thrombolyze. This will not do any harm. This will not produce any intracerebral hemorrhage. So please see that the patient has a stroke mimic, but take the evidence that you can treat the patient and the thrombolyze the patient, so that you can say, if you don't do it, that means we are neglecting the patient and producing a disability. The conclusions, hyperacute stroke therapy, still time sensitive. Several emerging therapies to expand the treatment eligibility. Implement the smart criteria which are given. And stroke centers, they do a lot of things. When we are not having a stroke center, we are giving less number of thrombolysis. In the stroke center, they have the facility. They have the facility to transport the patient from the house to the center where the thrombolysis can be done. So that is still we are waiting. Still we want it to be improved. When the patient has a stroke, he has a time. When the patient informs the moment the patient is in the ambulance, and if you have to see the Western countries, they do it in the ambulance itself. They try it in the ambulance itself. They have the facility in the ambulance. We are not having those things. I think we will get them within a short time. If we have the facility to shift the patient within time, within the window period, then we can do miracles with the patient. We can give the life to the patient. IV versus intra-arterial thrombolysis. What is this? If the patient comes within 4.5 hours, happily we can thrombolyze the patient with the intravenous route. If it is more than that, what they say is, though you thrombolyze intravenously, the patient can be treated with an intra-arterial thrombosis. Intravenous thrombolysis is not a contraindication for the intra-arterial thrombolysis or thrombectomy. Why? Because when you give intravenous thrombolytic drug, you can prevent the further extension of the thrombus, and you can make the clot supple, so that the interventional radiologist can happily thrombolyze by intraarterial route, or he can easily do a thrombectomy. Because the duration of the intraarterial thrombolysis takes more time, because he has to go for a conventional angio, he sees the block where it is, then he has to lyse this clot. Before that, if you can give an intravenous thrombolysis, it is easy for the patient, for the interventional radiologist to go ahead with the thrombolysis. So it is better than IV due to because they say they are the myths. There is some difference in the manifestations and the criteria laid down and the following the management. IV intraarterial is better than IV due to higher recanalization rate, not being conclusively shown. Intraarterial better if the stroke occurs more than 3 hours, ECAS reports. Intraarterial better in vertebro-based stroke, similar outcomes in meta-analysis is there. Intraarterial superior if the occlusion seen on CT or MRI, the criteria we already discussed about that. And diffusion and diffusion image, it is really a wonderful thing when you will see the infarct in the diffusion weighted image, and if it is not there in the diffusion image, I mean the diffusion, you can go ahead with the thrombolysis, because the time is less, it is less than 4.5 hours. Now, let us come to the management when the patient is on anticoagulant. You see the number of patients who are in the cardiac department and the cardiothoracic surgery department where the patients are on anticoagulants, oral anticoagulants. It may be vitamin K antagonist or the thrombin inhibitor or factor 10A inhibitors. These are the common anticoagulants which are used in the case of low atrial fibrillation or sometimes in the venous thrombosis or some other diseases where they require the anticoagulants. If the patient comes to you while the patient is on anticoagulant, the patient may develop a stroke. So what to do? It is a complete check. We have to traumatize the patient when the patient is on anticoagulants. Because there is a very possibility that the patient can have a bleed, intracellular bleed, which may disable him. So what to do if the patient comes with a stroke and the patient is on oral anticoagulants? So the important thing, the moment the patient comes to the hospital and he is within the window period, you have to run to treat this patient because the time is less for the evaluation of the patient. Hematological evaluation is necessary in this patient. You have to see the hemolytic factors. If you are able to estimate the APTT and the thrombin time and protein the INR. If the INR is less than 1.7, you can happily go ahead with the thrombolysis, though the patient is on oral anticoagulant. If it is more than that, what to do? So which type of anticoagulant he is using is important here. Is it vitamin K antagonist or thrombin inhibitor or factor 10A inhibitor? This is what we have to take into cognizance and treat accordingly when the patient has an INR more than 1.7. So in such a case, if you find the INR within normal limits, it's okay, you can do the thrombolysis. If it is more than 1.7, you have to give the antidote and then thrombolyze. So if it is a vitamin K antagonist like warfarin, you give to the patient this FFP 4 packets, give intravenous vitamin K can save the patient. If the patient is on antithrombin inhibitor, then what to do? Because this factor 10A inhibitor and thrombin inhibitors, this is dabigatran, apixaban and rivaroxaban. These are some problem with these things because we are not having the lab test availability immediately in the centers. Most of the centers we are not having the evaluation of the factor 10A and the thrombin levels. If you are able to do it, if the INR is more than 1.7, you give the corresponding antidote. Etanercept in the case of dabigatran, and in the case of apixaban and rivaroxaban, then the corresponding antidote is available for. But the availability of the antidotes is still not possible in the country because we may lose the patient. If the antidote is available, then there is no problem, we can use it. Yes. So what are the antidotes you give in the case of thrombin inhibitor and factor 10A inhibitor? It is the adnexate alpha. If you give this antidote and if it is available, then you can thrombolyze the patient happily and save the patient. So, AH and ASA guidelines against thrombolytic therapy when the patient has ischemic stroke while the patient is on anticoagulant. But the present guidelines are if the INR is more than 1.7, you investigate thoroughly and give the patient the thrombolysis after giving the vitamin K and FFP and the corresponding antidote in the case of other anticoagulants.
No. I present you one important case which we have managed. We have managed recently 3 cases, one by my colleague and 2 cases by me, where the patients are on anticoagulants, that is warfarin. Here is a patient who is 53 years old, who developed an acute left-sided weakness, and he underwent double wall replacement exactly 1 year back, and the patient was on warfarin 4 milligrams per day. And he came to the hospital within 1 hour of the onset of the stroke. When once the patient on the anticoagulant, we have to run to investigate thoroughly the coagulation profile. So we could get the PT and INR and other investigations, we have done it within time. And he came with a power, when we examined the patient, he was conscious and his power was 2/5. So we have evaluated him. We found that the INR was less than 1.7. So it is a chance for us to do the thrombolysis in this patient. All the other investigations like 2D-CO, RFT, LFT, blood sugars, everything was normal. So we have thrombolyzed the patient. We have the availability of the tenacteplase at that time. That is 0.25 milligrams per kg body weight. We have given a single bolus dose and the patient was safe at that time. The last dose of the warfarin was 12 hours for him. So we have thrombolyzed the patient and you see the infarct size on the right side involving the temporoparietal region. It is an extensive infarct with a disability 2/5. So we have thrombolyzed the patient. Video play, please. Yeah. This is the patient. This is the grade 2 power.
left leg.
He came within 1 hour of the onset of the stroke. And we have thrombolized patient with a 10 active plates, 0.25 milligrams per kg body weight. Next, please.
ఇంకా గట్టిగా ముయ్యండి, గట్టి బిగించండి, పళ్ళు చూపించండి.
Yeah. This is after 1 week of the thrombolysis, the grade 2 power, now he is able to walk. He has gone walking to the home. This is the miracle of thrombolysis, where we can give the life to the patient, a normal life to the patient. Yes, thank you. Now this is the publication, a short review of thrombolysis in ischemic stroke patients in anticoagulants. This was published in the Annals of Neurology and Neurosurgery in the last year. Thank you all.
As a working professor, there's nothing to ask him, but anyway, any questions are there we can ask. Yeah, but audience, any questions? Karnakar sir.
Thank you, sir. Very excellent presentation. It's like classroom teaching. Even if we are not in neurology, we could able to understand a lot of things. And very interesting the case, sir, which presented was operated by me, and patient was really very happy. And frankly, I didn't have that idea that patient on anticoagulation can be thrombolized so safely. And I think another patient also, Dr.
Yes, yes. We have done 3 cases.
3 cases.
Now,
all of them
one
are
more case
coming
by me and
forward.
one case by my colleague.
Yes,
who had some complication at that time. He had a bleed from the suture line,
Yeah.
but he improved very well.
Even one more case also, he was supposed to undergo CABG, he developed stroke, was thrombolized, now he is coming for CABG next week. So this is really a wonderful modality of treatment, and before we used to lose those patients, or they will be in chronic disability, and good, thank you sir, it is a very eye-opening for all of us.
Welcome, thank you sir.
But as you said, Karunakar sir, it's a balance between cardiology and neurology. Where you want to give, but they don't want to give.
Yeah.
There are no more questions. I thank both the speaker, doctor, for the wonderful presentation on thrombolysis in stroke. Thank you. Yeah.
Sir, is there any role of recently approved, FDA approved drug, Novotel in acute stroke, or in these cases where we can't thrombolyze?
Please repeat that.
Is there any role of Novotel, sir?
Roll up?
Novotel, Tyvalgi, sir. Recently FDA approved drug in acute ischemic stroke.
No, I don't think it is FDA approved.
It is
Sir,
not
it is
approved.
recently approved, sir, in acute ischemic stroke.
No, I don't think we have any such thing available now. It's approval and other things. And we have not come across these things.
Actually, this drug is mainly for those who have missed the thrombolytic therapy.
Yes.
So the trial included all patients who were ineligible for the thrombolytic therapy, but they reached the hospital within 24 hours. Again, the outcome was evaluated at the end of 3 months. And then apparently there was nothing like a number needed to treat. Their figures are not available. But they said the more number of patients achieved independence compared to the group which did not receive the drug. And then the one more thing is that the mechanism is not thrombolysis in that case,
The mechanism is, they say that it is apoptosis, and the neurons which are at the borderline zone, they recovered, and then the apoptosis is prevented, and then more neurons came into, and then more stem cells or premature cells are brought into role, and then they matured into neurons, and then they continued to innervate and then facilitate the recovery. That is a different mechanism of action altogether. Those are the patients who are not eligible for thrombolysis, but at the same time they have reached the hospital within 24 hours.
I think this is a different scenario. It is not a thrombolysis. That is on after 24 hours. I think we can give that drug. That is as he said, it is an apoptosis which may improve it. Always we evaluate the patient, the improvement of the patient at the end of the 3 months. But here we have the improvement within the just 10 days. All these people who are thrombolized, while on anticoagulant, they walked out of the hospital within 10 days. But what you said that, as Dr. Venkateswarlu said, I think it is an apoptosis that almost a neuronal regeneration which takes place, and to be evaluated after 3 months.
Thank you, sir.
Thank you, sir. Thank you. If no more questions, we'll end the session here. Thank you.
Thank you so much, sir, for the wonderful session. Now let's move into the another topic, that is Symposium Rapid AI, for which I would like to invite Professor Sailesh Gaikwad, sir, Dr. Kairalu Azmi, sir, Dr. Sivasankar Dalai, sir, and Dr. Sarath Kumar, sir, to be as a moderator for this topic. And I would like to call Dr. Uday, sir, to give the inputs on the same.
So I'll have to look at my slide. There is no monitor over here, so I'll have to look at my slides from here. I'll have to look at my slides from here, right? Because there is no monitor in front of me. No, I'm just asking. It's okay. It's fine. It's okay. It's all right, Shiva. Maybe do it for the next talk. Yeah, sure. Okay. Thank you, chairpersons, and welcome all to the Rapid Symposium. Rapid AI is, of course, artificial intelligence, useful in stroke practice, and it's a software. So let's find out. There might be few people here, you already know about it, and few people want to know about it. And so let's find out that what is Rapid AI, and why it caused ripples in the last few years, and why today in stroke practice we should have it. And I'm sorry, but okay, they have paused it because they're moving the motion. So that gives us. I'm good. Thank you. It's okay. It's fine. it live now? Is it live? Okay. So let's start. Thank you, chairpersons. Okay. So we know that mechanical thrombectomy has absolutely caused revolution in the practice of acute stroke therapy. And these are the 3 trials which totally changed the scenario. It happened nearly 10 years ago, 2014 to be precise. 3 trials at one go changed and caused complete paradigm shift in stroke practice. We were, of course, treating acute stroke by intra-arterial therapy many, many years before that, but there were few takers from stroke neurology practice worldwide. But these 3 trials, which were done very well, they caused complete paradigm shift. So let us start from there. Let us not start whether is it indicated, not indicated, which patient. It's there, and for last 10 years, it really has benefited many, many patients. Why? Is because nearly half, that's 40% is a huge number. 40% of all stroke patients are large vessel occlusions. This is actually the gist of the whole talk. 40% is large vessel occlusions. That means these patients will benefit tremendously if mechanically the clot is actually removed. That taken, how can we now make it better, faster, and obviously for our country, cost effective? Coming to the point, when an acute stroke patient comes to the hospital, the burden, I would call it burden because I have been gone through it like the last several decades, the burden of decision making, whether to do the mechanical thrombectomy or not, whether this patient will benefit from mechanical thrombectomy or not, or whether we would continue the conservative management. The burden of decision making almost always lies on one person. And it's a little bit too much to do because, as we know, the outcomes are variable, they can be unpredictable, and sometimes downright bad. So how can we help accurate or nearly accurate decision making? And this is the software which helps us, and it has been helping us for last 5 years, to be precise. Those 3 trials which I mentioned, all of them had Rapid incorporated into them. And so that's how the world knew that you can actually select patients for MT, and there is a software. So we don't have to break our heads every single time. There is a software which will help you do this. It's a radiology software, or it rather helps radiology to select patients. We know that this is, the classical. Why do we do imaging in a stroke? Because, of course, we want to rule out hemorrhage, and then we want to see which of those patients of acute stroke, ischemic stroke, will benefit from mechanical thrombectomy. And so in these recommendations, it is written in that small corner on the top that it is recommended to use an artificial intelligence software to select patients more accurately so that overall the results are better. And this should not be about ego, I know everything and I don't need a software. It's about just help. Something is helping you choose it. And the advantages are, of course, well known. Sometimes the imaging, especially the neuroimaging in MR, especially the perfusion-weighted imaging, it's difficult to understand even for experienced radiologists. So if there's something which looks at everything and gives us the answer before you go to the hospital or before you see the patient, I think it's a tremendous help. I'm going to show you a case now, okay? All of us are learned people here. And so this is our case. This is a very routine practice, whoever practices stroke intervention. Okay, so it didn't. Okay, without the video it is useless because, the video didn't play at all. this patient had a very large infarct. Can you do something about it? No, if you don't have it on the Apple computer over there, it won't play. Okay, too late. We are in stroke practice, so we cannot just wait for something. We have to go and treat the patient. It's all right. You have to take my word that this was a large MCA territory infarction with a massive right MCA diffusion defect already when the patient came. We are in Bombay, the patient came from Nasik. So, the journey takes 5 hours. So they would have gone to the hospital, decided about it, and come here way, way beyond window period with the MR looking like a large infarction. Of course, this at least doesn't have to be a video. You know that it's an MCA, M1 occlusion. M1 occlusion, treatable, large infarction, patient laid in very bad NIH. Yes. So this is the question for all of you. And before I ask the question, I'll let you think about it. Show of hands, please. Who amongst us is actually treating acute stroke? You might be neurologist, you might be intensivist, you might be interventionist. Okay. So a good number, but not a very large number. Fine. I'm not going to ask who is a neurologist and radiologist or intensivist. All of us are actually treating the patients. Who amongst us, 10, 12 patients, who amongst us is calling the shots? Calling the shots means, oh, this patient needs to go to MT directly, or let's give him IV thrombolysis and shift him to cath lab. Calls like this. Who calls the shots? Let me allow you a moment more because I think you're thinking and then, oh, I call the shots. Okay, so nearly 80% of us, small number, but 80% of us have to call the shots. How many of you are, burdened is a very good word, but how many of you are bogged down, that's the right word, bogged down by the decision-making process? We know in our hearts that we need to do this. At the same time, bogged down by expectations on all sides, patient, family, physicians, referring physicians. Cost, significant cost is involved. Uncertainty. And of course, at times, there are complications and bad outcomes. We are not very far away from actually complaining patient families and litigation. So how many of, be honest here, this is not like an international big meeting or something, be honest here, how many of us in our minds have that small little thing, I know that I have to do this, but 1, 2, 3, 4, 5. Okay, so nearly all of us. And we are in this practice, we need to do this. If we can have some help, it won't just help us because we will do our job. Either it will be either thrombolysis or thrombectomy or conservative. We will do our job. But when we are doing it, if there is something like software, which I talked about, which will tell you, do this patient. So at least in our minds, we are clear. In the referring physician, neurologist's mind, we are clear. And in patient family, it is not just our decision. We have experience, but look, we have used the software, which without any additions, it is not going to be influenced by something, tells us that yes, we need to do this. So amongst those 10, 12 people, who has a software, rapid software, in their hospitals? Yeah, you have it. So, okay, so 3 or 4, so less than half, yeah, less than half. Who wants to have it? The other half, no brainer. Who should have it? Okay, so this is about it. It is not about, having an expense or whatever. It is something which is without emotion, will tell you that this is what it is, and you are at home, you are in the cafeteria, or you are driving to the hospital, you'll get the message on your mobile, which is everyone is on the mobile now. You don't have to go to the PACS system to go decide and make a call. Everyone in the hospital who is actually the decision maker, maybe 5 of us, 6 of us, everyone simultaneously get it on the mobile, which we see, and then we can mobilize it faster. So it is about accurate decision making and a faster decision making. I'm sure that as everything in the world, it is not going to be 100%, but it's pretty much close to that. Do I have any more? I think I just finished my slides before I hand you over to the expert. We already know what we did. When we used to appear for exams, and when there was a bouncer X-ray or case which is put by the examiner, the smart people like us, we knew that who is he, what's his specialty, and then start thinking. So it is the same. If I'm going to show you this case, it doesn't mean at all, oh no, we didn't do it, we conserved it. Of course not. We did this, but with this also comes, at least in a number of patients, a wonderful case shown in the previous talk by the same left hemisphere large MCS stroke, thrombolysis, and patient walking. It matters a lot. Only thing, if something can help you, do it. Do lysis, do MT, whatever, but do it. Not doing it is an easier thing to do. Doing it is more difficult. Then maybe it's worth it. It's not only about Rapid, there are many other softwares, AI softwares in stroke. Rapid, obviously, it was the first, so it has the maximum installations and a maximum number of papers, so evidence. So that's why we talk about. And this is the last slide. It's like the positive impact. It is about making a positive impact about a difficult practice. Acute stroke is not like a tumor, not like an aneurysm that you fix it and patient is going to do well. It's not a defined target. It is messy. And so when that happens, if something has a positive impact, at least according to people who practice it, it's a good thing. If it is not so good in some aspects, let's first hear it from the expert. I'm going to call my friend Nishant Aditya, who has been using it for the last three years. Nishant, 3 years. And so he's going to show us the workflow as patient comes in his hospital and how it starts, and of course a few cases. Nishant.
Thank you, sir. Thank you, chairpersons, for introduction. And congrats, Shiva, once more an update. I'm first time here. So, my job is now very easy. I will show few images, few thousand words, and that's it. So, this is how it starts. Is all the more we are doing, the conundrum gets deeper. And ultimate goal now, the present time, is the large core thrombectomy and way out of the window period. And this is how we start. Fluctuating symptom, getting to the bottom, high NHS, and late. So this is ultimate, it's holy grail. If we succeed here, then it is way forward. And that's how it's going to be. As word itself suggests, is artificial. It can't replace the human intelligence. It's already incorporated in the system itself, is artificial intelligence. The more we'll feed it, the more it will start behaving close to our understanding of stroke. And as sir described all these slides, large vessel stroke, a neutral opinion about the penumbra, differences, radiological clinical mismatch, gives us way forward to prognosticate whatever we are doing, how much is going to help. And we are living in golden time for medicine. Never in the history of medicine, number needed to treat for a stroke been 2.7 ever. And in such a short duration, class 1 level A evidence is the golden period. And this is all because whenever we take decision, there will be human variability, as sir was saying. The cost, the relative expectation, referral expectation, and then we are in the dark for the future. And there, the data fed to an artificial intelligence system comes to the fore. Sir has already mentioned these things. This slide is very important for us. Gone are the days when we organized a specialist to start IV thrombolysis. Now, tele-thrombolysis is the practice and is legally possible. So whenever we are going to use this rapid AI or any artificial intelligence system, we have to brush up whole system, especially the EMS services. If EMS service is not active, forget about the intra-arterial thrombectomies done with conjunction with IV thrombolysis. Because once we wait for a specialist to come, dependent upon the speciality, then it is too late. So first system, we have to create an emergency system. Not some great super guy, just a human body who can raise the hackle. And that's enough. Who can send a patient to a CT scan to exclude hemorrhage and ischemia. That's more than enough. Like in trauma, we don't search a orthopedician, trauma patient comes and triage happens automatically. That will be the goal for any stroke-ready hospital. We have to designate EMS guy, give them power to differentiate hemorrhage to ischemia. And that then half job is done. So if you see this, this is my 2 hospital workflow matrix. And as soon as EMS get the call, they take the call after the CT scan. I am fortunate to have the CT scanner in the ground floor nearby the EMS, one scan. So then stroke team is alerted. And then in one hospital I'm having both CT MRI based rapid and one we are having MRI based. Take the call, send your patient where the CT scan is available, do the CT angiography perfusion or MRI perfusion. And more data you feed to the system, better it becomes. It's like a monster. And it learns. And after that, neurology team, whosoever on the call will be intimated along with the INR. Already your data system is in place. And then decision making becomes an objective goal, not a interpersonal variability. Aspect is completely taken care by the rapid. You must have seen the screenshot. At the bottom in yellow line is written, thrombectomy may be indicated. And this is how it comes to your system. First will be aspect, and the bottom will be the eligibility criteria, that is CVF, the flow, and the max. And on the bottom is written, thrombectomy may be indicated depending on the clinical situation. The second 2 lines in violet and green, the large core thrombectomy is going to be our practice, and more and more understanding is a work in progress, and we know that core is not core and penumbra is not completely penumbra, so there is mini penumbra and mini cores. So all these things will change and rapid will catch up. Coming back to our situation, very high score, started with a very low NHS, relatively young patient, way out of the window period of any clinical trial. And this is what it is. If you see the aspect score, 5 years ago, forget about doing anything in this 5 to 6 aspect score. However, these are the very niche population where we have to consider aspect not as a like written in stone. And this is what I'm going to show you. Even if you see the left hemisphere, the parietal lobe is showing already hypodensity. Still, we went ahead because of the youth. He's just 51. And see here, it's classical mismatch. If you see the Tmax 146 and hardly any core. Even I'm talking about the classical core definition. Still, it's 8.9. It's a huge differentiation. It's a huge mismatch. And this is what it is. There's a large dissection from the cervical ICA to the almost to the petrous ICA and M1 occlusion. So the minor stroke must have started with a minor embolic phenomenon and went to the LVO. And this is what it is. You can see the dissection from the classical definition, distal to the bifurcation, stopping at the petrous. Thrombectomy done. The details may be for different talks, but whole IC is reconstructed from neck to the petrous and TK3. Same thing, you have to update your radiology department. This is not hemorrhage, this is just a contrast stagnation. Talking about those things in 2023 still looks very archaic, but this is the reality. You have to train them, you have to keep talking to them. This is not hemorrhage, it's just contrast. And he did well. So if you see the patches, even before this mini core, mini penumbra concept came, we used to see this CT scan earlier, aspect 5, 6, and still over 7 days those islands were gray, not the black. So that means there was surviving tissue in that thing and correlated with clinical recovery. Second case. So rapid AI, if you have read the rapid AI declaration, it says that posterior circulation, their understanding of posterior circulation or pickup is very low, which is a fact because of the bony landmarks and the tract-based deficits like cerebellum infarcts are not considered to be a decision-making component for a posterior circulation stroke. However, the more data is fed, it started understanding the tract also of the pons and brainstem. So this case is about that. Altered sensorium, classical posterior circulation stroke. Here again, aspect is not that much of value, but by default it does that. And you see that Tmax 23, and if you look carefully with Vermis and right cerebral lobe infarct, it has picked the area of Tmax more than 6 even in the pons, which is not the usual case. Because of the posterior circulation stroke, in few of the hospitals they still give tetracycline, which is okay. And you can see the bachelor top. No posterior communicating artery. Stent tuber in place, out, and TK3. Usual CT scan with small contrast stagnation in the pons and recovered completely. And MRS 90 days 0. Thank you very much.
When he was
Thank you
talking,
so much, sir. I would like to.
so when he was talking, we wrote a few questions. They may be a little bit tricky, so I'm sure you can answer. Okay, so we talk about advanced imaging, especially perfusion. So can you tell all of us, like, does it really help in patient selection?
So the idea of perfusion, when perfusion was started, to designate the core and penumbra, still is valid. we should know that how much core we are dealing with. It's paradoxical because nowadays we are doing more and more large core, thrombectomy. So why we need to do perfusion when we have to do everything? Cases like this, dissection, where you don't know whether it is just a flap or large vessel occlusion, or it's just creating hypoperfusion during the flap is up, that duration. That's number one. Number two, when there is very early presentation of stroke and when the cytotoxic edema is still in early phase, you get the negative diffusion and patient is having deficit. At that time, you have to detect the core and penumbra and can be done with the perfusion study. The word perfusion, diffusion, confusion came because of we were not doing that much of stroke. So it used to give lots of data and we were not able to consume that data. So that's why the word confusion. Now we are doing more and more low NHSs, more and more dissection, more and more aspect, this kind of aspect. So there you have to designate the core, classical core with perfusion study. There is no doubt about it. Only you have to decipher that, sit with the data, and that is a habit.
Okay, yeah. Pankaj.
Complete ICA block. Correct.
Arvind, please arrange a mic for sir.
I think we are talking about a situation where you have a complete ICA block, and what is the accuracy of the perfusion data? It is going to show you a very large penumbra, and it's the core. The point is now there are a lot of papers that we have to shift either the Tmax or the arterial input to the normal side, or give the delay, because the delay is what is giving you such a large penumbra.
Correct.
So does this take that into consideration? I mean, does it help in that situation?
So you're talking about a very selected group of patients of ICA occlusion. So there, if you're not putting stress on the competence of circle of Willis, then is ICA occluded, but still is well perfused. So that's how that the data dependency was not one-to-one. That even there is a deficit, you are not one-to-one clinically correlated. However, the perfusion itself in isolation doesn't mean anything, because even in the rapid, there are few patients where the mismatch was 1.5, much below against the thrombectomy. But if you see the radiological mismatch yourself, or the flare diffusion mismatch, or flare clinical mismatch, still those are the candidates for the thrombectomy. So those things will get sorted out, because artificial intelligence is also learning these small pockets of data, which was not available a few years ago when the diffuse came.
Okay, so the second one is something like the case you showed. We have patients with LVO, like Pankaj said, ICA occlusion also, but the NIHS on presentation is low. And that's a huge dilemma, because everything that we do has a small little risk of complications. So how does something, I mean, you do your practice, but does it help in those patients?
So if you have seen the eligibility criteria 1.8 is the mismatch, and only two things are taken, CBF and Tmax. However, if you see the rapid sub data, there is category of 4-second Tmax and Tmax more than 10 seconds. So for very fast progressor, opposite end of low NHS is a very fast progressor, where the Tmax more than 10 is 100 ml, which were contraindicated few years ago. But those suggested the very large core at the start. Opposite spectrum is what sir is describing, the low NHS. So there you have to see the Tmax 4 seconds, how much you are dealing with, and then take the call. Again, low NHS is a work in progress. The trials are not supporting that like class 1, level A evidence, but still is work in progress. And those pockets of data where this Tmax around 4 or 5 is giving it is still good to go for thrombectomy in low HNS score. And there the perfusion will come in terms of not classical Tmax 4, but classic, but 4 to 5. then it will help.
Last two questions, two case scenarios. You showed one posterior circulation stroke, and everyone knows about anterior circulation and diffusion and perfusion and mismatch and rapid AI in that. What about posterior circulation? And the last one is what about distal vessels and nevos?
So posterior circulation, again, because of the bony landmark, small space, lots of activity in the neural tract. It will be little difficult, or it will take time to designate the track injury for the brain stem. I'm reiterating the same thing. The more data will feed to the system, it will get smarter. And the more we'll do under general anesthesia, especially the posterior circulation MRI, it picks the data far better than a moving patient. So that is for posterior circulation. It still is not up to the mark, but it still is a work in progress for them, and they will improve. The MEBOs and negative diffusion will be again same thing. Like when patient is quite early and collaterals are good, you will get a negative diffusion, although patient will have deficit because of the hypoperfusion area. And there you will see these kind of ratios, approximately 1.82, and small area, small core, a small penumbra kind of situation. Again, it's very important to do all those patient perfusion study. No doubt about it.
So, Uday, can I ask one question?
Yeah, sure.
So, Nishant, for posterior circulation stroke, what is your imaging algorithm? Do you rely only on CT, or you always advise MRI in this patient, diffusion and ADC?
Always MRI.
Always MRI. And what is your protocol?
So just for the posterior circulation stroke, just a TOF, diffusion, SW and flare. That is stroke protocol, yeah.
So in my center, we have formulated a protocol. We have 4 sequences: diffusion, ADC, SW, and flare, and a TOF, only for the circle of Willis.
Yeah.
So we try to get the mismatch between the flare and the diffusion. If there is a mismatch, obviously the stroke is less than 4.5 hours, and the patient becomes eligible for IV thrombolysis. That's one thing. But it is more than 4.5 hours, obviously nobody is giving IV TPA. But there is one trial going on at our place, which are trying to extend the time window for IV thrombolysis. And here we have divided the patients into 2 groups, up to 16 hours and from 6 to 24 hours. So here the patients who are found eligible are purely based on the diffusion, ADC, and flare mismatch. And second thing is the ratio between the core and the penumbra. So the cutoff is 1.8. That's the protocol that we are following at our place.
Almost same. Only thing when posterior circulation is showing anything disease in cervical vertebral artery, notope is fine, we directly go for endovascular.
Sometimes, we deal with stroke mimic. So if the patient clinically has come with a stroke, so they run the stroke protocol, and it turns out something else. Yeah. In that situation, the circle of Willis may be normal, and then we missed out on the information of the carotid bifurcation. So those patients then invariably undergo CT angio. That is one drawback of this running a protocol, fixed protocol.
So that's a great one, sir and Nishant. Basically, I just want to share my experience. 15 days back, one of my relatives came with a stroke, which was 48 hours old. And when we did the imaging, we found that the carotid is occluded. It's an occlusion of 48 hours. Patient had a stroke, symptomatic. He's a young man, smoker. Now, we were not able to decide whether we just continue medical management or we intervene in this patient who is already 48 hours old stroke. We did the diffusion, ADC, and the flare, and the mismatch we saw. There was significant, but there is no criteria to tell us whether at 48 hours you can do IC occlusion reopening. And it's my relative, a lot of emotions involved in it. As sir told, that to get over this kind of emotional bias, a software is always a good thing to take you out of a medical legal situation, or to take you as an operator who is not driven by emotion. So everything going towards automation. So good thing Sanjeev and Hani has brought us this beautiful software. We should be using it more often. And to come back to the story, we did a carotid artery revascularization at 48 hours of onset of stroke. Patient did well, and he also has come for follow-up last week. Arvind would remember that case. And he did fantastically well, recovered much from the stroke. So definitely we need some support from AI, and especially we are looking at stroke management. Thank you so much for the inputs.
Okay, so Vimal, the last question. Yeah?
I'm just trying to understand sitting here. I'm not a stroke specialist in any which way. But will this AI will become the third umpire, the final decision maker? Will it stand in medical legal situations? And, there were these small cases. The previous speaker spoke about patient on anticoagulant and now stroke. Now, these categories of patients also will be probably identified, and objective criteria can be given on that. Will it happen in future?
So, right now, rapid is in very tight spot, because the whole idea of rapid was to detection of core and penumbra, which is paradoxical now, because the last trial, last came is you can do with 0 aspect score. However, 3-4 things will come, like you suggested one, like can it give us a guidance for this patient on anticoagulation, can we do thrombectomy or not? Even ahead of that, can it detect the kind of clot, whether it is white clot, red clot or mixed clot, and what proportion? That's number one. Number two, can it detect the ICAD? India, 30 to 35% patient will have ICAD, either it just dural or intracranial. So those things now rapid should start, could have started much earlier. They are already late. And then it will be relevant. Otherwise, it's virtually will be old system of detection of aspect, core detection, hemorrhage exclusion, gone are the days now. So they have to go in this way. Can it designate the patient like we are doing?
Yes.
So that will be the future.
Yeah, looking forward. I hope my institution, obviously Manish must be having it, this. Thank you.
Thank you. Kavya, can we just move ahead?
Okay, thank you, Nishant, and thank you, everyone. We conclude the rapid symposium.
Thank you so much, sir, for your insightful thing. And I would like to request Dr. Uday, sir, Professor Sailesh Gaikwad, sir, Dr. Sarath Kumar, sir, to be as a chairperson for next session as well. And additionally, I would like to request Dr. Vijay, sir, and A. Mohan Rao, sir, to be on the dais.
There is no formal tea break, but tea and coffee can be brought inside with cookies. We will continue with the sessions. Thank you.
Dr. Uday, sir, and Sarath Kumar, sir. I'd like to invite Dr. Vivek Gupta, sir, to speak about endovascular treatment for acute ischemic stroke, mechanical thrombectomy.
Yes. Dr. Vivek will be speaking on endovascular treatment for acute ischemic stroke with a perspective mechanical thrombectomy. He is the Additional Director Interventional Neuroradiologist at Fortis Hospital, Mohali. Welcome, sir.
Can you start the projection, please? Good morning, everyone, and thank you, Siba, for having me here for this meeting. So, in the last session which we just attended, we discussed about how AI is helping us, how Rapid is helping us to make clinical decision making. So now we come to, once we have made the decision, what next? And next is the thrombectomy. So what I'm going to do in next half an hour is to discuss with you or take you why we are doing it, how we are doing it, how we are taking decision, and what we are doing. So starting with the why of mechanical thrombectomy, why is that we are doing it now in 2015 or 2018, we started doing it and not doing it in 2005 or 2008. The thing is that earlier we were thinking that stroke is because of these factors, the triage of patient is because of these time, age, and clot burden. But there is something else also. And that else is what the perfusion imaging has told us. And why we were searching for something else when we were deciding which patient to treat or not was the concept of fast progressors and slow progressors. Because we know, everybody who's working in stroke arena knows that patient coming at 3 hours may also not do well with IV or mechanical thrombectomy, and sometimes, as Nishant showed, patient coming at 36 hours may do very well. So these are the fast progressors and slow progressors. But what is happening inside physiologically? Why they are fast progressors and low progressors? And this is the concept which fundamentally changed how we treat, why we do mechanical thrombectomy now. The concept is of penumbra and collaterals. Earlier, in my place at PGI Chandigarh, we were doing perfusion imaging right from 2005. But as rightly said before, we did not know what to do of that data. We do not know how to apply that data to practical use. So we stopped doing it 5 years later, 6 years later, with a lot of CDs written of CT perfusion. But now with the softwares available, we know how to interpret, how to quantify, and do it in a timely, judicious manner in a matter of minutes. So that is why, that is one thing which led to the usage of mechanical thrombectomy in more and more patients. And second is the advent of faster scanners. Now we are not doing single phase CT angio at all. At most of the centers, we are doing at least 2 phases. At my center, we are doing 2 phases. At most of the centers, we are doing people are doing 2 or 3 phase CT angio. And the concept that this patient may have collateral has changed to that this patient has collateral or does not have collateral. We can see it in black and white whether the collaterals are there or not. And this also has given a lot of confidence that which patient we can go ahead and treat irrespective of number of hours, whether it's 10 hours or at 20 hours. And as rightly pointed, there is a class 1A evidence. So medical legal aspects, to my mind, if we are doing it as per the protocol, they are not there because we are not, this is not a half-baked story. There is a class 1A evidence. But this slide is important because we have to choose our patients judiciously if we are thinking about medical legal aspects, and softwares like AI and many other softwares help us to do that. So coming back to more fundamental questions, we know IV thrombolysis works, so why we started doing it. So when we talk about that, I just refer to this slide in 1995 NINDS trial, after which the TPA started to be used. If you see here, in small vessel, almost 50% of the patient improved, but in large vessel, only 33% of the patients improved. That means 2/3 of the patients were not getting any benefit with thrombolysis. And that is the truth. And in the pooled analysis, almost 50% of the patient did not improve. So that is why the whole struggle of last 20 years has taken place to give something to the patient which is much more reliable, at least to the tune of 70 to 80% outcome, if not more. So now coming to mechanical thrombectomy. So mechanical thrombectomy is nothing but mechanically taking out the clot by whatever means possible. It could be a stent, it could be a It could be a manual mechanical aspiration, or it could be combination of both. Lately in my practice, it is Solumbra. That means using the aspiration catheter as well as thrombectomy device. So the results, there is a debate which is better, whether it's stent retriever alone is better or aspiration is better. But what we are trying to achieve is we are trying to achieve first pass recanalization as early as possible. So if possible, both the techniques in conjunction, to my mind, gives better results than single technique alone if you have the protocols laid out. So, so how do I triage the stroke patients? So I put them into 4 groups: less than 4.5 hours, 4.5 to 6 hours, 6 to 24 hours, which can be combined with wake-up strokes as well. So when a patient comes to the triage, we have an EMS system where the stroke call goes to all the stakeholders, and we do the imaging. If the patient is within 4.5 hours, we don't go for any perfusion imaging. We just do a CT and CT angio vis-a-vis MR or MR angio. And if there is no bleed, we thrombolize the patient there. All the patients get thrombolized if they are in the window period, irrespective of small or large vessel. And then the patient, if there is a large vessel occlusion, is shifted to the cath lab, and we go forward. If the patient comes after 4.5 hours, of course, thrombolysis is out. So if there is a medium to large vessel, we do thrombectomy. If it is a small vessel or very low NHS, then we take individualized decision. However, if the patient comes after 6 hours, till 24 hours, or it is a wake-up stroke, then one kind of if perfusion is always done, whether MR perfusion or CT perfusion. And our CT software give us the core and penumbra right on the console. Of course, we don't get it on our phones or iPads, but those quantitative values, the CT software itself calculates and gives it to us. And based upon that, we individualize the treatment. So this is the imaging protocol, what I do in my practice. And we try to do it as early as possible. Just a patient like this patient, the first run was taken at 6:45, 6:47 crossed, 6:52 stent retriever deployed, first pass 6:52, not so great. Second pass taken, and in half an hour it is done. But it is, of course, I'm showing you one of the easiest and the fastest case. It is not always the story, but in our mind, the time clock is always running once the decision is made. It is not that you take a patient for 3 hours and keep on opening the vessel. That's not done. So it has to be done in a very, very timely, judicious manner. So with this background, let's see a couple of cases just to understand how we take decision making and how we treat mechanical thrombectomy. This is not this is a general meeting, so we will not go into the details how we do each and every step of mechanical thrombectomy, but in general, how we are going about it. So 73 years old male presented at almost 12 hours after stroke. Most of my patients are referred from outside from some other neurologists, so they already get thrombolized before shifting. So he was thrombolized, and he had a lot of background comorbidities, hypertension, CVA, breast patient treated. She came at E3, V1, M5 status. So this is the phase 1. So the ICA, the left ICA is not seen at all, and there are no vessels on the left side. However, if you see the phase 2 of the CT angio, there is a very good collateral. You can see the distal M1 as well as the MCA branches are reformed retrogradely by PLPL collaterals. So these are good cases, and CT perfusion, the multiphasic CT angio really helps us. And this is the data which I'm talking about. The CT scanner itself has this software which gives us the hyperperfusion tissue infarct and the mismatch. So we do it in all the patients who come out after 6 hours. And this was the CT angio, ICO was occluded, collaterals were good, and it was recanalized as by aspiration as well as thrombectomy. So these are not the patients who will go home with zero deficit. They will go home with some deficit. It may be MRS of, they may have 3 months MRS of 2 or 1. It will never be 0. And these are the sequential CTs, starting from left to bottom. The patient sequentially improves when you do thrombectomies in patients like this with very good collaterals. Another patient, 56-year-old male patient, 7 a.m. is the time of ectives, admitted at 12, recanalized at 1. So he was relatively preserved patient. As you can see, the GCS is good. He has aphasia, hemiplegia. You see the diffusion. The impact or the DWI positivity is not so much, but it is extending from the perisylvian cortex. Speech was involved, and he was hemiplegic. See the SWI. SWI helps us sometimes to locate the clot even before we do the DSA or the CT angio. So this is the clot, and as expected, the smaller branch, this branch is occluded right here, and so in this we did plain thrombectomy. The left image is showing the stent reaver in situ. So whenever we are deploying the stent reaver, our aim is to deploy at least 2/3 of it beyond the clot, so that when we are pulling it out, the clot gets integrated and comes out. And this is the branch which we were talking about. This was offloaded and was giving rise to hemiplegia and speech deficit. And this is the follow-up CT after 1 week at the point of discharge. So very small clot, nothing more which formed, and the patient did pretty well. Another patient, 56-year-old, he himself was a doctor running a very heavy OPD. He came, he had a stroke in the afternoon, but he tried multiple things, did not improve, came to us at midnight, and we took the patient. Patient was thrombolized outside. He was not very preserved clinically, and see the occlusion. The reason is because distal M1 was blocked, and see the perfusion scan. There's a lot of hyperperfusion happening, and the core was very less. We took the patient. This is the early frame. This is the delayed frame. See all these MCA branches. These are retrogradely filling. These are not the video still images, so you can't appreciate. You may not be able to appreciate. But all these big branches are retrogradely filling, which again tells us that this patient, even though he has come late, will benefit from the treatment. Again, Solumbra, the aspiration catheter, thrombectomy. These dots are the thrombectomy device, the stent reaver, nicely opened up vessels, and see the follow-up CT. So he does have a large hypodensity, but this hypodensity, as the time goes on, it becomes less and less. And this patient, currently we are, I think, a couple of months after this treatment, and this patient has just mild dysarthria, nothing else. Partial motor aphasia, nothing else. Older patients, sometimes we find it difficult to take a call. As my previous speakers were discussing, there is a emotional thing or there's a medical legal thing whether we should do beyond 80. So this was an 80-year-old patient. He was admitted in CCU for cardiac ailments, and in hospital he had a stroke, which nobody recognized because patient already was very sick and nobody was doing motor exam, and patient was on multiple inotropes. But as and when it was detected, imaging was done, and this was the imaging. The left two images are the diffusion and the right is the flare. There's a gross flare diffusion mismatch. So irrespective of times, we take up these patients even without perfusion imaging when this much amount of mismatch is there. And as expected on diffusion, there is an IC occlusion, very tortuous looking vessel. However, again, because of the age or because of the larger stroke, we cannot deny these patients because these patients are salvageable patients and we have objective evidence for that. So this aspiration catheter, microcatheter crossed, stent reaver deployed, and the vessel, this is a stent reaver with aspiration catheter, again the Solumbra technique. And vessel open. There were few clots here which were thrombolized, which was a small amount of IVA TPA was given, and they were dissolved. And this is the follow-up CT. So again, these are the patients. In previous times, they would have been left, but now we are expanding our definitions of core. I'll come to that, and as Nishant was saying, we are becoming more and more aggressive, and we know that these patients on long term will do better than those patients who are not intervened at all. This was an interesting case, again out of window period stroke. He was having symptoms for almost a week, and then he was driving, and his wife noted that his vehicle is swaying to one side, and he was having stroke while driving the vehicle. He was coming from Punjab to Chandigarh to our city. And when he landed in a secondary hospital, as per the protocol, MRI was done. There were multiple DWI positive lesions, as you can see. DSA was done there, and they detected dissection, but there was no flow limitation. The flow was good, so they decided to preserve this patient. They did not do any other treatment, but patient further deteriorated after 24 hours of admission. And this is when we came to us. the DWI lesions have increased. And when we took it for imaging, this was the status. The ICO had gone. This is the classical dissection. And perfusion shows a lot of hypoperfusion. These are the, as you were asking in the previous, you were asking IC occlusions. So although we don't believe in this large mismatch, but we know that these are salvageable patients because these maps are absolutely normal. There's no difference in the right or left side. So these are salvageable patients, even though they are well beyond window period. So again, in this patient, dissection was there. There was a longish flap, the whole, and the MCA was occluded. The ICA was reconstructed with multiple stents, some balloon mounted and some carotid stents. After reconstruction, the MCA, there was a small clot here, and it was reconstructed. And this is the final outcome. So only infarcts which were positive on DWI, only those were formed, and the rest of the entire area was salvaged. And this is the patient, just see that he is absolutely normal. So if we have judicious use of imaging and using objective criteria, so even large ICA dissections out of window period, mechanical thrombectomy can salvage these patients. Another patient, this is a youngish patient. He again presented to a secondary hospital, then referred to us, a lot of deficits. And this was the CT when he came to us, very largish looking left MCA infarct. But again, CT perfusion, there's a lot of mismatch. And these are the values which the software gave us, 41 cc, 20 cc of infarct, 40 cc of penumbra. So there's almost 50% mismatch. And CT angio again show a similar dissection patient with M2 occlusion. So these tandem strokes we see it very frequently because they get time to reach to a tertiary care center. Again, similar picture as in the last patient. The ICA is completely cut off. Cross-check the MCA as well. And again, reconstructed the ICA and then opened the MCA with stent reaver. Here only stent reaver was used, so Lumbra was not used. And we routinely see clots like this entangled in the stent reavers and when they come out. And again, you see the amount of limitation of the deficit which we could achieve with mechanical thrombectomy. And this is the patient. As I told you, he's a youngish patient, and he's able to do his everything. Again, he has just very small component of motor aphasia, but nothing more than that. So, I'll skip these slides. So, but is it always like this? Not always. See this patient, this is a 68-year-old patient, came well within window period. Stroke at 2 a.m. at night, detected, admitted at 5 a.m. and thrombolized, and then we did thrombectomy as well. These are diffusion, these are the flare. Again, classical mismatch, well within window period, less than 6 hours. So ideal candidate for both IV thrombolysis and thrombectomy. See the CT angio, left side is the phase 1, right side is the phase 2. Just concentrate on the ICA. On these MIP images, there is no ICA, no MCA, no vessels in the left hemisphere. In these base images, you see that ICA is missing on the phase 1, but on phase 2, ICA is filling. However, it gets attenuated as it goes up. On the first phase, you will say the ICA is completely gone, but it is there. Small, but very weak ICA, very poor flow, and hardly any MCA, hardly any collaterals. So although this patient is well within window period, and then here is the point when patients, when you have to rationalize in your mind that do we go ahead and do it, or we leave this patient even though he is in 4 hours or 5 hours window period. We did take the decision to do it. These are the images. Excellent reperfusion, TICI 3, well with straightforward procedure, but see the outcome. So these are the patients which we want to avoid even though within window period. So no emotional quotient, whether it's of 3 hours, 4 hours. If the imaging is telling you that this patient is going to have a reperfusion hemorrhage, it is better to avoid mechanical thrombectomy rather than to do a mechanical thrombectomy, because we know what's the outcome is. The patient will have hemorrhage, may have hemorrhage, may have midline shift, and this patient will go outwards. So what we do now is that when the patient comes even at 3 hours, but if we have pictures like this, complete occlusions, like this, and there is no mismatch. We don't even offer mechanical thrombectomy to the patient because we have to remember that those are lay persons. Whatever we tell them, if they are good patient attendants, they will believe you. So we have to guide them towards the right decision, whatever there is there in our mind. So in patients like this, even at 3 years, there's no point of doing mechanical thrombectomy. So we did not do it, we stopped. We did an early hemicranotomy, which is a protocol at our place, and we salvaged the patient. So at least we did not do any unnecessary procedure. We cut down the cost, we cut down our losses, and we gave whatever best the patient could have got. So this is how we treat stroke with mechanical thrombectomy. We know it is a very robust technique. There are multiple ways to do it. Every operator develops his own protocol. But what is there in the future? Again, when we were talking about rapid AI in the last symposium, we were talking whether perfusion is really gonna required or not. So to my mind, these two things are gonna change the how we treat stroke in coming very early in coming 2 years or 3 years. Already it is happening in many countries. So one is the superbore catheters, and second is the large core thrombectomies. So now the concept of 70 mils of core, we should not do thrombectomy after that, or any arbitrary value is going out of the window, because if you see these all trials happen in the last 2 years at different places, the numbers are not so great. They're nearly 1,200, 1,300 patients, but all of them have been done in low aspect, 3 to 5 aspect. In one study was 2 to 5 aspect. That means patient had a very large core, poor grade patients, and they have shown consistently that this is what they have shown. Good outcome means MRS of 0 to 3, and excellent is MRS of 0 to 2. So if you see the benefit shift, majority of these patients have significantly done better at 3 months vis-a-vis medical management patient. That essentially says, although we are early in generalizing the result, but which essentially says that even if the core is large, if the patient is coming within 24 hours, all these are within 24 hours, we should do thrombectomies even though there is a large infarct formed. And if we are doing it, the chances of patient being mobile, we are comparing MRS of 5 vis-a-vis MRS of 0 to 3. So chances of patient getting 0 to 3 are 50% more than those patients who are being medically managed. So this is very exciting. If this becomes a norm, there's another trial whose results are waited. If this is accepted world over, and if the guidelines change, then probably we'll not have to do any fancy imaging. We can just do a conventional imaging, CT angio, CT, or MRI angio, and take the patients from that. So this is first thing which is going to change, which is going to change how we practice stroke, or how we do mechanical thrombectomy. Second is the development of large bore or super bore catheters. Right now we are using catheters which are 070 or 072 inches. But we know MCA in majority of the patient, even in our Indian population, is 2 to 2.5 millimeter, which is somewhere between 0.7 to 0.9, 0.07 to 0.09 inches. So development of 0.88 inches catheter is changing. What it is changing, it is helping us to recanalize early, recanalize without clot fragmentation, and more patients are getting recanalized in a timely fashion. How it does is we don't have access to that, so personally we don't know, but this is something which is there out in the market, in the US at least. So instead of using guide wire, they use a guiding catheter, a smaller catheter which fits into the large bore catheters, which facilitates the deployment of large bore catheter in the MCA. So these are 0.88 catheters, and they ingest the clot in toto. And the initial results, the papers which have come in last 2 years, are very encouraging. So large core, empties in large core, and development of large core, super bore catheters are probably two things which are going to change the landscape of how we are doing mechanical thrombectomies. We'll be doing mechanical thrombectomies in the future. So this was my take on mechanical thrombectomy. So we know what has changed in last 10 years is we can effectively see the collaterals, we can effectively quantify the damage. We have tools to take out the clot in a timely fashion, And as I showed, as we are becoming more and more aggressive, it probably will go the cardiology way, that if the vessel is blocked, you open it, although I'm generalizing here, but it might go that way. If it is within 24 hours, or if the imaging says within 48 hours, 36 hours, you open it. Thank you so much.
Thank you, Vivek. Wonderful and very detailed as well. Is there any comment or question from the floor? Swati?
According to you, when you do mechanical thrombectomy, do you have in your imaging or presentation or for that rapid AI or somewhere where we can predict which patient is going to have reperfusion bleed after mechanical thrombectomy?
See, prediction, if you talk about data, if the aspect is less than 6 or less than 5, the chances of having reperfusion bleed is more. But if you say objectively that can I predict in every patient, no, I cannot. It may happen. The only thing which we are cognizant is that once the vessel opens right on the table, the anesthetic brings down the blood pressure. So that is the only thing which is in our control. But we cannot predict it in 100% of the patients. We can only guesstimate. It is like estimate versus guess based upon the imaging.
You think rapid AI will help in any way in this?
I think Vivek answered the question. Right now we cannot predict. But to continue with the corollary to what Swati said, is that you said that if dominant hemisphere and no collaterals, you would rather not do. That's what you said, right? I mean, you know beforehand that maybe it's possible to open the artery, especially IC occlusion, and you said a case, you showed a case, as you rightly said. Do you go up to doing a DSA, or you can take that call before? Because once you do a DSA, you're sucked into opening the artery.
So you have asked something which we are still debating how to go about it, because it is very difficult to say no to MT within window period, but we know this patient is not going to do well. So if possible, we don't do DSA, because once patient is in the cath lab, you have a close.
Your talk was fantastic. I think you covered practically every aspect of the acute stroke interventions. But I would like to make one specific comment about the type of the lesion that we see, the T-junction. This T-junction block has never been studied in any trial. What does it mean? That the clot is extending from the terminal ICA beyond the posterior communicating artery, and the thrombus is extending into the A1 and the A1. So what does this thrombus does? It prevents the development of the collaterals. You cannot have collaterals from the ophthalmic, you cannot have collaterals from the PCOM, you cannot have collaterals through the ACOM. So the patient is bound to have a massive hemispheric infarct. And these are the subsets of patients. They should be aggressively treated by mechanical thrombectomy if the brain is not infarcted. So we go aggressively after this subset of patients. Yes, you may end up getting this decompressive craniectomy done later on, I think, but we should be very aggressive about this. So any experience on this, Vivek, on your side?
Never seen such kind of clot. But I agree to your point.
Okay, Nishant, go ahead.
Yeah, thank you, Vivek. Beautiful images. Your second last patient was good CT scan. Why you said it's bad outcome? The large hyperdensity, left dominant hemisphere.
The one which we intervened, or we did not intervene?
You intervened.
Yeah.
Looking good.
No, CT was very good, but there was no collateral. Like it was zero collateral. Even in second phase, there was nothing there.
No. Where you intervened, you said we shouldn't have done. Where the hyperdense, everything is hyperdense.
Can you just put on the PPT back?
Yeah.
This one?
Your second last patient,
zero collateral. So what is your question, sorry?
No, means those CT scans are good. They're not bad outcome. Just this one.
This one, no?
No, before that.
This one?
Yeah, this one.
Yeah.
It's reasonably good.
The post-op CT?
Yeah. This CT scan is good.
No, the first one is okay. This one, the on the right side.
It's still okay.
See, the outcome here, when we are doing it within window period, we are at least hoping.
Your experience is both private sector is even better than even. But still, these are the patients coming months, because all those things, as you said, there are fast progresses, but they are coming to us. We have to do with due risk of hemorrhagic conversion and decompression.
Very rightly said. So basically what happens, understanding of these images helps us to counsel the patient. Because we do tell them that, suppose if you are giving a risk of reperfusion hemorrhage of 10%, you jack it to 40% or 50%, that we are going to open the vessel, there's 50-50 chance, if you agree with us, we'll go ahead and do it. He may be mobile, right? So I agree with you and Dr. Uday that very difficult to say no to a MT in a window period, but we know that this patient may not do well, so probably if the patients are on board with you, it's safer to do it. If they're not on board with you, they're looking for value for money that we have spent, say, X amount of lakhs, and patients should walk home, then these patients are not to be touched. At least I don't do it.
Thank you.
Okay, so the last question is for me. You said that the 88 and 92 is the future, but we spoke about this yesterday, Nishant and I. 20 to 30% of our patients have ICAD or carotid artery disease, and you travel everywhere. So, you see cases which are done in the Western world, in Europe and in US. The number of ICADs is low, and so these very large bore catheters work tremendously well there. But, I'm not too sure, as Nishant was also having his doubts.
I agree, because our subset of Southeast Asian patients, they are different. We know that, and since the time we are doing even stent retrievers, we know that we get those plaques which are avulsed, bit of plaques which comes. So that is an issue, but to my mind, these large bore catheters will definitely help us for ICAs or proximal M1 or T occlusion, because ICAD predominantly is mid M1 or distal M1. Proximal M1, ICAD, at least in my experience, are very less. So, or it is in the proximal ICAs. So once you are in the ICA and there's a large clot burden, instead of fragmenting and the clot going in A1s and M1s, so these catheters might be much more helpful in taking out those kind of clots. For ICAD, probably we'll have to find a better way to say which patient has underlying ICAD. Right now we don't.
And we as a community, you're right, we as a community, we learn from our teachers and we learn from operators who have 10 times the experience as ours. But this is a subset, it's our disease, diabetic capital of the world and blah, blah. It's our disease. So I think, we need to have a solution for our set of patients. Try it by all means, but I think this is the direction that we must think about.
And just to extend the same discussion, as you said, the future is the large bore and large core. So same catheter 72, 68 availability. Now the cyclical aspiration will be another aspect of aspiration, because majority of time we lose the clot because there is no suction force once the clot is engaged. That's number one. And number two, now for the large clot burden, ICA top, T, where the clot burden is really large and where we are thinking for large core, the trial has come for the by-2 stent retriever. So that will be another aspect to look at it. And our disease is not just the supraclinoid intracranial, cavernous, petrous, all those will hamper with changing the superbore catheter like millipede and all this. Although it's always good to have more arms.
But again, for ICA, to my mind, for ICA superbore is not that much of a problem, because there's still ICAs are much bigger. These are like 4 millimeter on an average. So if you are putting a 2.2 millimeter catheter there, so it should be okay. So what Dr. Uday is saying, that concern is very real if you are putting a 088 catheter in M1 and there's hardly any space left. So what will happen to the plaque if it is there? So that remains to be seen.
Thank you.
Okay, thank you very much. And Vivek, thank you for a good talk and good discussion. So let's have Pankaj for his presentation on mobile stroke unit. Pankaj is from Kowai Medical Center, and a few years ago they started the mobile stroke unit, and let's hear from him about his experience.
So this whole morning we've had 4 sessions, and we're talking of once the patient comes to the hospital and what we do after that. And okay. So but now I am going to take you to an area where a lot of people have been thinking about it since the early 2000s, or maybe even before that, as how can we change metrics, dynamics of the situation before the patient comes to the hospital. Because we all agree that there's something known as the golden hour thrombolysis, and that has shown to have the maximum benefit to any patient. So when you look at the golden hour, that is the first 60 minutes of a stroke, then you're talking of this 3.5 to 4.5 and 6, 16 and 24 hours sort of puts everything into perspective. So that is where this mobile stroke unit comes in. And ideally, I think Matthew would have loved to speak about this, but for some unforeseen circumstances, he is not here. Because this was his pet baby, at least in India, when it started. So we all are aware now, since the first sessions in the morning, that this is a very debilitating and morbid disease, and that time to reperfusion is the most crucial factor in the outcomes which we see. But the point remains that since its introduction in the 2008 in Germany, it has been proven that if you can change what happens before the patient comes to the hospital, you can make a huge difference in the outcomes. So that is why we talk about mobile stroke units. And this was the paper which actually started evaluation of cost benefit analysis and cost consequences of time delays, which made Dr. Fassbender start thinking, because it is very clear. See, we talk to patients about 19 million neurons every minute and 32,000 every second. I don't think anybody can get it, but if you can put this point across to them, that every 10 minutes of earlier treatment will save you 39 days of disability-free life, I think that is something putting it more into perspective. So this was the paper which made this person start thinking. Now let us look at some other statistics as to how we are failing in that first 60 minutes, which put things into really good perspective. So despite every event, this is with the Get With The Guidelines registry. It's a very large registry. It's not just a registry, it also guides people onto how to manage their stroke programs, how to improve their stroke programs. This is mainly in the US. And it also certifies centers to be stroke units and further. So the interesting part was, though 50 to 60% of acute ischemic stroke patients arrive in the hospital in time, only 10.6% of those patients get it within the first 90 minutes. We are still 30 minutes late here. And out of that, if you look, only 1.4% patients have the golden hour thrombolysis. That is in the first 60 minutes. So if we can meet this time metric, then maybe we can make a bigger difference to the patients who come to our hospitals or who depend on us to treat them. And the numbers needed to treat, if you can see how they increase from every 1.5 hour increment, you can see the number needed to, is this the pointer? Yeah. The number needed to treat them is 4.5, 9 and 14. That's a huge difference which comes with over just 2-3 hours. So we can imagine the impact of this problem and why we needed to see this better. This was the gentleman who actually started the whole thing. He wrote a letter to the editor after going through all the literature and pretty concerned. This is from Germany, and he wrote a letter in which he wrote that I propose a hypothetical mobile unit, which would be a vehicle, he talked about Mercedes, which will have a CT scan, an energy unit, a coolant non-dependent CT scan which can help us triage a patient. So with this background and with these thoughts, he also incorporated a small laboratory in that, which would help us find out about all the factors which we need to find out before we decide on a thrombolysis. So that point of care laboratory will do a blood sugar, it will do a coagulation parameters, it will tell you platelet count. So once you have all this at your disposal, you can take a decision and thrombolyze the patient in the ambulance itself. Now when they started, the CTs which they had were 8 mm, which could not do a perfusion. Now I believe we have 16 slice CTs which can do a pretty decent CT angio and CT perfusion to fit in an ambulance. So this was the first prototype MSU which was made at the University of Saarland in Hamburg, and that's Dr. Fassbender with you. And this was the start, and they made the first single center trial after that in where they put their results out. So what does this MSU have or contain? It got a computed tomography, point of care laboratory, fully equipped intensive care, because you will obviously be picking up patients who are not stroke, so maybe you can pick them up. A specialized stroke team obviously has to be there. They were managing with stroke nurses. In our hospital, I think Renoy is sitting there. Renoy was the one who first went with the ambulance. So he must be having a story to tell. It's not very easy to go and take all these decisions. And then, of course, all the appropriate tools and medications and a telemedicine setup if you don't have a person who can actually interpret the scans. So the MSU will reach the patient, meet the EMU, which is bringing the patient. Now, abroad, most of the times they have, on the studies which you look at, they tend to take these ambulances right to the patient, to the house. But that is not possible in our country, because mostly you will have to meet them halfway through or at a designated spot. I'll tell you about that later. So it evaluates the patient, it runs the tests, all the point of care laboratory tests, it does a CT triage. Now the advantage of this is not only administering the thrombolytics, it is also to triage the patient after that to the correct hospital. Now supposing you have given a thrombolysis, your CT angio has shown you that there is a large vessel block, then you have to send them to a comprehensive stroke unit. So they found an advantage even in triaging and of course in prognosticating these patients. So this was the first trial which these people did. After all the exclusions, they had 53 and 47 patients which were divided into two groups, one which went with the MSU pathway and the one which went with the optimized conventional pathway, that is the EMU coming to the hospital. Now the model which they had was, they had 1 week on, 1 week off to sort of homogenize the population they're picking up, because they hypothesized that over a period of a week, you will have more or less the same type of population which presents to the hospital like the next week. Not absolutely logical thinking, but see what they found. If you find out that most of the patients are pretty well matched in age, gender, even hypertension, diabetes, pretty close. So they got a pretty decent comparable cohort of patients on both sides. So that added a lot of strength to this study, and in every aspect, actually. And what they really found was that 0 to 60, this is the time metric we are looking for. That is why the mobile stroke unit concept came. They found a huge 4% to 57% gain, which they had in that 0 to 60 thrombolysis. And what would the results be? And they found that in every time metric that they had imagined, they did quite well and gained significant times. So this was alarm to therapy, that is since the first phone call came to therapy, that was the large time metric, having so many other time metrics. They gained nearly half the time, which was pretty significant. Similarly, the secondary endpoints of the study, symptom onset to therapy decision, this will be much earlier than this time. That also they gained time. The number of patients with intravenous thrombolysis went up. The alarm to intervention. So it is basically common sense. It's not a very great thing that if you get the patient early, you will also start treating the patient early, thereby increasing the chances of your good MRS at 3rd month. So the symptom to onset treatment time, the alarm to therapy decision times became the most important parameters in the study. So this good work was actually carried on.
Now the point remains that everything which you will find, detect in your acute care, you have to see what are the long-term outcomes of this. That is what gives the real weightage to whether the effort and the money being put in. Because by no means of imagination is a mobile stroke unit a cheap thing, as we realized to our detriment actually. And so the long-term outcomes, the first study which actually studied long-term outcomes was the BEST MSU study, which is done in the US. And they enrolled 1,515 patients. And they had a decent group on both sides, 438, 617. The primary endpoint here was the MRS at 90 days. And the secondary endpoints were MRS at 90 for all patients. Now, what are these two sets of patients? One is that only patients who will receive the TPA, RTPA, irrespective, who are eligible, but who may or may not receive it. So they're looking at the whole cohort there. Secondary endpoint is MRS at 90 for those people, only those who got the TPA. And then another parametric metric was a 30% reduction of NIHSS in 24 hours. That's a really great one. And a time metric related to treatment times, what we saw, the treatment, alarm to treat, lysis, alarm to treatment, and all of those. So you find that they have actually found that you will have a 30%, in the primary endpoint, there was less disability at the end of 90 days in all patients who were attended with the MSU as compared to the EMS group or the conventional pathway. And the primary, the first secondary endpoint, that is 30% reduction, also occurred in 75% of the patients compared to 67. Now this may not look like a very large number, but of 1,500, this is a direction to move in and improve what study design which they had. The secondary endpoints, what we were discussing, all showed a significant improvement in the mobile stroke unit arm compared to the conventional arm. So by now this has been easily proven, and the next study, which was the Be Proud study, actually this was slightly before, this was done in Berlin, and they also opined absolutely the same. They had a similar kind of a patient selection. They had a very beautifully made cohort on each side, matched in every way. And the MSU group again had a significantly less disability than the EMS group. So there's no more thinking about this, and after that these people have made a huge push for mobile stroke unit based this thing. It is mainly seen in Europe and in USA. There were some units in Thailand, and then I think we jumped in from India, 2 places had it. So the impact was very simple. The impact was, if you look at the initial trials, the NINS, TPA, and the DAWN trials, you can see the numbers needed to treat. The MSU have a compelling NNT of 9.4 and 8.6 according to these 2 studies. So they are matching, and they are proving again and again that if you can invest. Now, they have done a lot of cost-benefit analysis to justify these stroke units and how, because in US, the way they compute the cost effectiveness, even in your working hours, the number of man-loss hours, economy parameters and all that, which we just cannot do in India. So for every 100 patients treated with an MSU, 27 will have less disability and 11 more will be disability-free. So that was the final conclusion they came to. So this is the world map. As of when this was written, that is nearly some 4-5 years back, and you can see that the US has got a high density, Europe has got a few, and in India, we have, Coimbatore was the first, and then Tejpur model, which happened just after us, but they benefited something from the experience. So let us see what really happens in these 2 areas. So now, after seeing that the MSU, the West has proven very well, that's good, let's see how the India experience was. We'll start with the KMCH experience. We were the first in India to launch it, and it was after a lot of passionate pitching of this model to the chairman, that's our chairman, and that's Matthew, and finally approved, okay, let's go for this, because this is not a cheap project. So this was the first prototype which we made in March 2017, which was with the Tata chassis. Now, as we worked, And we realized we developed into a lot of problems. As we can see, obviously, this is a very low vehicle. And what we found that the chassis of the vehicle could not take the weight after we met with the government regulations of a 2 mm lead shielding all across. Even though we had pointed out that most of these CTs are internally shielded also, this 2 mm thing we could not come out of. So this machine became really heavy, and our bad Indian roads and a very high clearance which was needed, negated. And the first 2 trial runs really gave us a lot of trouble with, speed. We don't have any standards of speed breakers also in India. Some are high, some are low. So it was really a poor experience. And I remember all of us sitting and wondering where to now. We spent so many crores. This was managed by Schiller from us from Delhi, the building of this bus. Then we said, okay. The chairman said, never mind, we'll do this again. So we started all over again. Now that, seriously, I'm so thankful to a person who can spend money in that manner. So this time we used a Mercedes chassis, and everything was planned. We decided to put the electrical and the generators, everything in a separate compartment. The CT here, we increased the ground clearance. We put an air suspension. We got stability bars installed in the vehicle to fix on the ground when you're doing a CT. Because one thing about the CT is you need an absolute level ground for it to work properly. Because it's a very lightweight CT, there's not too much of scaffolding it has inside the gantry. It's a very tiny one. So after doing all that, we started, the other changes we made was, the first body was made out of stainless steel and iron and everything, like they do for the regular buses and lorries. That was really too heavy. So we changed the whole thing to pure stainless steel. That was one change we made. And we added a lift to this part. You'll see that next. So this had everything in it. This had the point of care laboratory, it had the ICU units and everything, and it had our small unit where we interpret the CTs too. And this lift was installed to take the patient up, because we had made the ground clearance really high, which was not there in any other thing. So all the emergency trolleys which are there, they cannot push a patient into the ambulance. So we made this lift. I don't know if this will work. As usual, it doesn't. Yeah, so this lift will carry the stretcher onto the thing and it will go in. So these were the changes we made, and we ran this machine. Oh, this is working. So this was an innovation nobody else had, and this people were pretty impressed when this happened. So we thought, okay, we got everything in place and we shall go, and we finally realized one thing, that you can make a bus, you can push in press releases, you can get phone numbers and everything, but the people will just not lose it. Part of the thing we feel is the distrust naturally which comes to a private hospital, that these guys are trying to make money. They're doing something which nobody else is doing. This is just for money. So we hardly got any calls. It was a very frustrating period. Over a period of 1.5 years, maybe 8-9 months, these are the calls we got 14. And then to our dismay, we found, because see, we have to keep explaining to the hospital what are we generating out of this, no? We were picking up mainly bleeds. See, bleed. And so that was another thing which was very distressing. Wish we were in the tranexamic acid trial. We could have at least put all these patients in that trial when we picked them up. But anyway, it was quite distressing, and so we managed to only get 3, we managed to get just 3 patients for thrombolysis, and 1 patient out of them was converted to empty. So there were a lot of learning points in this. We realized that somehow the thing of sending an ambulance to the house doesn't work. So a lot of the first few times they realized you'll get a phone call, but as you go, the roads are too narrow, because this was a huge structure. This is the size of a bus. It just wouldn't go. So I don't know how it was running in Tejpur and in Assam, but they managed to do that in certain areas. So we realized the best model is the rendezvous method, wherein you share live locations, ask them to start from that side, and we will start from this side, meet somewhere, invariably on a petrol bunk, and transfer the patient, do the CT, do the test, and thrombolyze them if you have a patient with thrombolysis, or triage them, however you want to triage them. So that was a big lesson we learned in this. And this is what our very, very small numbers showed us. We got 3 patients for TPA, 3 went for conservative, and this was what we generally picked up. But overall, it was a very interesting experience. So out of that, this was pre-MSU what we had. We found that we are able to somehow get at least some parameters which you see on this. We were able to beat them with this because we brought down our overall treatment times by nearly 60 minutes. So that is something we noticed, that if this is executed well, and we manage to reach the right patients, we manage to have the right publicity, this can be a very good model for India. But to run it as a sole private hospital is going to be a big problem because of the element of trust which is missing. So, see, this is what we finally managed to achieve, the final metric. But with 14 patients, out of which only 3 we got, this doesn't mean anything. So, sadly speaking, after that, the numbers kept decreasing, and after that, we actually abandoned this project, and the stroke ambulance never went out for the last few years. What a waste of good money. And now we have taken out that CT and put it in our ICU, so those people are using it with a little bit of refurbishment. Now, but after this experience, Dr. Jairaj Pandian, the president-elect this year of the World Stroke Organization, a very committed stroke person, neurologist, director of CMC Ludhiana, he had talked to Dr. Matthew, and they came up with the fact that he said, maybe we can make it work. But the things which went well for him, one was the area was very poorly served. And second thing, he got some state government support and ICMR support. That was the changing factor here. So let's see how they did. So what they could do was, it was funded by the ICMR, the TPA was free, and the cost of the treatment was also borne. What this doesn't have, the hospitals did not have a comprehensive stroke unit. So this could study only thrombolysis. So that was sort of a disappointing part of that trial, but they managed to get very decent numbers. These are the 3 stroke MSU units. They started with just 16, then they've gone up to 57 and 37. And this is only over 6-7 months, 10 months. And they have an unusually large number of bleeds which they pick up, but that is very common in the Northeast for some reason. They have a lot more intracranial bleeds than they have strokes. And they picked up so many. What he wrote to us actually was that though they gave thrombolysis only for 2 patients in the MSU, they could make a difference by bringing the patients in early and give, because a lot of times they could not bring down the BP or the sugars while traveling in the thing, so they could not give the lysis. But they could bring them back and put them into lysis, and they did quite well after that. But the point here remains is, they faced a lot of administrative issues, collaboration with 108. These are the issues the West does not face. And that is why those trials went so successfully, and even I think the Tejpur and the other sectors have suffered. So what we have realized that our problems mainly were with one, that's a very narrow table or the trolley which you use. So very obese patients are going to be a problem. And this is reiterated even by Dr. Jairaj when we talked to him. And he had this problem very severely. The hilly roads negotiating, so they had to wait for the patient to come. And oftentimes, the patient would come down from the hills on a chair carried by 4 people and stuff like that. So you can imagine what they went through. And unstable patient stabilizing became an issue sometimes. And the initial CTs were very time consuming, but now we have much better small CTs which are equipped. And of course, no CT perfusion, which is possible now in the new 16 slice ones, and internet connectivity. We had the problem sometimes, but I think they had it much more when they ran it in the hills in Assam. So the challenges. The first challenge would be that we do not have one sort of red number. How much ever we requested the Coimbatore administration to give us a 999, 888 or something, this was the number we got, which is very difficult to remember. And second thing is, what we realized was the cost. As we were a private hospital, nearly everything was paid for. Though we kept the ambulance costs very low, you have to charge for the imaging. Thrombolysis is 30 to 50,000. Makes it easier with Tenet to place than with thing, because at least you can give it in one shot. You're not starting a bolus and all that. and mechanical thrombectomy after that, if needed, is costlier. So imagine you have a situation where you are pulling in a guy out of his hut, and then you tell him 4.5 lakhs. So this doesn't really work in our scenario. And this was a problem we found quite often. So these were major issues which we could not overcome, and that led in a large way for us to not have a successful MSU program. And second thing is, just like you have these kind of things for hypertension, diabetes, tuberculosis, we need a national policy on stroke prevention, and we need a full action plan. We need centers, we need insurance. The patient cannot be taking a decision, especially the poor patients, on how much money they can spend at that time when they need to get treatment. So if this is worked and supported by the government, I think this has got a future. And the future in India is on a rendezvous where the patient starts from the house and comes in. We can actually save a lot of patients, cross disability and other things, if we can manage with these helps. Now, if you look at the US map, just as to show you, these are all nodal centers and coordinating centers. And then so many minor centers which are not there on this map. And that is what makes the whole thing succeed. Incidentally, interestingly, Dr. Fassbender's program closed down quite some time back, because in their country, they started using helicopters for triage. So taking the ambulance, doing the CT, bringing back, giving thrombolysis was negated by a helicopter ride for 10-15 minutes. So he lost his program, but he showed the world what is possible. And if you can tailor it to your population needs and density, because obviously the units are going to be successful where there's a good population density, where you can cover a short area, less time, but you can serve a large number of people. Because if your density is low, cost effectively, if you look, you'll have to cover larger areas to get you patients. And India should not be a problem because our density is like crazy. Yeah? So in conclusion, I'd just like to say that this has got a future. It's a very excellent model with saving time metrics. It's very safe and long-term medical benefits are there. This has really got something, but this is all Western literature. And it is cost-effective according to their studies. But one thing we found, and they found, and I think that works for everybody, is this thing succeeded in creating a lot of stroke awareness. Dr. Jairaj Pandian, when personally he spoke to us about this, he mentioned the same thing. He said the stroke awareness has gone up so much after we started running this, that we were thinking, I told Matthew, we should have kept that ambulance even with no CT in it. Morning, evening, just run it down the town with the siren and at least you'll create some stroke awareness. But the chairman was not for it. We could have done something like that. Yeah. So, and there's a lot more research going on how you can use this, because you tend to pick up so many bleeds. So there are ongoing studies which are running for tranexamic acid trials, which in Tejpur they have enrolled. They've had 3 patients in that, and also factor 7A. And also in hyperacute stage, bringing down the BP, how it affects and neuroprotective agents. That's the latest work which is going on in MSU units in, I think, the US. Because they believe that when you start the neuroprotectives late, by the time the patient comes 3-4 hours later, you already missed the molecular window. And the earlier you start neuroprotective agents, it's going to help. So that is one of the areas this research is going. And in India, of course, in conclusion, we can only work if the government supports, funds, and pushes us and creates an infrastructure where you have a nodal center and cooperative areas. I hope I've done justice to this topic. Thank you so much. I'll take some questions.
Thank you, sir. That was a wonderful insight regarding the MSU and its specific challenges and the possible solutions which you offered. If you have any questions specific to MSU or anything, we can discuss briefly. Audience? Yes, sir.
As usual, a very nice lecture and a good insight to the subject. And probably one of the most important things required, before patient comes in, if you can start looking at therapy and try the patient. In your condition, I think one important thing which missed out, cost was also not so absurdly high as I see it. I mean, you guys kept it quite logical.
No, we kept it very low.
Yeah, they were quite okay. The failure, as you said, reaching all the way up to the level of the patient where there are all small gullies and everywhere you have to reach was a challenge. I think more important was the awareness, probably a marketing of the whole project. When you said you just wanted the bus to go up and down, was your marketing strategy, was not a bad idea. But I think where marketing probably was the miss, where probably you could have.
I think you were
Did
there
you
or-
employ any marketing agencies?
When we launched it, launched it during a conference, ST, and I think some of you were there. And after that, there was a lot of paper coverage, a lot of talks and everything we did. But somehow it just didn't take off. And I think because it was an entirely paid experience. See, when you, NABH comes in a large way in this, when you take a patient, you have to get signed estimate and stuff like that, even if you come to the hospital. It makes them hesitant, I feel. At the same time, if it is run by the government, there is a lot more trust. Another thing we found which we just could not achieve, was making a 108 ambulance meet us at a point. They said, I'm sorry, we can't do it to you. You are a private hospital. We'll take it only to the general hospital. General hospital doesn't give TPA. General hospital doesn't have mechanical thrombectomy. So what are they taking these patients there for? We discussed this with the administration and nobody just saw the point. So we are lacking there. And I think our experience was purely because of private funded thing, and even though we kept it cheap, even though we made it cheap, it was pretty expensive because tenecteplase costs money, mechanical thrombectomy costs money.
At the end of it, as you said, probably yes, government, and probably the insurance company may have to come in.
We need some sort of a national
Because abroad,
insurance.
maybe it's working on the insurance company probably that it's running in US and other places
Yes,
where
successful
it's running.
because of that.
Yeah. Thank you.
If I can suggest one thing, like how we popularize the cardiac ambulance for the patient on CPR or who is going arrest in the home. So if we can have some model, like propose this kind of model in a public-private partnership, like stroke ambulance and thrombolysis at the home or in the mobile unit itself, in a large scale, that scenario can change.
No, we try to do it at decent scale. See, in cardiac, what happens is, TPA is free by the government of Tamil Nadu, but they're not ready to do it for ischemic neurological strokes. So those are the areas we have to iron out, and I think finally, it can't be led. We just wanted to set an example that it becomes popular, but didn't happen.
So can I address the question raised by Dr. Bimal?
Please, sir.
Yeah. So there is a policy which is being run by the government of India, that is the Ayushman Bharat scheme. Here stroke has been included. I am part of that National Health Authority. We have devised a package for the acute stroke as well as the entire spectrum of the neurointervention procedure. And the prices have been looked into, taking into account the cost of each and every device, including the ICU care required for managing the patient post-thrombectomy. And the package are very good. I think even the private hospitals can participate. It's just a matter of time when they bring out a gazette notification. So the work is ongoing, so it's practically included in the Ayushman Bharat scheme. So that is one thing which I wanted to tell. The second... So pre means what are you exactly looking for?
Lysis, imaging lysis before the patient reaches the hospital.
IVTPA?
Yeah.
Yeah, IVTPA is included. IVTPA is included. The only issue is about the mobile stroke unit that since there are very few, like one in Kovai, there are 3 in the northeast cities. That was as a pilot project started by the ICMR. But we can look into this aspect, but there are only few, so maybe the government will be a little more reluctant. But I think that's a good idea to have the package included in the overall package for the
But
stroke.
I think the solution to India will come out, since you are on the committee, I'm telling you, the solution to India will come out by not reinventing the wheel in this case. Mobile stroke unit, I feel, after reading so much and running it for 2-3 years, we have so many CT scan centers in the country. If we can get a way of making them the stroke alerting unit, because invariably 80% of our patients land up in some local CT scan center from a neurologist. If we can tap that data source, input source, that okay, there is a stroke here, and move things from there, they become the alerting centers. I think we can overcome this problem of having an MSU problem. Then the EMS will do the rest of the problem.
That's a good comment, Pankaj. The National Stroke Registry is working on this line. And again, I am part of that committee. We have included almost 32 medical colleges in that arm. And we are trying to dissipate the information to have the basic minimal infrastructure required for managing the acute stroke patients. The basic requirement, at least you should have a CT with a CT angiogram protocol, because unless you run a CT angiogram, you'll never know whether it's a small vessel occlusion or large vessel occlusion. If it turns out a large vessel occlusion, you need to shift the patient to endo-ready centers. Endo-ready centers may be tertiary care hospitals or comprehensive stroke centers, right? So the basic problem lies in identifying the large from a small vessel occlusion. And this is what I think the mobile stroke unit is trying to reach out to the patient's doorstep. And this may not be possible. You have to understand the country's length and breadth of so this may not be very cost effective. So the cost effectiveness lies in realizing that we have to install the CTs in the primary health center, the secondary health centers, and of course tertiary has completely CT, MR, DS and everything. The other model which you didn't speak about is a spoke and wheel method, right? Spoke and hub method. So there is a hub which is a comprehensive stroke center, and this hub can be connected through this mobile stroke unit to places where there is no stroke management facilities. Like the patient, if it turns out a large vessel occlusion, rather than shifting the patient from primary to secondary, the patient can be straight away taken to comprehensive strokes. By this method, at least you can save on the time. So this is what I wanted to just highlight. But anyway, it was a very nice talk, and you highlighted beautifully the challenges, particularly which are pertinent to our Indian scenario. And fully agree with you.
A heartfelt thank you to our esteemed moderators and speakers for the insightful discussions in the previous session. Now, before going to the next topic, I would like to break for some time for memento distribution, and I'll call Aravind sir and Sibisankar Dalai sir for further proceedings.
A very warm welcome to all our guests and dignitaries. Before I call upon Dr. Vimal sir onto the stage, we'll take a small gap for momental distribution to the available speakers as well as the chairpersons. So, Dalai sir, can I enlist you? Sir, so we would like to call upon Dr. Uday Limai sir as well as Nishant Aditya sir onto the dais for a small memento presentation. So thank you, Uday sir, for your time and traveling all the way. Another memento for our Dr. Nishant sir. Thank you for taking time, sir. Next, I would like to call upon to the stage Dr. Vivek Gupta sir for his talk about mechanical thrombectomy in stroke. Next, we would like to have Dr. Pankaj Mehta, sir. Next, we would like to call upon Dr. Sailesh Gaikwad, sir, to give the mementos to the next speakers and chairpersons. I would like to invite Dr. Vijay Chenna, sir. Dr. Vijay Chenna, sir, has been a wonderful moderator for us, and thank you for accommodating us, sir. Then I would like to call upon Dr. A. Mohan Rao, sir. Thank you, sir. Next, I would like to call upon Dr. Vivek, sir. Dr. Vivek Gupta, sir. So now I would like to welcome onto the stage Senior Neurologist Dr. K.V. Lu, sir, for making time out of his busy schedule to be with us today. Then we would like to call upon to the stage Dr. Rajesh Pati, sir. Thank you, Vivek Gupta, sir. Now we would like to invite up onto the stage Dr. Vimal Someshwar, sir, for his talk about subclavian steal syndrome. And as the moderators, I would like to invite Dr. V. Sujata, madam, and Dr. R. Lalita, madam. I would also like to call upon to the dais Dr. Minzilki, all the way from Almaty, Kazakhstan, to be one of our chairpersons. Next, I would like to call upon Dr. Dalai, sir.
Already been called first, so you can we can go ahead with the talk first.
Thank you, ISNR. Special thanks to Dr. Siva for the invitation and the hospitality here. Lovely city. I had a good chance to walk around the beach, and it was. I've made a plan that I'm going to spend 4 or 5 days later, sometime in my life. So with that, we will start with subclavian steal syndrome. Probably compared to the talks that we have had on stroke, the difficulties, the challenges, We all felt that the subclavian steel or the narrowing of the subclavian being managed by intervention is not very difficult, and it's a very straightforward procedure, and even I felt so. And we did all our procedures with that background. But thanks to you, made me read. You made me read, and when I went through the literature, there are a whole lot of things that came up. And I thought probably it's worth sharing these experiences, or the latest that I read about it. My cases have gone off very well, which must be the case with most of the people here. But these small facts and ideas is what I'm going to discuss today. So what is this subclavian steel syndrome? Just for some of you. Well, it is the syncope or a pre-syncopal attack that a patient would get. It's primarily because of diversion of the blood flow away from the vertebrobasilar territory, and this is due to the hypoperfusion that occurs during the use of the arm. It's more common on the left side versus the right side, and it's primarily the poor communication at the PCOM level that you get these patients. You may have stenosis in quite a few patients, but they may not have this syncope because the PCOM is looking after it and the perfusion or the hypoperfusion in the vertebrobasilar territory does not take place. It is due to the stenosis, and also I realized it can happen because of the AV fistula that we create in a dialysis patient. So this was something I read and I think this was not there in my mind before this. So this is one thing which I realized it. Large AV malformations also can divert the blood or sump the blood away from the vertebrobasilar territory and can have these pre-syncopal attacks. Now, what are the various things that can happen during the subclavian narrowing? Well, these are the 4 areas. Vertebrobasilar, obviously we are going to discuss that today. That will be the main idea of discussion. Spinal also can be an area, especially this we started seeing when we started doing TVAR procedures, and there was a lack of perfusion especially in the thyrocervical and costocervical trunk, which can supply the spinal cord. Again, was an area that we realized it. Upper limb claudication, ulcer and gangrene is one of the commonest presentation that these patients with subclavian narrowing will have, and coronary steel. And we have treated some patients post bypass surgery done where they have taken a lima as a bypass graft and there is a subclavian narrowing. I have done some patients where the surgeon sent the patient to dilate the subclavian artery before the patient was taken up for CABG. So these are the 4, the lima, the vertebral artery, the thyrocervical and costocervical, and obviously the subclavian supplying the upper limb is the area that you can get ischemia because of narrowing there. The causes, obviously, commonest is the atherosclerosis, which is very commonly seen in the left side because there is a turbulence of flow, and that is one of the common cause for an atherosclerosis to develop there. Again, patients who are smokers will have a chance of developing this, and males more common than females. In India, we should not forget if you have subclavian artery issues, then you can have Takayasu arthritis. Again, young females is a big category of patients that we do see in our lower socioeconomic strata patients. Thoracic outlet syndrome, especially among athletes, neuromuscular compressions, ribs crossing and traversing that area like the thoracic outlet is all that can cause subclavian. But remember, if you want to have a vertebrobasilar territory affection, then that narrowing should be proximal to the subclavian origin. Aortic anomalies, surgical, that is, as I told you, TVAR, that is one of the commonest things that we do. Aortic dissection and vertebral artery dissections are another causes for a vertebral steel syndrome or a subclavian steel syndrome. What are the various severities? Well, it purely depends on how is the flow in the vertebral artery. If the vertebral artery, there is just a reduced antegrade flow in the vertebral artery, then it's a grade 1 pre-SSS as we call it. Grade 2 is when there is alternating. During the diastole there is an antegrade flow, and during the systole there is a retrograde flow from the opposite side going into the ipsilateral side vertebral artery. And grade 3, which is what oftenly the patient will come to you, and this will be a permanent retrograde flow in the ipsilateral vertebral artery. These are the symptomatology. Well, one of the common things that these patients come up with is that the doctor says that your pulse is a little weaker on the given side or the blood pressure is a little lower. But if there are symptoms like pain, fatigue, numbness during exercise in the upper limb, again you can make a diagnosis of subclavian steal syndrome. Use of the arm during and the head on the same side again can cause pain and fatigue on the same side. Neurological symptoms are dizziness, blurring, ataxia, tinnitus. Hearing loss also can be a cause where you can pick up a subclavian steal in these patients. And obviously the signs are reduced pulse, BP of more than 15 millimeter difference between the two sides. And if you can hear a bruit during auscultation, could get you the diagnosis clinically. Well, the differential diagnoses are there. Upper limb peripheral arterial disease, posterior circulation stroke, aortic stenosis proximal to the subclavian artery, diabetic neuropathy are another case where you would kind of make a mix-up between the subclavian steal and these kind of diagnoses. Sonography, MRI, CTA and DSA are the diagnostic tools which can confirm the diagnosis. And important thing on a sonography, the velocity is what you need to kind of look at. Anything greater than 240 in the subclavian would suggest a proximal narrowing, and that's the reason the velocities have gone up. Especially looking at the narrowing in the subclavian may be difficult. I don't do Doppler, but I can imagine it is deep down in the thorax. You may miss a diagnosis there if you're doing a routine Doppler study. There are treatment, and one of the most important treatment is obviously, as I said, I'm going to talk more on atherosclerosis. That risk factor reduction in atherosclerosis is very important, and here in this case, starting antiplatelets is one way to start these patients, giving statins and stop smoking. These would be some of the instructions which you'll have to give to the patients. Surgery was the mainstay of therapy so far. And the usual therapy was a bypass where they did carotid to subclavian bypasses. Just at the neck, you don't need to open up the thorax, and that was a good bypass. But again, this is surgery, and if there is a minimal invasive procedure, like an endovascular procedure that has come up, it has now become the first choice, and we end up doing this in quite a few number of patients in a given year. Another thing that you should remember that there is surgery being associated with some complications. The reported data was about 21% neurological and lymphatic. There are a lot of lymphatic structures here, and if you damage that, you can have lymphatic complications here. And some patients would require resurgery in these patients, and therefore, endovascular has now become a first choice of therapy with subclavian artery stenosis. Now, what are the basic thing about subclavian artery angioplasty and stenting remains the same with most of the peripheral vascular disease when we treat it. Dual antiplatelets are to be started in these patients at least 3 days prior. We would like to do that or give a loading dose and do the procedure. Femoral or brachial approach of both axes may be necessary, so you should be well versed with it. Crossing the lesion is very important in these patients because that is the only challenge that you have. Crossing the lesion, sometimes it is dense calcified lesions, total occlusions may be challenging. You need a good sheath, good roadmap, a good wire and wiring technique that you need to have. And if you're coming from the brachial approach, you will require a snare. So these things should be available in your cath lab when you're planning these procedures. When you're doing the balloon angioplasty and stenting, well, you need a balloon-mounted stent, self-expandable stent. Do not have a roll here because you have a stent which has to be precisely placed, little hanging into the aorta and not crossing the subclavian, the vertebral artery should be the way that you should put it. So this precise placement, you need a balloon-mounted stent. You need the risk that is being discussed, and we always are worried. I'm sure all of you doing this, there's always a worry and question in your mind whether there is a risk of distal embolization going to the upper limb and or to the vertebral artery territory. And in that, I will tell you, my knowledge is that upper limb, there is a possibility the plaque can get dissected or ruptured and could go down the subclavian artery. Vertebral, I was very clear there is no risk, don't worry about it. But then when you go through the literature, you realize there are some things that we need to know about it. So when you talk of filters, or when you talk of emboli going into the vertebral artery, like the way we do for carotid stenting, is there a role for filter here? And now when you think about it, yes, there is a role. And what are the things that are being done? Invariably, you do your stenting and your procedure, as I said, either you come from the femoral or from the brachial approach, cross the lesion, and then even if you have come from the brachial, try and put your balloon and stents from the femoral approach. So you need both the axes. But for the filter, you go via the subclavian and go up into the vertebral artery. There are people who have put filters, and now people are talking about just putting a balloon, temporarily occlude it, and then withdraw the balloon out. And similarly, you withdraw the filter out. So these are the two things that are there that you can do it. And this is the landmark wire technique which they have discussed, which suggested that yes, you can do these therapies by placing a balloon or a filter via the subclavian approach. Now, if you look at this particular, let me see this. Yeah, when you look at this study, what they said was when you do your balloon angioplasty of the subclavian artery, there is delayed restoration of the antegrade vertebral flow, which takes about 20 seconds to several minutes. This was the suggestion, or this is what they probably feel is what is happening. I don't know if anybody has calculated that very clearly, but this particular paper said that it takes about 20 seconds, and therefore the risk of stroke happening is not there. The neurological complication that they have suggested is 0.04 to 4.7%, and that is what makes you worry that yes, do we need to put filter in all these cases? If you realize it in the carotid territory, when you put a filter in a standard case, you are reducing the risk rate by about 1 to 2%. If you have the filter and without filter. In this case, a particular paper suggests that there is 4.7% chance of getting a stroke, and therefore there is a role for filter. So now, in hindsight, this is one thing I learned thanks to you. This was one interesting complication they had. This was a patient on whom they went ahead with doing the procedure from the femoral approach and got the filter from the brachial approach. Now, unfortunately, they claimed the patient coughed during the procedure, and therefore the stent got dislodged beyond the subclavian, beyond the vertebral artery. The stent went up there, and the filter was still stuck up there. Now, how do you get it out? So therefore, the patient had to be subjected to surgery, and you know this surgery could be quite dangerous, and patient could have stroke just because of the procedure itself. And therefore, they said that don't put a filter, put a balloon, and that could easily come out if you want to do that. And then I thought about it, probably they could have kept the sheath to retrieve the filter already in place, and then could have used this filter. But I think balloon is a good choice in these kind of patients. There's no need to put a filter which can get stuck in the stent if you by chance overshoot and cover up the origin of the vertebral artery. Now, this combined transradial and transfemoral approach with osteal vertebral balloon protection is what probably is being discussed in this particular paper, and I think it's worth reading this paper, and I would probably use this therapy rather than a filter in these cases, and also the cost of the filter versus the balloon. Obviously, these balloons are cheaper. Then there was another good way of doing this. In this case, what they did was to increase the antegrade flow into the vertebral artery. They did a compression of the opposite arm with a BP cuff, and they raised the pressure up to 180 millimeters of mercury. By increasing the pressure here, there was more flow into the left vertebral artery, going down into the right vertebral artery, and they said there was no need for any kind of protection required in this. So again, thanks to you. These are some of the cases. This is a standard case where you see that extensive calcified lesion here, dirty looking area. Yes, you are worried the thing could go up into the vertebral artery, but as I said, we felt it was not the worry, and we did our stent and balloon and everything. It went on very well. There was no issue. Now remember, when would in this kind of a patient, when would the clot or the plaque could go up is post-angioplasty. Sorry, I went ahead. Yeah. It is post-angioplasty that the clot could go up. And once you are dilated, pre-dilated, and now getting a stent up, then there is a chance during that process the antegrade flow has started and you can have a plaque going up into the vertebral artery. This is an interesting case here. 70-year-old diabetes mellitus, CKD, all atherosclerotic risk factors, dizziness, loss of balance, tinnitus, and there was a poor pulse in the left upper limb. And this is the picture where you can, classical picture, where you can see the flow going retrograde into the opposite subclavian, and we needed to do this. We came from the femoral approach first, was not possible. We came from the brachial approach here. We struggled quite a bit to cross this lesion using various types of wires. Finally, we did cross it. You can see that the catheter has come from down up, and now we are trying to get a snare to hold the wire and go up on the segment, pre-dilated with a balloon, and then got the sheath up and got a balloon-mounted stent, and then finally deployed it successfully. As you can see that it's hanging little bit into the aorta and very close to the origin of the vertebral artery. Since this was a long lesion, we had to place it very close to that area. This is a 62-year-old female, left-sided headache, heaviness in the left side of the chest and back with the left upper limb pain since last 3 months. And this is again a good picture, all the 4 areas. There's a tight stenosis here, and that is the vertebral stele. And here in this case, what happened was we could get a wire from the femoral approach. You can see that my diagnostic catheter is here and a micro catheter. I used a micro catheter to cross this lesion. It went up. But when I'm trying to get my micro catheter up, it was not going up in this case. And so at this point, then we went ahead and then we came again from the brachial approach, went down, got the wire and did the same technique what I did the last time, and successfully managed to do a balloon angioplasty and stenting of the area. This was a very interesting case. Basically was referred to me by my bypass surgeon, the cardiac surgeon, because the patient basically had a triple vessel coronary artery disease. And during examination and various studies, we found that he was absolutely atherosclerotic, extensive disease, multi-vessel disease, as you can see that. There is, this is the right ICA narrowing, left ICA narrowing, bilateral renal, though right was still okay, left was tight. There's a femoral artery stenosis, and there is a subclavian. And the surgeon wanted to do a bypass in him and use the Lima for the surgery. And this was pre-CABG that we had to do this procedure. And we staged the procedure into, I think, 2 or 3 times, where we kept on doing 1 artery and 2 arteries at a time. And there you can see that we have stented the right carotid, the left renal, the left femoral. We just did a balloon plasty with a drug-coated balloon since it was a short lesion very close to the profunda, and we put a subclavian stent in him. And now he's undergone a bypass surgery. It's now more than 8 months that the whole procedure was done on him. This is, again, one of those rare cases where you can see that there is a dissecting plaque with a thrombus, and the patient, 32-year-old young male, blush discoloration of the little finger of the right hand since 3 days, and this was the angiogram here. Now here comes the idea that what should you do and how will you do this, because this is a plaque rupture with a secondary thrombus going up the limb. There you can see the brachial artery. There is a flow into the digital branches, though relatively slow. Now, this is a very tricky area. You can release the clot going up into the vertebral. You can release the clot going up into the upper limb and can cause any kind of ischemia and worsen the situation. So here in this case, first thing we did was we assessed how is the vertebral flow, and we realized that the left vertebral was dominant and there was a nice flow filling up the vertebral territory completely. So what I did was we went up first and did coil embolization so that there would be no further flow up into the left vertebral artery. And I put a filter in the right subclavian artery and then went ahead, did the aspiration with a catheter and then put a stent and got the answer completely. Patient had no upper limb or lower limb, upper limb or vertebral artery stroke, and this patient did well and is still following up with us. This was one case. This is another important aspect is when you have a stenosis of the right subclavian artery, where often it is very close to the carotid artery. And remember, in these kind of patients, when you want to put a stent, it will invariably, this point will overhang into the carotid artery. This is a common thing that will happen. So don't get worried. This is the way we have been doing, and we have not had any problem. This one case which I had done long time back, I don't have the pictures here, but I remember what I had done. This was innominate artery stenosis. Now we are worried about the stroke up the carotid, up the subclavian, also in the vertebral artery. And in this case, what we did was we did the whole procedure via the femoral approach, kept a filter in the internal carotid artery on the right side, and from the subclavian we got a balloon into the vertebral artery and then went and stented this patient successfully. Coming to my last case, this is a case of aneurysm here in the subclavian territory. And this again a challenge here because you're going to have a covered stent being put in here, and you surely don't want to cover the vertebral artery, but at the same time you don't want any of the collaterals refilling or causing an endo leak within the aneurysm. And what we did here in this case was we went into the branches here, the thyrocervical, costocervical, and we did coil embolization to prevent an endo leak, and we got a stent graft here and embolized and took care of the aneurysm very well. Surgery could have been another option here, but we all know the problems related to surgery. Endovascular, the next day patient was home. So these were some of the cases that we have done. This is another interesting aspect where there is a intramural thrombus, just about something like a dissection which is taking place. The patient came with a thoracic all the way close to the subclavian artery. And when we wanted to put a stent graft here, we knew there was no landing zone here. We had to extend it up to the carotid artery. And while doing that, we had to actually do a fenestration to get the subclavian flow. This is what is being done for all the TVAR procedures now. We invariably want to revascularize the subclavian artery either by surgery or by intervention by doing fenestration and then treating this patient. So this is one such case. There it is. And you can see that my stent graft has gone all the way up to here, and we've got a fenestration and a stent graft put into the subclavian artery. This would help reduce the risk of spinal ischemia in these patients. So again, as I said, I got a good chance to review some of my good cases when you gave me this offer to come and discuss these cases. Thank you again very much and any questions, we'll take it.
Thank you, sir, for coming and spending a lot of time with us. Great presentation. So the first one is, what is your antiplatelet protocol when you did a stenting followed by CABG? You have to wait for some time, or?
As you said, what is happening in these patients is that basically you have given dual antiplatelet. And the surgeons are a little worried about doing a bypass and a surgery, and bleeding could be a high risk. So what we do in this, we start our
dual antiplatelet. We finish the procedure, keep it at least for 7 days, then put them into, for 3 days, we give them low molecular weight heparin, stop 1 day dose, the surgery is done, and start with low molecular weight heparin and then antiplatelet. So that is what the usual pattern is, and that is what my surgeons are following. Nowadays, some surgeons are very aggressive and they say, we are not worried even if the antiplatelets are on, and they go ahead with the surgery. But yes, there is obviously a little increased risk of bleeding in these patients.
The second question is there a role of self-expandable stent in this type of lesion or only balloon expandable?
So the role of self-expanding stents would come in if there is longer lesions and you're not worried about covering or jailing the vertebral and all that thing. Especially in Taka issues, I have done patients where we had to put a long stent right from the origin going at least 10, 12, 14 centimeters. You don't get balloon mounted stent that long. And number two is patients with FMD. Again, they can have long lesions. And if it is coming from the origin, then you'll have to cover up that area. But subclavian with FMD, I have done with long stents, especially if it's going across the joint, we are using Supera stents in them. So we have used long stents, self-expanding.
Thank you, sir.
Are you worried about jailing an ordinary balloon-mounted stent?
Are we worried? Again, if it's necessary, yes, we would jail it. If we need to avoid it, we should avoid it. When you want to actually jail it, try and see if the opposite vertebral is dominant or at least equal to the side. Then only you should probably do all these kind of tricks. Otherwise, there is a high risk of these patients developing, vertebral flow reduction and stroke in the vertebrobasilar territory.
So it's a high flow area. Basically, nowadays, even in cardiology, we are moving away from dual antiplatelet to single antiplatelet. I think the antiplatelet beyond 1 week, you can go on to single antiplatelet in your...
Yeah, the only worry that we have is the amount of atherosclerotic plaque that in a peripheral territory that we are handling, calcified hard lesions compared to coronaries, the plaque load and the length of the disease that we have, the length of the stent that we are using, the metal that is being used is so much more than the coronary, and we don't have drug-coated, drug-eluting stents. So all that comes into play. And therefore, we are still skeptical, but yes, I would probably wait for some data coming in suggesting single antiplatelet is good enough, fair enough. We will do that. Thank you.
Dr. Vimal, thank you. Thank you for showing your beautiful cases. You showed two of your cases. In one right side, the stent was overhanging at the origin of ICA, and same, the stent was overhanging in the aorta. So do you change your antiplatelet protocol whenever there is such kind of
No, we maintain the same antiplatelet therapy.
Usually there's no thromboembolic phenomenon.
Yeah.
Thank you.
Okay, thank you.
Thank you.
Before Dr. Vimal sir gets off the stage, I know he has a flight shortly. So sir, if you could remain on the dais, I would like Dr. Minzilki to present the memento to Dr. Vimal Someshwar sir. Thank you, Vimal sir, for your time. I know you have to rush for your flight very shortly.
Okay, next speaker, Karunakar Padhi, carotid artery disease, role of endarterectomy.
May I request Professor Satya Rao sir to join the moderation? He is here in the hall now.
Respected chairpersons, audience. Good afternoon to everybody. First of all, I am thankful to the organizers, especially our friend Dr. Dalai, for giving me an opportunity to talk to this august audience. And I will speak on role of carotid endarterectomy in carotid artery disease. I know we are little odd men out for this audience because everybody believes that without surgery all this can be done. But we are little bit old timers, and if you look back the history, the carotid was maybe 20 years back, it was only handled by the cardiovascular surgeons. But now there are many players, like cardiologists take care of, vascular surgeons, and of course neurointerventionalists, all of you take care of these areas. So still we have a role. Still carotid endarterectomy can give good result in many of the patients. So I will try to go into details of what can be done and which are the subset of patients can really benefit by doing carotid endarterectomy. Of course, all of you may not like that surgeons will be doing in that area, because now most of the cases are being done by neurointerventionalists, but still I will try to do my justice. And some of the things I may be going to the basics, some slides may look a bit silly, so just bear with me. Next.
No, let me just clarify, Bhai. We like it. We like it that you do some surgery. There is nothing that we don't like it.
Yes.
We love you actually, that's why you're here. So we would love to listen to you, and whoever person is appropriate for whichever procedures should go to them. So there is nothing that we don't like it.
Yes.
Please.
Okay. Next. How to change slides? There, this one? Okay. So if you see today a lot of discussion on stroke was there. The hemodynamically significant carotid stenosis varies with the age and other risk factors, and on an average around 5 per 1,000 people above 50-60 years, they will develop some sort of stenosis, and 10% of the people above the age of 80 will have more than 50% stenosis. Increased risk of stroke, myocardial infarction and death are reported when there is significant carotid stenosis. And 50% of patients with stroke usually will have significant carotid obstruction. As the discussions were going on, many people, it is many times those small vessel disease can develop stroke, but major vessels, particularly carotid, will have significant blocks, and those things should be addressed at appropriate time. Without anatomy, the surgical things cannot be discussed, and particularly for being a surgeon, we have to know all the structures in and around the area where we operate. So I'll just go through quickly about the anatomies around the carotid artery. Here we can see there are a lot of triangles we call in the anatomy. There are below will be the subclavian triangle, then digastric triangle, and above will be the carotid triangle bounded by various muscles. So that is the area where we get the carotid arteries. And this is how the carotid artery goes and divides. The common carotid divides into internal and external. To identify on table, actually there are a few tricks. The external carotid artery usually remains a little internally, and internal carotid artery little externally. That is one trick. And the other is the external carotid artery will have branches in the neck, and internal carotid will not have any branch. So whenever there is a branch in one of the bifurcation, after bifurcation, it is 100% is the external carotid artery. And these are some of the knobs going around. So we have to be careful during surgery, particularly very high facial nerve, then hypoglossal nerve and vagus nerve. Pointer which is Yeah, you can see this is the hypoglossal nerve crossing just above the bifurcation, and the vagus nerve goes in the carotid sheath. So we have to be very careful while doing the surgery. And the more important is for doing the carotid endarterectomy, we have to be sure that the circle of Weil's is complete, so that the from other side blood can be blood flow can taken care of this side circulation. Otherwise, surgery itself can be a risk for the developing stroke unless we bypass during surgery. This is how the circle of Weil's has to be demonstrated by CT angiogram before doing surgery. Looking at the history, the first reported 1875 Gowers described that the extracranial disease can develop stroke, and that is mainly of the carotid or vertebral arteries. And first angiography was done in 1937, and in 1954 the first successful operation for carotid artery disease was done. Looking at the pathophysiology, as we know, the most common pathophysiology is atherosclerosis. It is the disease which causes the carotid artery stenosis, but of course other things including radiation, arthritis can play a role. And once there is chronic endothelial injury, there will be accumulation of the lipoproteins, then the inflammation process, fibrosis, smooth muscle recruitment, all this starts, and the size of the plaque increases and the narrowing goes up. There are two mechanisms of stroke, embolism and ischemia, but unfortunately both ways the carotid obstruction can cause development of the stroke. And the site of obstruction, most of the times, more than 90% of the times, it will be bifurcation, where the common carotid bifurcates into IC and external carotid artery, and that is the place. But of course, sometimes origin of the common carotid artery can develop the block. Intracranial part usually less affected because the atherosclerotic plaques does not occur in the intracranial part of the ICA. So coming to the associated disease, again the coronary artery disease is the most common association along with carotid block. Around 20% of the patients will have history of myocardial infarction, and I would suggest that any patient going for any carotid intervention, they should be evaluated cardiac wise, otherwise perioperative or periprocedural myocardial infarction development chance is very high. And that's why many of the times we do concomitant CABG along with carotid artery surgery. And peripheral vascular disease is another area where people will be having either femoral artery block, popliteal block, or iliac artery block, or sometimes brachial artery narrowing. So all these things has to be evaluated when a patient comes with carotid artery stenosis. And of course, all the risk factors pertaining to cardiovascular disease or any other atherosclerotic disease are still relevant for patients with carotid artery stenosis. The clinical presentation can be a TIA, hemorrhagic focus, or cerebral infarction. Clinically, we can get the carotid bruit and upper motor neuron lesion, or sometimes retinal infarction. They can be classified into mild, moderate, or severe. The investigations, usually we do color Doppler study in all the patients, particularly when we do coronary artery bypass grafting. Color Doppler of the neck vessel is a must, and many times we get significant or non-significant blocks. CT angiogram will exactly delineate where the disease. MR angiogram can delineate very clearly. Conventional angiogram also have a role, particularly while doing coronary angiogram. DSA also can clearly define the lesion, and virtual intraluminal endoscopy, I don't have much experience, but it may be useful particularly to characterize the plaque, and exact lesion and type of lesion may be useful. This is how the carotid Doppler, you can see the narrowing. This is the DSA where you can see the discrete block in the internal carotid artery. And these are the type of lesions exactly at the bifurcation, both external common and internal carotid arterial block. And these are the cases ideal for carotid endarterectomy, because along with that, both external and internal can be perfused very properly. This is a CT angiogram showing the origin of the internal carotid artery significant blockage. So what are the treatment options? Whenever we either intervenists or surgeons, we come, we just think of whether to do surgery or do intervention. But many of the patients can be managed medically if they come at early age, early lesions can be seen, so that the usual treatments like what we do for coronary artery disease or ischemic stroke patients holds good. Antiplatelet, antihypertensive, lipid lowering agents, and the very important is lifestyle modification, so that if we get a block of say 40-50% lesion, if they are asymptomatic, if they can properly medical managed, they can be managed without developing stroke or progression of the lesion. But if it is required, then other two options, of course, carotid angioplasty stenting or carotid endarterectomy will be useful. When we should operate? The symptomatic patients, if there is a frequent TIA in the past 6 months, even if carotid stenosis more than 50% patients, they should be offered treatment. Or if the ipsilateral carotid stenosis more than 70%, they should be operated if they are symptomatic. Of course, if there is a concomitant CABG, both should be done along with carotid endarterectomy, or we do a stenting after few weeks, we go for CABG. Progressive stroke with carotid more than 70% stenosis, they should go for endarterectomy or stenting. Asymptomatic patients are controversial. Before, even if asymptomatic with severe stenosis, we used to advise, even we also have done endarterectomy few patients, but often nowadays the literature does not support much. So in our practice, at least we stopped doing endarterectomy for asymptomatic patients because chance of developing stroke sometimes is there. And second thing, the natural disease process may so prolong that we can avoid the unnecessary surgery. Bilateral, we never do the carotid endarterectomy because chance of developing stroke are very high. But there are some indications where we should go for bilateral endarterectomy, particularly if they are symptomatic with more than 70% stenosis with intraplaque hemorrhage is there, or ipsilateral symptomatic with contralateral intraplaque hemorrhage, or even bilateral asymptomatic intraplaque hemorrhage of more than 80%, they should be offered surgery. Otherwise, chance of developing acute stroke in those cases is very high. Or even if we do one side, other side developing stroke, chances are very high. So coming to the angioplasty or carotid endarterectomy, the things are becoming more and more clear now. But if you look at the literature, the 30-day stroke mortality rates are marginally higher in the angioplasty group in comparison to carotid endarterectomy, though it is not statistically significant. But the stroke journal that was reported, the 5-year risk of stroke and death was same, and the nerve injuries are more with surgery, but the restenosis chances are very, very high with endovascular stenting in comparison to endarterectomy. Because if a complete good endarterectomy is done, the long-term results are very good. There is no doubt about it. Similarly, like CABG and angioplasty, long-term results are very high, very better in surgery. There are many clinical trials. All of you are more knowledgeable on these things. I am not going into details. In ICSS trial, they have shown that in symptomatic patients, the stroke, MI and death are significantly higher in the angioplasty group. But in CREST study, where there was mixed population of symptomatic and asymptomatic patients, there was no statistically significant difference. Of course, with better technologies nowadays, the stenting also gives much better results. So many of the patients, even we also refer to do angioplasty and stenting, particularly if the interventionist is a very expert, and we are lucky that we have Dr. Dalai. He is very good. So after many of the patients, we send him for doing the carotid angioplasty instead of going for surgery. But there are definite some patients who benefit from endarterectomy. I will just go. So as we told, asymptomatic patients' natural history is not much different than the normal population. So I think these are the group of patients they should be left alone instead of going for any intervention. There are, of course, contraindications for doing endarterectomy, particularly in acute stroke. If there is patient has severe stroke, which are non-rehabilitated, very major stroke, there is no point of doing a surgery. If they have high cardiac risk or they have short life expectancy. So these are the conditions where we should prefer for carotid endarterectomy, particularly when we are going along with CABG. If CABG can be postponed, we are doing stenting followed by CABG is better. But if CABG also demands emergency CABG, particularly left main or patient has ongoing chest pain, we cannot do a staged procedure. I think those are the patients we should do both the procedures, carotid endarterectomy and CABG. Similarly, the ICA is less involved, as I showed in that just proximal ICA is involved. Those cases they should go for endarterectomy. But if there is a significant narrowing of the ICA, because immediately after origin of the internal carotid artery, they goes intracranially. If there is a significant length of ICA is involved, then surgically it becomes technically difficult. We may not able to get the distal control. So those are the cases we cannot do endarterectomy, they should go for stenting. But if it is less involved, we should do. Early bifurcation, they are little easier to do for endarterectomy. Similarly, well-developed circle of wheels, develop of stroke chances are very less. So those are the patients also, they should go for endarterectomy. And if there is a very significant narrowing, 90%, 95% blocks, then the plaque will be very matured and they come out very easily, and the result of endarterectomy will be very good, and long-term patient benefit will be very good. Stenting also should be preferred if there occurs restenosis after endarterectomy, which less but sometimes can occur. Post-irradiation cases, and of course if there is a hostile neck, stiff neck where approaching the carotid artery is difficult, those are the cases directly they should undergo stenting. And of course some patients, if they are high risk for CA because of other comorbidities, particularly if they have CKD and other metabolic problems, medical problems, then they should also go for angioplasty. Complications do occur with surgery, particularly hematoma, infection, hypotension or hypertension, intracranial hemorrhage, hyperperfusion, development of CVA and nerve injury, and of course long-term restenosis. There are two surgical techniques. One is conventional technique where we just remove the plaque, and there is another known as eversion technique where we cut the artery and pull it out the part. And this is one of the surgical picture where we can see the bifurcation as the artery which is remains medially towards the midline is the external carotid artery, the other will be the internal carotid artery. And these are some of the dissections where you can see. This is the conventional technique where we remove the plaque and put a patch, either synthetic patch, or if we are doing along with CABG, we put the pericardial patch. And this is the eversion technique where we divide, pull it out and re-anastomose. This is the post-operative picture. These are some of the pictures where we can see we put a patch. And this is not an endarterectomy, this is a carotid body tumor. We can see big carotid body tumors we can remove from the bifurcation site. Just to show it, I have put this. So during surgery, we bypass either externally or inside the lumen to protect the blood supply. And this is our experience. We have done 42 cases with concomitant CABG, and internal bypass we have used. Pericardial patch we have used some of the cases along with CABG when we do. We didn't had any mortality, but one patient had stroke. And of course, last 2 years, we have, as I told, we stopped doing cases for asymptomatic cases. And angioplasty followed by CABG also an evolving option. As of now in Medicover Hospital, if patient can wait for CABG, we are sending patients to get angioplasty, and after a few weeks, preferably we wait 6 weeks to do the CABG. And as I told earlier, carotid Doppler, we do all CABG patients to not to miss any carotid disease, because these are so correlating coronary artery disease and carotid artery disease, so that we should not miss and get any eventful occurrence during procedure. Thank you all.
Given up the fight even before you started. We are prepared ourselves for a great debate, and
I know, because majority of your interventions, if I tell more on this, I don't have any exit here. So
more data is in your favor. So you, though in spite of the data, we were all said and done, the peri-procedural stroke rates are more with the carotid stenting. So we are all prepared to fight you and say that our stroke rates are coming down and we are doing things better, but you gave up the fight even before. Right?
Thank you.
Sir, as a neurologist, we still have some preference for surgery only, despite
good.
interventions being taken. Well, in certain conditions, the
Yes.
indications are definitely there, but we do a pre-op MRI, brain and MR angio. If there is evidence of significant small vessel disease, according to our register, although the numbers are very small, I've seen that the rates of restenosis or peri-procedural stroke are more if there is a significant small vessel disease. In those cases, I personally recommend a CEA rather than CAS. But if there is some evidence of intracranial atherosclerosis, I do tell them to go ahead for stenting, so that they will be on dual antiplatelet agents, and even the intracranial atherosclerosis is taken care of. So
thank you.
Thanks so much.
Do you have any situation?
1 minute. Just a surgeon prefers to do both carotid endarterectomy and bypass rather than stenting and bypass, and then do bypass.
That's true. We do, but some of cases we can do that. That also is because the results are also becoming better with angioplasty. So some cases we can do that one.
Do you have any situation where you absolutely feel that no, it has to be endarterectomy, not a stenting? Stenting is absolutely no, irrespective of the
That's what I showed in one of the slides. No, surgery is preferred, particularly if there is very significant discrete block is there. The removing the plaque is technically easier, and so those cases the long-term result will be very good. We will not have any restenosis, we can tell, particularly because of the major vessels. Because endarterectomy itself is also as unphysiological, I can tell, because we are removing the endothelium along with that. But particularly in the major vessel endarterectomies, particularly the abdominal aorta infrarenal endarterectomy we do, sometimes iliac artery endarterectomy, even up to femoral artery, then this carotid artery, there the long-term results are very good. But when there is a small vessels, when we do coronary endarterectomy, long-term results are not good. So we have almost reduced or stopped doing coronary endarterectomies. But as far as carotid is concerned, endarterectomy has still a good role, and as Madam told, its long-term results also is good. So we should selectively do some of the cases that. But the only disadvantage for us as surgeon is if the disease extending much into the internal carotid artery, then technically it becomes difficult for us, because immediately after bifurcation another 2 centimeters is going intracranial, and those are the cases will be difficult for us.
Thank you so much, Dr. Karunakar Padhi, for an excellent lecture. Now I would invite upon Professor Shailesh Gaikwad, who is the Director of Neurosciences at All India Institute of Medical Sciences, New Delhi, to speak us on carotid artery disease, role of stenting. Sir has been a pioneer in doing carotid artery stenting in the country and presently serving as the president of ISNR. We are happy to have you, sir. Please go ahead. Thank you.
Can someone help me out?
Can you check the pointer?
So, good afternoon, everybody, and the dignitaries on the dais and off the dais, and my special thanks to Dr. Siba. Okay. So thank you, Dr. Siba, for having me here. And actually, my talk has been made easy by the previous speaker. He has, in fact, laid down the foundation of my talk. And he has beautifully highlighted the role of CAA in contrast to the angioplasty and stenting. So I think let's move on to the talk. So as said by the earlier speaker, the cardiovascular, cerebrovascular cause of permanent physical neurological disability is high. So if you look at the total stroke burden in India, it is about 1.5 million. And looking at the humongous burden of the population, this is too high. But there are very few centers across India which are dealing with this acute stroke as well as a secondary role of the stroke prevention. But stroke is the first and the major cause of disability. So it's very important to not only treat them, but also prevent them. USA is, of course, the fifth most, the common cause. But in India, you know what is the stroke burden? It ranges from 105 to 152 per 1,000 person per year. And the prevalence is 44 to 559 per 100,000 persons. And of course, atherosclerotic disease of the extracranial is one of the major cause, but India is dealing with a very different situation. In India, the incidence of ICAD is almost 30 to 40%, and our population has an incidence similar to the other Southeast Asia Pacific region countries. So our data is almost matching the data from the China or some other neighboring countries. And of course, management strategy is medical management, the most important, followed by the surgical recanalization procedures, and of course, carotid angioplasty and stenting. So I'm going to focus more on angioplasty and stenting. So this is the overview of my talk. I'm going to focus on the carotid angioplasty and stenting. And in the end, I will try to share our experience. So coming to the carotid, how does this stenosis develop? Well, if you look at the carotid bifurcation, the flow dynamics are very important to understand. The flow is generally lamellar toward the center of the artery or the artery which is not branching. And towards the bifurcation, the flow becomes little wavy, like here, and then it continues to hit the intima of the vessel wall. So the factors that come into the pictures are the wall shear stress forces, the hemodynamic, the local turbulence, the intimal injury, inviting all the plaque-forming agents like the macrophages, the lipids and other things. They result in the formation of the plaque, like this here. And of course, the plaque can also form on the wall of the external carotid artery. So this is what the overall factors which lead to the formation of the plaque. And we need to focus on all this. And what does the stent does? Actually, it makes the hemodynamic stress forces less obvious, tries to keep the arterial flow in a lamellar way. So once you put a stent, like flow diverters, the similar mechanism applies here when you deploy a stent. At the same time, when you apply a stent, what it does, the plaque is pushed towards the wall of the artery, and it tends to open the stenosed segment of the artery. Sometimes you do need a post-stent balloon dilatation, but almost in 50 to 60% of the time, the post-stent balloon dilatation is not required. This is my own experience. So you need to be very careful when to use this post-balloon dilatation, because every step in stenting has a thromboembolic phenomena occurring, like when you are crossing with the wire, you are doing balloon angioplasty, you are putting a stent, or doing a post-stent balloon dilatation. All these four steps will cause some degree of thromboembolic phenomena. Even if the emboli are very micro, they do cause occlusion of the very, very small arteries, and may be seen as hits if you do a DWI in each and every patient with a stenting arm. So what are the techniques that assess the vasculature of the brain and the arteries leading from the aortic arch? So the most important, which can be performed from the OPD basis, is the ultrasound. So ultrasound, what are the situations when it is useful? For the neck region, it will tell you the morphology of the plaque, whether there is any intraplaque hemorrhage or not, whether it's a heavily calcified plaque. But the major limitation is that it cannot assess the intracranial circulation, if there is presence or absence of a tandem lesion. So this is the major drawback of the ultrasound. Yes, for the post-stented patient, I think this is the imaging modality of choice, because you directly see the stent, and if there is any other intimal disease evident like intimal hyperplasia, I think ultrasound is the best modality to pick on those things. And MR angio, yes, it's required, but in certain situations, it has a major limitation that aortic arch and the major vessel origin from the aortic arch, as well as the ostal stenosis, cannot be accurately localized by the MR angiography. So to offset that, we generally do CT angiogram, and that covers the area from the aortic arch right up the circle of Willis. So you will get to know the type of the aortic arch, and beside that is other information. Now, other imaging modality which is coming up in a big way is a vessel wall imaging. Now, what are the basic indication of vessel wall imaging? When you are dealing with ICAD, I think vessel wall imaging, especially for the circle of Willis region, is very, very useful. And if you want to use a vessel wall imaging for carotid bifurcation, then essentially you are looking at the presence or absence of an unstable plaque. For example, if it is more than 70%, there is no controversy about treating or not treating, but when it comes to less than 50% or 50% to 60%, and if the patient has come with symptoms, you want to know what is happening in the carotid bifurcation region. In that situation, you do a vessel wall imaging to look for intraplaque hemorrhage or any other evidence of a unstable plaque. If you identify unstable plaque, that becomes a major indication for treating this patient for the recanalization procedures. And digital subtraction angiography. Well, digital subtraction angiography is not required for diagnostic purposes. It's only used when the patient is a candidate either for CAA or for a carotid angioplasty and stenting. So at my center, we do angioplasty only when we are going ahead with the stenting in the same session. Or the surgeon wants to know the collateral circulation status and other evidence, then we do a DSA. Otherwise, we don't do DSA for a diagnostic purposes. So vascular wall image, yeah, MR angio, DSA and everything, but what is the basic idea of doing a DSA? We want to know the percentage of stenosis, and this is highlighted in various trials like NACET and ECST, and this is a formula which is used across board to find out the percentage of stenosis. So let's move on. Now, the management, the medical management. Here we manage the patient with antiplatelet agents, statins, antihypertensive, and management of any comorbid condition that the patient may be having. If it is significant stenosis, then this medical management will fail. And almost 20% of the patient, it generally it is not effective. So then we come to the next management, that is a recanalization procedure. So surgery has been beautifully highlighted by the previous speaker. And then we have the carotid angioplasty and stenting. So if you look at this CEA, it is a more invasive procedure. You need to do a resection, dissection, removing the plaque, and then suturing, all those things. And they are blocking the artery distally. Need to understand they are blocking the flow distally. So if there are no good collaterals, the patient may not tolerate this occlusion for a longer period of time and may develop silent ischemia to the brain. In contrast, the advantage of stenting is great for simple reason that it's a minimally invasive therapy. You are going through the femoral region. There is no cosmetic concern about having a large incision over the neck. Then you cross the lesion with the wire, over the wire you deploy everything else and then come out. What is the major disadvantage? The continuous flow is going on during all this procedure because your infusion drip is on. So naturally you are throwing all the emboli into the distal circulation. But most of the time you get away with it for simple reason that unless and until the embolus is large enough to cause major vessel occlusion, the small emboli do not cause much symptoms in the patient, as is evident by the studies performed by the DWI. So 95% of the small heads, they are asymptomatic. They become symptomatic only when they are large and they are occluding a major artery, which is strategic in supply. So those situations, the patient may become symptomatic. So let's move on. What is the case selection? Very important. For a beginner, I think you should take a youngish patient, less than 70 years. Vessels are very straight. Aortic arch is type 1. Those are the subset of patients we should start to begin and do angioplasty and stenting. For more experienced person, we do everything left and right, type 1, type 2, type 3. It doesn't matter to us because anyway we are well trained in intervening in other areas like aneurysm management, AVM. So stenting is another spectrum to deal with. So the next thing is the assessment of the brain parenchyma, planning, proper selection of the hardware, whether you want to use a open cell design, closed cell design, or a membrane layer. That is largely decided by the anatomy of the lesion. And then most important thing is the management of the complications. So pre-procedure CT followed by post-procedure CT, look for any evidence of stroke, look for any evidence of bleeds in the brain parenchyma. If the patient becomes symptomatic, CT is normal, you have to ship the patient to MR, at least get 4 sequences like DWI, ADC, SWI, and FLAIR, right? That is the minimum requirement. You have to have a good post-procedure follow-up. And of course, what is the follow-up protocol in my department? We keep the patient in ward for 48 hours. The first 24 hours are spent in the ICU. Later, the next day, we ship the patient to the private ward or the general ward. And after 48 hours, we discharge the patient. Our first contact with the patient is 1 week later when we call the patient to the OPD. We do a repeat Doppler just to see that the stent is not thrombus and patent. So this is the protocol that we follow at AIMS. And these are the imaging which we generally do. For parenchymal imaging, yes, the gold standard is CT scan. But if you are dealing with a situation where CT is relatively normal, we do DWI, we do FLAIR and SWI. SWI, if there are too many hemorrhages, then it means that if the patient is in DAPT, it's a candidate for having a hemorrhagic complication. So that gives a fair idea. If there are not many bleeds, micro bleeds in the brain, then safely stenting and DAPT can be started. Of course, you have to decide which territory is affected. Is a territorial infarct like this, middle cerebral artery is gone. This is like a watershed territory infarct schematically seen on the left side, and this is its infarct in the watershed zone. The watershed zone could be anterior cerebral artery and middle cerebral artery anteriorly, or posteriorly it could be the middle cerebral artery and the PCA. So internal watershed territory infarct is very important. If the infarct size is too large, don't intervene because there is every chance of creating a hypoperfusion bleed. So we should not intervene. If the infarct is large enough, you should wait for some time, allow the patient to recover at least 6 weeks, 8 weeks, only then. If the patient becomes non-disabling, then you should intervene. But if there is a large infarct, don't intervene. So you can divide these zones for the purpose of checklist from aortic arch, look at the origin of the arteries, whether it's a type 1, type 2, or type 3 aortic arch, then the great vessel origin, then you have this carotid bifurcation region or the stenting zone. Look at the stenosis, percentage of stenosis. It is eccentric plaque, concentric plaque, whether it's calcified, non-calcified, whether ECA is also involved or not. If ECA is also involved, tightly stenosed, my suggestion is don't use closed cell design, don't use membrane layers stents, otherwise you will end up occluding the ECA. So then, yes, cerebral vessels, whether there is any tandem lesion, like whether there is associated ICAD or not, based on that you have to decide your own strategy. So, arch anatomy, calcium, angulation, presence or absence of a tendon lesion, and this is very important, collaterals. What do I mean by collateral? Suppose the artery, target artery is left carotid, the A1 is absent on the left carotid, and the A2s are coming from the right side. So which means that when you are doing balloon angioplasty, right, the patient is having flow exclusively into the MCA. So during that momentary phase of balloon angioplasty, you are cutting off the flow to the middle cerebral arteries, and there are no other collaterals. So which means that you have to keep your inflation balloon to shortest minimal possible time. So less than 20 seconds, you just inflate and close, deflate quickly. So that is the implication of having the knowledge about the collateral status. Yeah, we put our all patient on dual antiplatelets. So drug choice is aspirin, clopidogrel. If the patient is known resistant to any of the drug, you can change to the other drug. But my experience tells me that some of the drugs like prasugrel, if it is used in patients who are older than 75 years, have more hemorrhagic complications. So be judicious in choice of your dual antiplatelet agent. It's better to go with the known devil rather than going with the unknown devil. So rest of the things are rarely required. Yes, all our procedures are done under local anesthesia, but under the supervision of the neuroanesthetist. What does it mean? That the anesthetist is sitting not on the console, he's standing right beside you. And he has loaded 2 vials of atropine, 0.4 mg, because when you inflate the balloon, patient may have bradycardia, patient may develop hypotension. If the collaterals are not good, patient may develop watershed territory infarct. So this is the time when you have to ask your anesthetist to inject the atropine. So that is very important. Of course, this you select your best projection where it unfolds the bifurcation. In my opinion, lateral is the best because it hardly obscures the internal carotid artery. So you can generally choose lateral view, but AP view, if it is there, you can make a little bit oblique to clearly visualize the bifurcation area. These are the steps, like those who are fond of using embolic protection device. If the percentage of stenosis is very, very tight, then you need to pre-dilate that with the help of the 2 millimeter angioplasty balloon to just place the embolic protection device. Then, of course, you can take a 3 millimeter, 4 millimeter balloon, angioplasty, deploy the stent. If the percentage of residual stenosis is more than 30%, those patients require post-stent dilatation. So you take a balloon which matches with the size of the normal artery, 5 millimeter generally is sufficient. Some people take 6 millimeter balloon, but I prefer 5 millimeter balloon because that's the average size of the carotid in Indian subcontinent patients. So stents, closed cell, and open cell design, I think is your choice. And I've already highlighted this, what is the appropriate stent. It depends on the artery anatomy. Yes, there are some advantages, pros and cons with both open cell as well as closed stent, and these are highlighted here. But I think the closed cell have a better radial force, but it will occlude the external carotid artery ostium, so that is one drawback. And in a very loopy artery, it will straighten the artery. So we have to be very, very careful in deciding the choice of the stents. So I'll skip this. Now, coming to the steps, all procedures are done under roadmap. First, we cross the lesion with the wire. Wire is generally J-shaped in order to avoid direct intimal injury. That is one first step. Park your distal end of the wire close to the base of the cranium, and it should always be visible under the roadmap guidance. Then you take a balloon. Usually I take a 3 millimeter balloon, sometimes 4 millimeter balloon. I dilate, and then I deploy this. This is the balloon dilatation, and then deploying the stent. And post-stent balloon dilatation is what is shown here. Some of the complications, yes, commonest is thromboembolic complication, but the most dreaded complication is the hyperperfusion bleed. And some literature do mention about the predictors of the hyperperfusion bleed. Yes, the collaterals are not good. If there is a large infarct or if the infarct is very, very fresh, these are the subgroup of patients who can develop hyperperfusion bleed. But more than that, I think some of the patients are hyper-responders to some of the dual antiplatelet agents. And some may overreact to the anticoagulation that we give on table, especially the heparin. So those are the patients, if you give too much dose, I think you need to reverse it immediately. Otherwise, 5,000 international unit, 2,500 first in the initial, and then later on you can repeat the bolus of another 2,500 international units. So this is what we do, and we maintain the infusion in the heparin in the infusion drips. So the other is a dissection, right? So dissection, if it is happening, you have to balloon angioplasty. If there is an instant thrombosis, you can give a ReaPro and lyse the thrombus and treat accordingly. So let's move on to this is the checklist, right? Just keep in mind, you have to follow each and every step if you want to avoid or minimize the complication. So I'll go with some of the examples, how I do it. This was a patient who came to us in 1996. He had a many comorbid condition. In 1994, we were not doing stenting, so the patient was operated on. And unfortunately, the left carotid completely thrombosed post-surgery. But fortunately, he improved because there were good collaterals through ACOM and PCOM. And this patient came to us again in February 2003. So 7 years later, he came to us. And this was the initial angiogram. It showed that the right-sided carotid artery hardly has any stenosis. Left side was symptomatic, significantly stenosed. There were good collaterals from the ACOM and the PCOM. As is seen here, the ACAs are filling from both the sides. And this was the post-surgery angiogram. You can see this is the stump of the left common carotid artery. We did an aortic angiogram. The left common carotid was completely occluded. This was the right carotid. Then there were good collaterals to the other side through the PCOM also, so the patient improved. Again, to come back to us in 2003 with fresh symptoms from the other side. So this was the only artery which was supplying the contralateral hemisphere. So it was a precious artery, and we wanted to protect it. So we went ahead, and then we deployed a stent, post-stent balloon dilatation. This was the final outcome, and the patient did well. After that, the patient continued to come to us for a follow-up. So 2007, 4 years later, he came to us. The artery was fully patent, and the left common carotid artery remained occluded even then. Then he continued to come to us. Every year we were having follow-up in this patient. On Doppler in 2013, he underwent CT angiogram. So you can see now, 10 years down the line, the stent is still patent, and 20 years down the line, the stent is still patent. There is no evidence of any intimal hyperplasia or restenosis. So this case is very unique because we have a follow-up of almost 20 years. The major concern that have been expressed in the literature is the development of restenosis in a stented patient. So this is another patient, 83 years old, had too many comorbid conditions. There was watershed territory infarct in both the hemisphere. This was the artery looking very ugly with ulcerated plaque. This was another contraindication for stenting because the fear was accidentally going into the ulcerated plaque and causing distal embolization. But if you are very cautious in your approach, like what I do in this situation, the wire is generally a U shape here. You can see there is a U shape. So this will not enter this ulcer, it will go straight into the distal ICA. This is what I do. And this is the final run. There was no complication. Patient did extremely well. So another example, you can see here, I think this wire loop is very important. If you make a wire loop like this, it will not enter the ulcer. So this is what the message which I want to convey. Now this is example which you see it carefully. There is a stenosis. This was with the diagnostic catheter, the Picard. And interestingly, the distal ICA was coming through the ophthalmic, clearly seen here. So we are not sure whether this artery is completely thrombosed in the mid segment, or there is a fresh thrombose, or there is a chronic thrombose. But we decided to go ahead and give a trial. So we were not sure whether we were going to succeed or not. But interestingly, after we placed our guiding catheter, see, this is the large bore guiding catheter, the ICA stopped filling completely. So now where is the ostium? Yes, faintly this was the ostium, very thin, thread-like. And to place a wire here is extremely difficult because the artery is pulsating and the wire tends to go into the external carotid artery rather than going into the internal carotid artery. So generally what I do, I take a guiding right up to here and then take a microcatheter. This, you can see the microcatheter here, and with the help of the wire, I just cross it. Then I make sure that I'm in the main lumen of the artery, and the distal artery was filling. So distal artery was filling, so I was sure that the mid segment was a false localization, and we should balloon dilate that. So this is what I did. Here we did a balloon angioplasty, and immediately after the balloon angioplasty, now you can see a good distal runoff right up to the intracranial circulation. So we deployed a stent. This is the stent, and finally we finished the job, and it was a quite rewarding result. Now, calcified plaque, another very debatable issue about the contraindication for stenting. Well, I try to differentiate into two. If it is a dense, heavily calcified plaque, which is concentric. Concentric means the calcification is all around the wall of the artery. Those are the subset of patients which should go to the CA. But I have done few of them with stenting. I didn't post-dilate. I followed them subsequently, and these stents, they are self-expanding, they are oversized. Slowly and slowly, they will expand over a period of time. So you don't have to force post-stent balloon dilatation in this case. But if it is eccentric, involving one of the wall, you can easily do a stenting. So this is one patient where the calcification in the posterior wall, and the artery is little tortuous, but yeah, you can see the calcification here. Here you can use a closed cell design. You can straighten this artery by putting a closed cell design. This is what we did. We pre-dilated, we deployed the stent, and this was the end result. The artery loop has got straightened up. So sometimes it's better to use a closed cell design because you want to straighten the artery. And there was good flow into the intracranial circulation. Now, post-procedure, yeah, I've already said that patient is monitored in the ICU. We maintain the mean arterial pressure to 80 millimeter to 100 millimeter mercury. Then we don't allow the hypotension or hypertension. If there is a hypotension, we withheld the antihypertensive drug for 1 to 2 days. As the BP starts rising, we reinstitute the antihypertensive drug. This patient needs to be monitored because once the patient are off antihypertensive, they can suddenly have a shoot in the blood pressure and cause hypoperfusion bleed. So you have to be very, very careful and closely monitor this group of patients. So I think these are my experience. We have treated more than 979, but these are the patients where we have a follow-up of at least 90 days. And most of the patients are symptomatic. Complications, we were having only 21. Most of them were minor, and they improved subsequently. The trials have been highlighted beautifully by the previous speakers, but what I want to say that most of the trials are not in favor of angioplasty and stenting, and they are more in favor of a CA. And that is because the experience of the previous operator was not good, but as the experience of the interventionists is growing, I think we are in a much better position now, and now trials are almost giving up comparable results. So The most important thing is the age of the patient. Any patient who is above 70 years is likely to have more stroke from the stenting arm rather than the C arm. So if you are not very versed with the navigating the aortic arch, which is tortuous, I think you should give it to the surgeon for the CA patients. So these are the meta-analyses which are giving quite positive results, and some of the data which says that the even with unprotected balloon angioplasty and stenting, you can have a very good outcome. So with this word, I will end my talk by concluding that stenting is quite promising, especially in those patients which are high risk. But yes, if the patient is for CA, he wants to opt for a CA, I think it's the patient's first right to opt for CA. Unless there is refusal from the patient, you should not do a stenting. And in younger patients who are less than 70 years, I think stenting has proven its role. So with this word, I will thank the organizers for giving me a patient hearing. Thank you very much.
Thank you, sir. Any questions?
I don't do asymptomatic carotid. Only when the patients come with TIA or some minor symptoms, if the plaque is unstable, like as disclosed with vessel wall imaging, only in those group of patients we do stenting. 30 to 40% I pre-dilated, but only when it is very, very tight, it's difficult to cross the delivery system, then I pre-dilate. Generally, if the percentage of stenosis is, for example, 70%, I don't pre-dilate. If it is more than 85%, I pre-dilate. And post-end dilatation, I see the run, I do a check shoot and see. If the residual stenosis is less than 20%, I don't post-dilate. Yes.
Towards radial, and also you don't use filters, embolic protection devices?
No, I don't use embolic protection device.
So you feel that they have no role?
See, there is no randomized trial which shows the superiority of balloon protection without balloon protection. But one subgroup analysis in the randomized trial, the SPACE trial, has shown that those which underwent stenting under protection, they have more thromboembolic complications than the unprotected one.
But the CREST-2 trial, which is being quoted by most of you, has a protocol that there is a distal embolic protection device.
Yeah, that's right. So I think there is a tendency to use a protection device. But those who are very, very experienced centers across India, they are not using any balloon protection.
Any experience in opening a chronically occluded carotid? Indication or experience? Chronic carotid occlusion.
Completely occluded?
Occluded for a long time.
So I don't do which is chronically occluded, but if it is acutely occluded, I do intervene.
Benzel?
We did this vessel wall imaging in this patient. We saw fresh thrombus. So that was one of the reasons why we went ahead and did an angioplasty and stenting.
So thank you, sir. Can we just have the memento before we break for lunch?
So for our ceremonies, I would like to call upon Dr. K. Satyarao sir to present the mementos to the speakers. So I would like to welcome Dr. Karunakar Padi sir onto the dais to receive his memento for his talk on carotid endarterectomy.
Professor Satyarao, sir will present the memento to Dr. Karunakar Padi.
Next, I would like to call upon Dr. Shailesh Gaikwad sir to please send. Dr. Satya Rao sir. One more memento for Dr. Shailesh Gaikwad.
It should be loud and clear. Professor Satya Rao sir will present it to Professor Shailesh Gaikwad sir.
Thank you, Satya Rao sir. Now I would like to call upon Dr. K.V. Lu sir to please get on the stage and present the mementos to our chairpersons. I would like to call upon Dr. G. Bujiraju sir for his patience with us in the morning. Next, I would like Dr. K. Vilu sir to present memento to Dr. K. Satya Rao sir, who was our moderator for this session as well as a speaker earlier in the morning. Thank you, sir. Now I would like to call upon Dr. Dalai sir to present the mementos. So we would like to call upon Dr. V. Sujata madam to receive the memento from Dr. Dalai. Next, we would like to call upon Dr. R. Lalita madam to receive her memento from Dr. Dalai. So this ends the ceremonies for right now. Let us all break for a short lunch and get back.
differential diagnosis in this category because the management of individual diseases are totally different as compared to eye care. So prompt recognition is very important so that you are in the right pathway of management. Vasculitis, as we all know, vasculitis has a typical clinical profile, typical investigational studies, and imaging also has a typical findings, may involve multiple intracranial arteries. It depends on the etiology. There are various etiologies which can cause vasculitis, from inflammatory infectious to even the drug-induced vasculitis are known. But typical imaging findings are we see the multiple cortical infarcts, microbleeds, and then the vessel wall imaging, which I will be showing you cases as well. There are typical imaging findings. And dissection, we have a characteristic angiographic appearance, the demonstration of intramural hematoma, the morphology of the dissection in angiography, all are very, very classical. RCVS is another important DD, but clinically they are very classical. They present with recurrent thunderclap headache, which is known as pathognomonic clinical sign, with or without convexity sulcal SCH. If you do angiography, you get multiple medium vessel or a large vessel, sausage type of narrowing, sausages we call it, arterial sausages. And moya disease, we all know how the typical imaging pattern, the moya collaterals, basal collaterals, choroidal, ethmoidal, dural, all those can be characterized. So we should know the morphology, both on imaging as well as clinically, how they present. And coming to the imaging modalities, there are three important imaging modalities in the intracranial circulation. One is high resolution MRI, which is gaining a lot of popularity in the form of vessel wall imaging, IVUS and OCT. And like these IVUS and OCT have a lot of work done in coronary field, but we don't have current available dedicated OCT devices for our intracranial circulation. But the current studies, whatever has been done with respect to intracranial vessels, is by using a 21 catheter of OCT, which is known as Dragonfly, which they use in coronary. And OCT has shown to have a better imaging characteristic as compared to IVUS, because they use a coherent light from an intraarterial catheter to perform three-dimensional imaging of the vessel wall. Likewise, the use of high-resolution MRI has helped better characterization of the plaque and active inflammatory activity, as well as anatomical relationships to the adjacent perforators. We can go and see the morphology of the plaque, like whether it is vulnerable factors like fatty rich necrotic core, what is happening to the fibrous cap, whether it is continuous or discontinuous or thin, and is there intraplaque hemorrhage, is there inflammation in the form of enhancement of the plaque, which are all the vulnerable factors can be assessed using vessel wall imaging. So if you look at this, this is a narrowing in a vessel which may be due to anything, but if you do a vessel wall imaging, better appreciated in nowadays 3 Tesla MRI or higher magnetic Tesla, the eccentric enhancement, unlike a vasculitis where we see a concentric vessel wall involvement, multifocal involvement, adjacent multiple cortical territory infarcts or microbleeds. If you see this is isolated eccentric vessel wall, active plaque sign, and there is adjacent subacute infarct which is also enhancing there. And this is another vessel wall imaging of a vasculitis patient. You can see this concentric type of enhancement, typically rim-like enhancement and adjacent subacute infarct which is enhancing there. This is how typically vasculitis looks as compared to atherosclerotic plaque, which has eccentric plaque with an enhancement there. And this is another interesting entity which we are noticing nowadays, which was initially described in pediatric age group, focal cerebral arteropathy of childhood, but we often see even in young adults, especially post-COVID, we could see so many cases of focal cerebral arteropathy. They have a very characteristic imaging pattern. They involve terminal ICA going all the way to proximal ACA and MCA in a Y configuration. And if you do a vessel wall imaging, high resolution vessel wall imaging, you see this thick rind of enhancement, very thick enhancement, starting from the terminal ICA going on either side in a Y shape. This is very, very characteristic. They have their self-limiting pathology. Initially, they progress for a period of few months and they mature and remodel. In between, they may have a recurrent strokes. Post-COVID focal cerebral arteropathy, there are more than 10 to 20 publications after COVID. So we should all differentiate. Because of this typical location and morphology, we are able to identify focal cerebral arteropathy. The steroid treatment is a mainstay, but it's also a controversial. There is currently no treatment exists for this as per the guidelines. So coming to atherosclerosis, the first initial notification of this atherosclerosis was done by Thomas Williams way back in 1664 in the autopsy specimens. Then the imaging came into the picture in the form of angiography, then started by Egas Moniz in 1927, then CT, MRI came, then the trial started. The first trial was VASI trial, 2005, then the SAMPRIS in 2011, VIV registry published in 2019, then the last one, the recent one was the CASIS, which I will go through individually. Only the brief introduction, because we have to know these important trials, landmark trials, so that why we failed and what we can do in future. If you see the VASIT trial, this is the first randomized trial for a symptomatic intracranial atherosclerosis involving more than 569 patients. And warfarin versus aspirin was compared, and it was obviously found that warfarin is associated with more significant complication, 9.7 versus 4.3% in the aspirin control group. And the dose used in aspirin was very surprising. It was 1,300 milligram per day in this study. It was very high. And aspirin should be preferred over the warfarin for patient with intracranial atherosclerosis. This was the first trial, followed by SAMPRIS, which led a setback to the endovascular therapy in 2011. It was a multicentric prospective RCT involving around 451 patients using a first generation device known as wingspan stent system. And it included all those who are symptomatic patients with more than 70% stenosis with the recent TIA or non-disabling stroke patients. And with this, if I summarize this, if you see that results of this, 30-day and 1-year stroke and death rate was 5.8% and 12.2% in medical management, as compared to stenting group, where 30-day and 1-year stroke or death rate was 14 and 20% respectively. So because of this, we had a setback, and there were several publications after SAMPRIS. Is the SAMPRIS very practical? Can we replicate in the real life? And so many publications came into the picture. One of the article which I am quoting was published in 2016 April in the Green Journal of Neurology. If you see this, these trial patients had a lifestyle coach to teach them how to do a lifestyle modification. They were provided with free drugs. They used to do an aggressive follow-up every 2 weeks and strict medical management. And this could never be replicated in real lifetime. As a result of this publication, it says that in real world, there are so many studies where aggressive medical management in symptomatic ICAD yielded higher stroke recurrence rate at 30 days as compared to SAMPRIS. So this could never be replicated. And why SAMPRIS failed? It was analyzed why we failed in this trial. Because if you see so many factors, heart plaques are when the plaque is in its inflammatory stage, especially in the first 7 days of the acute event or the index event, most of the cases were taken for intervention. And operator experience was not considered in this trial. Most of them were inexperienced or had no earlier experience. There was a lot of snowplow effect was seen, and which contributed to the chunk of complications, because these M1 and mid-basilar territory vessels were intervened often. And first generation wingspan stent had a lot of exchange system, which is causing a lot of complication due to wire perforation distally. So inadequate antiplatelet and inclusion of off-label patients were another reasons why it would have failed. And then came into another trial as a desperate measure. There's a VISIT trial. This is the first randomized control trial comparing balloon-mounted stent treatment with the medical management. Earlier, since the wingspan failed, they tried a balloon-mounted stent. And if you see this, even this trial also failed, because the 30-day and 1-year stroke and death rate was 9.4 and 15.1% with the aggressive medical management arm, as compared to the intervention arm, which was 24 and 36% respectively. So it was 2 to 3 times higher, both the stroke and the mortality rates. And then another changeover is the VIV and the Woven trial, which came in 2019 and 20. This was a wingspan 1-year vascular event and neurological outcome trial, Woven trial, which reported a sustained benefit after the stenting group. What they did was they corrected some of the factors where they went wrong in the SAMPRIS. If you see the timings, the mean time of intervention in SAMPRIS trial was just 7 days, as compared to 22 days in the VIV trial. And even the operators were experienced interventionists, and rigorous patient selection protocol was used in V-event O1 trial. As a result of that, the event rate was very less than it was approximately 2.6% complication rate, that's all. And why was this? Because of highly experienced operators, no patient only with TIA or vertebrobasilar insufficiency without stroke were taken. They were all symptomatic stroke with more than 70% stenosis. Pre-medication was followed 5 days prior. Best practical techniques were used, like control of exchange wire, use of support catheters, use of vasodilators, how we do nowadays, submaximal angioplasty under general anesthesia, aggressive peri-procedural BP management and procedure. After minimum 8 days of the index event, ideally around 3 weeks was all considered, and it led to a better outcome. But finally, this is another trial which got published in 2022, which led another setback to us, which is known as CASIS trial, which was done in China. It concluded that the findings do not support the addition of percutaneous transluminal angioplasty and stenting to medical therapy for the treatment of patients with symptomatic severe ICAS, which was published last year. It also, the immediate complication rate was not much, it was comparable, but 3-year mortality and stroke rate was much higher in the intervention arm as compared to medical arm. So this was again another setback which happened. So coming to the technique, how we do and what we do in clinical practice, there are mainly 3 types of endovascular techniques available to treat ICAD. One is balloon angioplasty alone, balloon mounted stent, and the self-expanding stents. Each of these has its own features and a specific advantages relating to different intracranial artery lesion and location. Another important thing what we should not forget is intracranial arteries are not same as the extracranial or arteries elsewhere. They have thinner walls, thinner muscular layer, no external elastic lamina, hardly any vasovasorum out in the adventitia. So aggressive dilatation is prohibited, unlike what we do in cardiac procedures. So we should be very cautious in intracranial circulation. Talking about this, continuing with this, submaximal angioplasty is another technique what we safely can do in these cases, because there is a lot of work to be done and studies to be done with respect to submaximal angioplasty. Angioplasty to be performed with a balloon undersized approximately 80% of the non-diseased diameter, and submaximal angioplasty limits the risk of thromboembolism, vessel perforation. Often the disadvantage is that many cases, often they result in elastic recoil, restenosis, dissection, and thrombosis, ultimately leading to stenting, because we should have a stent as a backup. But there is an interesting study which did a meta-analysis comparing 9 submaximal angioplasty studies. Totally around 408 patients were studied, and they had a very less peri-procedural risk, both long-term and short-term, together accounting for less than 5% of complications. So the experts say that submaximal balloon angioplasty should be tested against medical therapy, and how we tested against the stenting. See, this should also be put to the test against medical therapy in future randomized trials. This is one more suggestion to go forward. And nowadays, drug-coated balloon percutaneous transluminal angioplasty is coming. Most of these are coated with paclitaxel, which is highly lipophilic mitotic inhibitor. And similar to the angioplasty, because if you see the balloon technology, it is much softer because of the softer tip, and it thus enabling the operator to reach more distant lesions as compared to the drug-coated stents. And research studies have demonstrated encouraging results with low complication and restenosis rate. However, currently there is lack of prospective data with regard to long-term results. This is where the work has to be done. And a lot of self-expanding stents were also tried, especially the Wingspan, which is currently the only FDA-approved stent for ICAD. Over-the-wire system disrepute is mainly because of Sampris trial. As compared to the balloon-mounted stents, self-expanding stents are preferred for smaller vessels with larger ICAD lesions. They can handle tortuosity in the landing zones better, and wherever the vessel size mismatch is more, this is the device what we prefer. And another system is Neurospeed and Credo, because the advantage is that you can do angioplasty in the same balloon, you can just deploy the stent and come out. But there are no much studies. The largest study what I could get was 76 ICAD patients with this new generation stent system, and with a peri-procedural complication rate of 6.5%. So this is the best what they could achieve in this. And coronary stent, yes, very good, very attractive, because they are drug-coated, less restenosis rate, precise placement, cheap and easily available, but unfortunately they are not so easy to track in the tight curves. If you see this trial, which was published in 2022, they have compared drug-eluting stent with a bare metal stent which has got a very good, impressive result. There was total of 263 participants in this prospective RCT, and 1 year instant restenosis rate was lower in drug-eluting stent as compared to balloon-mounted stents, and drug-eluting stent group had a significant lower ischemic rate at the end of 31 days to 1 year, 0.8 versus 6.9%, very impressive data here. So how do I do the ICADs? The ICADs, when I select a case, I see that the patient is more than having a symptomatic stenosis with more than 70%, and all patients should be symptomatic and completed the medical management for the minimum period of 6 months. They should have failed this medical management, and post-acute stroke of at least 7 to 10 days, and non-disabling and non-hemorrhagic strokes will be selected. Dual antiplatelets at least 5 days before to the procedure in elective case, and sometimes in emergency we load them a couple of hours before, and preferably my antiplatelet of choice is ticagrelor and aspirin. Now we have shifted out from the clopidogrel. And if the ICAD is in the perforator-rich territory like M1 or mid-basilar, I will be very cautious. If I have to use, I will use a self-expanding stent or balloon-mounted stent. And a bedridden patient with a severe debilitated patients of MRS more than 3, we will not take them for any interventions. And timing is very important. At least many trials have shown that the Sampris failed because of they intervened in acute phase. Because the acute plaques are very vulnerable, they are highly inflammatory and thrombogenic, so it is more likely to cause embolic events and perforator infarction with angioplasty. And also another risk is, if you do emergency endovascular, is the reperfusion hemorrhage if the core is very big. So how do we plan? We do a DSA, preferably 3D DSA, which are, if you don't have that facility, if you have a good quality CT angiography, you can do that as well for planning your procedure. Review the MRI images before you do all these things. Try to understand what is the mechanism of stroke in a given patient, and plan this. What is the access you require? What is the length and extent of the plaque? How is the calcium? What are your landing zones? And then decide on the type of balloon and the stent you select. Preferably do it, all the cases will be done under general anesthesia. We get most of the time cardiac and physician clearance, because all these elderly patients with multiple comorbidities need to be given a clearance and fitness for the procedure. And I load them with a ticagrelor 180 mg and aspirin 325 mg previous night. And then the maintenance dose will be 90 mg BD and ecosprin 75 mg OD for next 3 months to 1 year. In acute stenting, if suppose I am not anticipating, but I get a ICAD when I am dealing with acute stroke, then I open up the vessel, I infuse a tirofiban, 2B3 inhibitor, and load the patient on Brilinta and run the tirofiban for 3 hours, because my Brilinta will start acting as early as 2 hours or maybe quicker. So I have to protect the stent during that time. And also, if the submaximal angioplasty is done without a requirement of the stent, I run a tirofiban, and then I load the patient with dual antiplatelets after a check CT. So always keep a long sheath and a distal access catheter, which will be helpful in ICADs to give a good support. Pre-plasty with undersized balloon, and wait and watch, and then see and do a stent based on the lesion, whether it is balloon or stent, self-expanding stent. Post-plasty only if it is required. Generally, I avoid post-plasty, and we wait on table for 15 to 30 minutes to see any instant thrombosis. And on table, after once it is okay, then we do an on table CT, high resolution stent CT or a vaso CT before extubating the patient. If you see this example, the deep watershed infarcts, I know that it is a hemodynamic insufficiency, so it has to be corrected. So angiogram showed there is a tight narrowing here above the ophthalmic artery in the supraclinoid segment. This was and this was calcified as well densely, so we had to use this one fibrous plaque was there, sorry. And we have to use a balloon mounted stent to open this. This is another case in the proximal basilar artery, a tight stenosis. This patient was put on medication, dual antiplatelets, was resistant to clopidogrel, changed on to Brilinta. Still he came with recent infarcts. So we considered taking this patient for the intervention. And this patient, we used a self-expanding stent. You can see the stent nicely deployed. We did a submaximal angioplasty and put a stent there. And this is the pre and post procedure. I will show you the follow-up of these cases once. Sometimes what happens is we land up in acute LVO and with the underlying ICAD. And how do we manage? Because at least 20 to 30% of these cases are this. We have an underlying ICAD. Once we open a vessel, we see that there's a plaque there, and then the challenge starts. So we do a standard protocol, either aspiration or stent retrieval or combination of them. Once we expose that and take out the clot, we see underlying plaque. As typically it closes again and again, as we all know. We try to do a tirofiban infusion and see that whether it holds on. If it doesn't hold on, we do a submaximal angioplasty. If still it is not holding on, then only we do a rescue stenting. Otherwise, we try to avoid a stenting in the acute phase as much as possible. But we have to wait for a long time on the table. And this is another case, like typical case which came with the basilar syndrome, like patient had a evolving infarct in the right half of the pons, and the patient did an angiogram, and there was hardly any flow in the basilar artery, and the patient was going down. He arrested in MRI, was resuscitated, and then intubated and taken to the cath lab, and there was hardly any infarct. And when we went through the femoral artery, there was a tight 360-degree loop which could not be navigated on the left side. So I went through the radial artery because the right vertebral was not visualized, and I could hook the right vertebral artery and went and saw, and there was occlusion at the basilar top as well as the stenosis in the proximal to the occlusion. And this was, you can see there, there's a plaque, There's a plaque there, and there was an occlusion in the basilar top, artery to artery embolus, and occluding the basilar top there. And did a standard stent retriever, took out the clot, and then it revealed the underlying tight plaque there, which was not holding on with the balloon. At that time, we don't keep self-expanding stents in the shelf, so I had to use a drug-eluting stent at that moment. And this was the picture at the final picture. This was the stent what we used. And you can see that post-procedure CT was looking good, and the patient was extubated next day, and he was doing very well. And he's on follow-up, his MRS is 0. This is how we salvage in many cases. This is our day-to-day problem. And complications, what do we expected in ICAD stenting is IC bleeds, both iatrogenic and antiplatelet related, dissections, distal embolic strokes, no flow phenomena related to branch occlusion, instant thrombosis, instant stenosis, and access related challenges. I will show you one case, that case which I showed initially, to a similar case. This patient stented with a self-expanding stent, sent home. He was very good. He was called for the 6-month follow-up. But he started developing new symptoms in spite of on dual antiplatelets. Whenever he used to stand up and cough, he used to collapse. There was a posterior circulation insufficiency. When we called him and did an angiogram, the stent was occluded. There was no forward flow. Whatever was from the PCOM, it was reforming, but it was not sufficient. So it was a desperate situation. Patient was very well preserved, no new infarcts, but symptomatic. Every time he used to stand up or cough, used to collapse and fall down, and again, he was almost wheelchair bound because of this. And what we did was we had to make a J shape, and crossing the occluded stent is very difficult and tricky. We had to make a real U shape of the wire and cross that stent, which was self-expanding stent, and then we deployed a balloon mounted stent so that it is overlapping each other and could open that. And this was salvaged, and the patient was salvaged in this manner. And we see that in our practice, at least 30% of self-expanding stents do have a restenosis in the follow-up. This is another big challenge for the ICAD. So where do we stand as of now with respect to ICAD? The treatment of symptomatic ICAD remains challenging with recurrence rate of up to 20 to 38% as per the literature, despite the best medical management. And endovascular treatment of symptomatic ICAS has been facing controversy since the publication of SAMPRIS trial, followed by VISIT, and now due to CASIS trial. Current guidelines recommend best medical management, a combination of antiplatelet therapy and vascular risk factor control as a first-line therapy, with endovascular therapy considered as a rescue therapy. So this is where ICAD, we have yet to conquer. The aggressive medical management is somewhere in the middle, and we are still in the bottom. And how do we improve our outcome? Probably by strict patient selection criteria, understand the underlying mechanism of stroke, timing the procedure, not in the acute phase, and look at whether you are dealing with the perforator-rich territory or not, and plan accordingly, anticipate the complication, and have alternative plans. And In future direction for ICAD, probably advanced plaque imaging give us good insight. Trackable and surface-coated endovascular devices may be the answer in future. Personalized treatment strategies, looking for novel serum and imaging biomarkers for this ICAD, and targeted clinical trials to understand the pathogenesis and treatment. These are the possible work where we can do with respect to ICAD. So thank you so much.
Thank you. It's a very nice job, and for the ICAD in our center and in our experience, we're using all type of stents, including balloon-mounted and self-expandable. And the lessons learned from the Sampris trial, if there is a perforators, usually it's mid-basilar and the M1, M2 segment. We try to use self-expandable stents with the submaximal angioplasty. And yes, self-expandable stents, mostly we see restenosis.
Yes.
And the other solution is drug-eluted balloons for the repeat angioplasty.
Yeah.
And surprisingly, the segments excluding basilar and the M1, M2, there is no perforators, and you can use any stent, and usually it's very safe. And for the young colleagues who is planning to do elective intracranial stenosis, our recommendation to start from Petros, cavernous segment stenosis and V4 segment stenosis. It's very safe, and usually it's possible to have complication, but the number is very low.
Yes, yes, thank you.
Hi, sir.
Yeah.
Do you think there is any role of bioresorbable stents, coronary stents? Because the self-expanding ones are coming back with restenosis.
Yeah, like in coronary bioabsorbable stents in future. Looks very interesting, like in our center, cardiologists are implanting a lot of bioabsorbable stents there. Even the large data in that field also is pending as of now. We always interact because I get a lot of ideas from the coronary stents that we are much experienced with respect to these diseases. So even the large data is yet pending there as per them. But last 3 years they are extensively using this bioabsorbable so that we can stop our antiplatelets and restenosis. I think these are the fields where we can do a lot of research, especially drug-coated balloons, submaximal angioplasty versus medical management, and these bioabsorbable devices.
But Sharat, with the resorbable stents, there is a necessity of 100% of angioplasty. It's only point stopping to use these resorbable stents.
Correct.
And from the coronary experience, we have seen the cases when the stent was resorbed and patient had a myocardial infarction. As in intracranial circulation, there is no systole and diastole, just flow, but the point is 100% of angioplasty is stopping to use these stents.
Okay, thank you.
Sarat, that was a great presentation. So why do you have to wait for 3 hours after giving ticagrelor? Because the half-life is very short. In half an hour time you start working,
No.
and 1 hour time at the peak.
3 hours, I run 3 hours infusion, tirofiban, just to overlap between, because we crush the tablets and give through the nasogastric tube, and generally with that technique, even the peak value of ticagrelor reaches by 1.5 hours to 2 hours.
45 minutes.
Yeah. So to be on the safer side, just we overlap, that is a protocol. I have seen like, we have stopped at 2 hours also. Once the CT, post-procedure CT looks good and decent, we generally just try to be cautious side rather than that. I agree with you, as per the theoretically, we can stop as early as 2 hours or lesser than that tirofiban infusion. Agree.
What we do is, in case, for example, we have to do an acute stenting, and cardiology department also, if they have to do a primary stenting, they give ticagrelor, and in half an hour they deploy the stent.
Yes, yes, yes.
So they might be having those evidences, which I don't know. But our practice is whenever we are treating a stroke and we have to do a concomitant stenting, which we do quite a few. So we load the patient, and in 45 minutes we deploy a stent, whether it's a carotid or intracranial.
Yeah, by the time it will be acting there.
Yeah, and we don't give additional tirofiban, thinking that it might bleed also.
Yes, agree.
I just wanted to ask some technical thing, that this credo stent and that neuro balloon comes, that balloon is not very good, it doesn't open our atherosclerotic plaques very well.
Yeah,
So
it's
what
like
other options you use?
It's a semi-compliant balloon like any other coronary balloon. We have used in couple of cases. It's good because it avoids our exchange system. That's the main reason why we use that balloon. Till now, there is no technical challenges with that as of now for us. We have used in M1 and basilar artery as well. Most of them are in M1. We just dilate it and then deploy the stent. It generally does well till now. In only one case, we could not, after plastic did not open, we had to take it out and do other balloon plastic and then exchange it. But in other all cases, it has done well till now. Otherwise, we take it out and then do a conventional treatment.
One more strange experience I have, I don't know like how many people understand that. Basically, whenever we have mid-basilar or basilar, proximal basilar, we prefer a coronary stent over a self-expandable stent all the time. The reason being, I have seen that whenever we put a self-expandable stent, the dilatation or approaching kind of lumen is not adequate, at least visually.
Correct.
And taking a coronary stent is pretty easy instead of like compared to a M1 or beyond.
Yeah.
So that has been our preference, although there is no evidence to.
Yeah. Except in M1 and mid-basilar, we have always used drug-eluting stent elsewhere in almost all the places.
Great.
And Sharat, you showed the case with V1 segment kink with coiling.
Yeah.
And you tried to avoid this and went to the contralateral side. The lessons learned from René Chapeau in V1 segment, it's possible to cross with the coronary wire 14, and when you send the wire to V3 segment, it's straightened and it's very safe to cross with the 6 French guiding catheter, and in some cases, in a purpose, we are placing protege stent from subclavian to V2 segment, and usually it's very helpful.
Yeah, true. We can do that.
From a neurologist perspective, I think all patients with stroke, because the intracranial atherosclerotic disease is quite common, along with routine MRI, imaging of the intracranial vasculature is very important to detect the intracranial disease because it has treatment implications. Because the recurrence rate is very high, so the duration of antiplatelet therapy in intracranial atherosclerotic vascular disease is much longer, that is 3 months, compared to the extracranial disease, which is usually about 3 weeks. And then very aggressive management of the risk factors, which Dr. Sharat Kumar highlighted. So they are very important because it remains the cornerstone of the treatment of intracranial atherosclerotic disease. I think Dr. Sharat Kumar, thank you very much.
Thank you, sir.
You have highlighted the very importance of medical treatment and then dual antiplatelet therapy and then aggressive management of vascular risk factors. Thank you.
Thank you, Sharat.
Thank you, sir.
So,
thank you, Sharat Kumar sir. Now I would like to invite Dr. Jenny Gandhi ma'am to discuss few of the complex case scenarios that she has gone through.
Dr. Jenny is consultant interventional radiologist at Salvi Hospital at Surat. She's doing some fantastic cases of late, especially those intracranial arteriovenous malformations and aneurysms are quite impressive. So let us see a couple of great cases that she has done.
Good afternoon, everyone. Thank you, Siva sir and the entire ISNR team for inviting me for sharing my experience. Today I'm going to show some complex cases of ICAD, which I have done in past 5 years. Before starting my presentation, I would like to continue the discussion which was going on with Dr. Sarad sir and the entire team, that we take all patients of ICAD who are symptomatic on optimum medical management, but we don't wait for 6 months to complete the medical management. If the patient has recurrent symptoms after starting optimum medical management, at least for 1 month, then we do advise endovascular management. In elective cases, we load patients if the patient is usually on antiplatelet. So we give brilliant, the preferred drug is ticagrelol 90 mg BD and ecosprin 75 4D. But in acute setting, in setting of stroke, if we have to do upfront stenting along with mechanical thrombectomy, then we have stopped giving tirofiban because we have experienced high chances of reperfusion injury. So we give patient on table through Riles tube Disprin loading dose. We do balloon angioplasty. We wait for 1 hour. If we need to put a stent, then Disprin usually starts acting very fast, and we upfrontly put a stent after 1 hour of giving Disprin loading dose. And then we continue with the single antiplatelet in acute setting for at least 1 week to 15 days, depending, it varies case to case. And then up to 1 month, we just give single antiplatelets. Till now, in our experience, all patients are doing good. So now I would like to start my presentation. So whatever cases are being shown here, they all are referred by neurologists of town from a different hospital for the ICAD management. All patients had major or minor stroke in the past. They were on optimum medical management, that is a dual antiplatelet, preferably ecosprin and clopidogrel. In spite of optimal medical management, the patient had symptoms, hence they were referred for the IR management. So this is a first case, a 64-year-old gentleman, onset of stroke 4 days back. At presentation, the GCS was very low. Patient no eye opening, the motor response was M4 and patient was intubated. On MRI, there was a pons infarct and bilateral cerebellar infarct. MR angio, the vertebrobasilar system was not seen. It was out of window period acute stroke, but there was a clinical radiological mismatch. So we counseled the relative and advised for the angiography, SOS mechanical thrombectomy. So DSA was done, left ICA, basilar was not seen, right vertebral was hypoplastic ending into pica, and this is the left vertebral artery. Beyond at V3, V4 junction, it was not seen. So did the mechanical thrombectomy through Solumbra technique, and the artery got open in first pass. So here there was a underlying stenosis which has occluded the artery. So we did balloon angioplasty. We loaded patient on table with Disprin and waited for subsequent 5 minutes, 10 minutes, 15 and 30 minutes check angiography. The stenosis was holding, there was good forward flow. So did not do stenting in acute setting. Did post-procedure MRI, there was no further progression of infarct, there was no bleed. Patient was, and this is MR angio, the underlying stenosis which was there in the V4 segment. So kept patient on Clexine and Ecosprin 75 for 3 days. On 4th day, we shifted to Ecosprin 150 along with Clexine, and from 7th day, patient was given dual antiplatelet. We usually ask patient to come for follow-up at 1 week and 3 weeks. So at 3 weeks, patient had at 1 and 3 week, patient had the symptoms of giddiness in spite of dual antiplatelet. So we proceeded for stenting after 4 weeks, and this is post-stenting. After elective stenting, patient did not have any symptoms of giddiness, and episodes of giddiness and transient numbness in all 4 extremities for past 6 months, managed conservatively by neurologists. Patient was on dual antiplatelet, Ecosprin 150, clopidogrel 150. MR angio was showing the basilar stenosis, so referred for the angiography. On angiography, the right vertebral was hypoplastic, left origin was showing high-grade stenosis, and at basilar also there was a very severe tight stenosis. So patient was advised angioplasty and stenting, but relative did not give consent. So patient was discharged on Brilinta and Ecosprin, that is Brilinta 90 mg BD and Ecosprin 75. 3 days after the discharge, I got a call at midnight that patient which we did angiography, patient had presented with repeated episode of vomiting followed by loss of consciousness. At presentation, the patient GCS was very low. We intubated patient, repeated the MRI which showed the left PCA territory infarct, and the basilar was not seen. Now, because of the poor GCS, the relative got agreed. We took patient for the angiography, and as expected, the vertebral there was a stenosis, and the basilar got completely occluded. Did mechanical thrombectomy through a Solombra technique. The artery got open in first pass. So here, in this case, patient was already on Brilinta and Ecosprin, and in spite of that, patient had a stroke. So we put stent in the proximal basilar. That's a coronary stent, drug-eluting stent, followed by, while coming back. So this is post-stenting basilar, and while coming back down in the vertebral, the second stent was put, and this is the final run.
Can we go back and see that basilar stent once?
Yes, sir. This was.
Right. Take.
Okay.
Next one.
Okay. So the basilar stenting was the first. We did the angioplasty of vertebral origin, then took the guiding up, did the basilar angioplasty and stenting. While coming back, we did the vertebral artery stenting. So the difference in both the cases, the first case was out of window period, that's a 4-day after the onset of stroke. Though there was because there was a radio clinical mismatch, we did a mechanical thrombectomy. After angioplasty, the plaque was remaining stable with good forward flow. So we did elective, we staged the stenting at 1 month. In case 2, patient was on dual antiplatelet, patient had a stroke and the artery got occluded. So we did upfront stenting. Both patients are doing good and discharge normal. It's been 6 months for both the cases. So take-home points. Do not fix a protocol for the stroke or the ICAD. It varies from case to case. Every case is individual and different. Try to achieve optimum result in each cases, avoiding underdo or overdo. Another case, 60-year-old male, recurrent posterior circulation, minor stroke, 3 episodes in 1 year. Patient was on dual antiplatelet. So this is the MRI images, bilateral cerebellar infarcts, right PCA territory infarct. On MR angio, there was a V4 segment. So there was two-level disease. One was at the proximal V4 and one was just proximal to the basilar in the distal V4 segment. So we did stenting at both angioplasty and stenting at both the level. Similar like a previous case, first did angioplasty at the lower level, followed by up angioplasty, then coronary stent distally first and then proximally first. And this is post-stenting result. So multifocal flow-limiting symptomatic stenosis in a single artery can be or should be intervened and managed in the same sitting. Another case, 60-year-old male, history of giddiness, one episode 10 days back, started dual antiplatelet by neurologist. Second episode after 8 days of starting dual antiplatelets. So referred for endovascular management. Patient, I don't have MRI images in this presentation, but patient had a left basilar artery minus, left cerebellum minus stroke. So here there was a V4 segment, very tight stenosis. Just distal to the stenosis, there was a left ICA origin. On the right side, there was a right ICA. On the the other side image, if you can see, this is a left vertebral artery. One artery here, second artery is arising here, and the right vertebral is joining just distal to the stenosis. So initially we thought of putting a self-expanding stent after optimum balloon angioplasty. But like other operators' experience, I do have a similar experience with a self-expanding stent. And here the plaque was eccentric and the left ICA was on the opposite wall of the plaque. So I decided to put a coronary stent, did balloon angioplasty and stenting. This is a post-stenting result. And all arteries are preserved. Another case, 60-year-old male, recurrent brainstem stroke, mid-basilar, very tight stenosis. Both PC were filling via PCOM, fetal PCOM, fetal PCA. Here, balloon angioplasty and stenting was done by a coronary drug-eluting stent. Another patient, 57-year-old male, recurrent minor brainstem stroke, proximal basilar tight stenosis, a coronary stent again, drug-eluting coronary stent post-stenting. 62-year-old male, recurrent minor brainstem stroke, mid-basilar eccentric plaque. On MRI it was posterior and the left lateral wall. So was afraid of perforator infarct. So chose a self-expanding credo stent. This is post-stenting. Patient came back 20 days after the procedure with a minor stroke-like symptoms which he had prior to the endovascular treatment. I got a phone from the patient's relative, asked they told that they have not skipped the dose of medications. So I told them take another 175 mg ecosprin and bring patient to the hospital. We did MRI. There was no acute infarct, but the patient was very sure that I had a similar episode which I experienced before procedure. So they took patient for the angiography. The stent was open, but like the Siba sir told, visually the opposition, the opening of the artery was not optimum like a coronary stent. Patient was kept on Brilinta 90 mg BD and ecosprin 150 in spite of 75. And this patient, then he is symptoms free for past 1.5 years. Another young patient in his 40 presented with recurrent episode of minor stroke in left MCA territory. He had right upper limb weakness and numbness, each time recovered in a day. So he experienced similar thing for past 1 month in spite of optimum ecosprin and clopidogrel. So we did angiography. There was a small focal stenosis in the distal M1 segment. We put a self-expanding credo stent after optimum angioplasty. This is post-stenting. It's been 6 months, patient is free of symptoms. Another case, 55-year-old male, left hemiparesis, the power in the left side in upper limb is 0, lower limb 3/5, and numbness in the right leg. This is the MRI. So patient on angiography, right ICA was occluded from the origin. Left supraclinoid segment had a very tight stenosis. This is the lateral view, this is the AP view. So we have we did angioplasty and stenting. Self-expanding stent was kept. Credo stent was used, the size was 5 mm. Here again, in spite of using the optimum diameter of stent, the appearance of an artery post angioplasty and stenting is not optimum. But this patient is symptoms free we have followed him up very regularly. It's been 1 year and he's symptoms free. Recently, 15 days back, I have done an angiography. There is no restenosis, but artery diameter is same and he's symptoms free. Another case, 48-year-old male, recurrent minor stroke, left hemiparesis, upper limb, lower limb 3/5. So here, the right supraclinoid segment had a tight stenosis. There was a cross flow, but the patient had symptoms, recurrent. So we did angioplasty and stenting with a self-expanding credo stent. This patient presented 4 months after the procedure with the occlusion of the stent. We did balloon angioplasty. Patient was not ready for the second stent. So we just did a balloon angioplasty and left it. So till now I have done total 29 cases of ICAD managed endovascularly. Out of 29 cases, in 21 cases, I have kept a coronary drug-eluting stent. One patient expired in COVID 2 years after the procedure, so I don't have a follow-up. Rest all patients are asymptomatic, doing well angiographically. There is no restenosis and the patients clinically also asymptomatic. 8 cases of self-expanding stent. One patient had a minor TIA at 20 days. Angio shows no restenosis, but patient had minor TIA-like symptoms. One patient had a minor stroke due to stent occlusion, and the 6 patients are asymptomatic. So self-expanding stents was used in all patients in anterior circulation, where there is a mismatch of a diameter of artery at the landing, proximal and distal landing zone, or the tight bend across the paraclinoid segment. All patients of M1 stenosis were treated with the self-expanding stent. In posterior circulation, the self-expanding stent was used where the plaque was at the posterior or the lateral wall of the basilar artery, or the chances of major side branch occlusion is there. So in short, when there is a chances of perforator infarcts or the side branch occlusion is there, I have chosen a self-expanding stent over coronary. Rest, all patients were treated with coronary drug-eluting stents or petrocavernous segment. The straightforward anatomy, the coronary stents, drug-eluting stents were used. No patients of coronary stent had any recurrence even after 4.5 years. Thank you.
Thank you. We will take over the discussion after Dharav's presentation. Dr. Dharav is a consultant interventional radiologist senior at VSP Lakeshore Hospital, Kochi, and is planning to shift to Mumbai in a couple of months. So close to Bollywood. Next, let's go ahead, look at your cases.
Thank you for that introduction. So, couple of unusual stroke cases. First case, 35-year-old gentleman, no vascular risk factor, presented with altered sensorium and left-sided weakness. NIHS was 14, 5 hours onset. So MRI was done. It showed right MC occlusion. This is the MRI. Patchy small infarction. Ischemic right hemisphere. So taken for the mechanical thrombectomy, no IV thrombolysis. And I always start with the bifurcation, carotid bifurcation. What you can see here is a triangular self-like projection at a IC origin. So it is suggestive of carotid web. So it's not like a very common entity. Many of the radiologists, they don't know about this carotid web. Even neurologists, they don't know about carotid web. So it's a variant of FMD. It's a self-like projection seen at IC origin. What is the stroke mechanism? When you have this web, it will cause a stasis of flow just distal to it, and then thrombus formation. It will migrate to the intracranially and can cause a stroke. So patient taken for the thrombectomy, solitaire and balloon tip guiding catheter. After first pass, MC open, but what you see here, there is embolization to new territory. AC is not seen now. So there was clot migration to the ACA. So with the, you can see same picture. With the same solitaire deploy in the ACA, and ACA clot was taken out. So this is the final picture. TK2B is some small non-eloquent area. There is some distal cord migration was there, but otherwise it was a fairly good result. TK2B. And then I check what's happened to the carotid web, so it completely disappeared. I don't know what happened. There was some thrombus there. It migrated intracranially, but there was nothing there. So this was the pre-picture, and then you can see it's completely clear. And then I again check intracranially whether now it has migrated now, but there was intracranially it was okay. And this patient did very well. On table he improved. We generally don't see routinely patient improving on table, but he was young patient, and on table he was started moving upper limb, lower limb. He was speaking. Sensorium was much better. So I was very happy. And we didn't give anything. Only heparin was given 3,000 unit, but no antiplatelet, no IV thrombolysis. And then next day morning, I called ICU sister and I inquired about how is the patient doing. Then she said patient is not well. He's having drowsiness and he's not moving a left hip. So then I suddenly rushed to the hospital and assessed him. He was drowsy, power was again 0. And I thought it's a reperfusion bleed or anything. So we did a CT scan, and you can see there was again stroke, re-stroke. Entire right MCA, you can see hyperdense MCA, and infarction is already developed. We did a MRI also. So it was already large infarction. So, I mean, then we didn't offer any thrombectomy or anything, which was already infarcted. And then I did bedside Doppler. You can see the carotid web is there. Video quality is not good, but you can see self-like projection there. So that carotid web was still there, and that is the cause of the stroke recurrence. And there was also thrombus in the ICA. So this was the cause of the recurrent immediate stroke. And he didn't do well. He had cardiac arrest, saturation drop, and he had multiple thrombus formation in the pulmonary artery, even in the systemic circulation. So must be some underlying hypercoagulation state. In aorta also there are some clots were there. This we can call as a thrombotic storm. So case in point is that you should not take carotid web very lightly. You should treat it very aggressively. Nowadays, if I see carotid web, I start aggressive medical management, and I advise standing upfront because it's not a benign entity. And there is one study which says that recurrent stroke on medical management is 30% for all symptomatic carotid web patients. So this was the first case. Moving on to second case, I see acute occlusion, but MCA patient. Many times we encounter this case scenario. Classical teaching is to conservatively manage, but not all patients are same. Some strokes are hemodynamic also. So let's see, 77-year-old gentleman, known case of IHD, he presented with right MCA syndrome, right hemiparesis, slurring of speech, gaze preference to the right side. NIHS was 20, wake-up stroke. So we did a CT angio, that's our first choice. It shows right ICA is occluded after origin. There is reformation of paracurrent ICA via collateral, circle of Willis collateral. And on plain CT, you can see hyperdense vessel sign suggestive of clot in the cavernous ICA. So must be underlying petrocavernous atherosclerotic disease with the plaque rupture and thrombus formation causing occlusion. Small ecom, no pecom, so obviously collaterals were not adequate. So you can see multi-phase CT, we do it routinely. First phase, right MCA branches are not very well filling. Second phase, they are filling very well. This is the color-coded system we can generate on the GE machine. Red is normal, green is good collateral, blue is bad collateral. So you can see good collaterals. Diffusion, not much changes, tiny 1 or 2 hits. So patient is symptomatic. Flare images shows hyperintense vessel, which is suggestive of slow flow in the MCA branches in the subarachnoid space. And SWI, you can see prominent veins in the right MC territory, which is suggestive of the ischemic brain. There is more deoxygenated veins on the right side as compared to the left side. So this is suggestive of ischemic brain. So all those features suggestive of that patient is not getting adequate blood supply in the right hemisphere. It's the indication of decanalization of ICA. So patient taken for the intervention. So this is the first angiogram. You can see occlusion just after bulb and then reformation of paracurrent ICA via ECA collaterals. So we need to recanalize this segment. Most likely there is clot in the petrocavernous ICA, this plaque there. So balloon tip guiding catheter was taken and then I crossed the stenosis at the cavernous ICA. From the CT I know where exactly clot is there, so I deploy solitary stent there, 640. This is the angiogram with the stent in situ. You can see there is thrombus. After keeping it 7 minutes, it was taken out, and this is after first pass. Sorry. This is a little tricky. So you can see arteries open. This is the run. This is after first pass. You can see arteries open, but there is underlying high-grade stenosis. This was the clot came out. So I waited for 5 minutes, it was not very stable. I decided to do angioplasty. So Navion was taken and coronary balloon, angioplasty, tirofiban. There was recoil, it was recoiling after angioplasty, very hard stenosis there. So I decided to put a stent. Before putting stent, I just did a CT scan. I don't know, some weird subarachnoid hemorrhage kind of picture was there, but I was not sure. So, but I decided to go ahead with the stent. Onyx resolute, it was difficult to push, but somehow I could push the stent. This is the final picture. And there was complete recanalization. That the frontal branch was missing from the previous stroke. This is the picture. And he did very well. So this is the before and after. This is the final picture. A CT scan taken next day. No bleed, nothing. That occipital thing just disappeared. So he did very well, and almost 2 years follow-up, he's doing very well. So what criteria I follow if I encounter such kind of scenario where IC is occluded but MC is patent? So I see if there is clinical imaging mismatch, patient is having lots of deficit and then diffusion is showing nothing or very small amount of diffusion hit, or patient is having a hemodynamic stroke, deep water circulatory stroke, so that indicates there is inadequate blood flow. Second thing I follow is flare, hyperintense vessel, it indicates slow flow. And third thing, SWI, if I see more hyperintense vein on the one hemisphere, it indicates ischemic brain. So these three criteria, if it is there, I open the IC. In case of IC occlusion, MC patent. Thank you.
Can we have the questions after the session here, because we are running a little late? So we will have questions with Dr. Jenny, Dr. Dharab, and Dr. Vikas.
Thank you, Jenny ma'am and Dharab sir, for sharing your experiences with us. Now I would like to invite Dr. Vikas Kumar sir to speak about venous stroke management.
Dr. Vikas is a senior most consultant at Bhubaneswar in Apollo Hospital. He has come to our stroke meeting a couple of times, and he does some excellent work in managing stroke in Bhubaneswar and Orissa. Welcome, welcome, sir.
Good afternoon, ladies and gentlemen. Thanks to Siva and ISNR group. When we talk about the arterial and venous stroke, we must understand the basic hemodynamic status in the venous circulation and the arterial circulation are very different, so also the outcome and management. If I would like to say you how the arterial and venous stroke look alike, is that there's a high pressure in the arterial stroke, whereas there is a low pressure in the venous stroke. This is a stagnation which causes the problem, whereas in the arterial stroke, it is the supply rupture that creates the problem. Now, if you look at the cerebral venous sinus thrombosis, CVT is around 0.5 to 1% of all the stroke cases, so it is pretty low in comparison to arterial stroke. And it is more common in young adults and children, unlike that of arterial stroke, which is more often seen in the elderly population. It is more common in females, almost 3 times more common, and in the younger age group. However, once the age group is beyond 60, there is no difference between the sexes. The presentation can be more of a non-stroke-like symptoms rather than the stroke-like symptom. This is another peculiarity of the venous sinus thrombosis or venous strokes. They can present with a headache, seizure, and other focal deficits which is not pertinent to any arterial stroke territory, or then let's say not in a stroke-like presentation. Who all are at risk of getting venous thrombosis? It is most common in young females, those who are on the oral contraceptive pills in the puerperal stage, during the pregnancy, and those who are on the hormone replacement therapy, particularly in the elderly females. If we look, OC pills intake patients carry the highest number, around 54% of the patients can have a history of oral contraceptive pills. And similarly, if you look at the puerperal stage or pregnancy, they also constitute a good amount of patients in the group, in the studies published in the literature. The next comes the genetic or the acquired prothrombotic conditions. And in the study that I have quoted, I have taken it is around 22% in the genetically acquired, or the acquired cases are in the 15% of patients. Most common is the APLA, antiphospholipid antibody syndrome patients, or methyl tetrahydrofolate reductase inhibitors. They are the two groups who who actually constitute the major number of patients. You will be surprised to see that nephrotic syndrome patients are also more prone to have venous thrombosis, so also iron deficiency anemia or in the underlying malignancy cases. Dural epifistula and AVM, which is the forte of the August gathering, those who are sitting here, their chances of having venous stroke is much less. If we look at the iatrogenic cause, surgical procedures done in the patients can have a 2.7% of cases to have venous thrombosis. However, the peculiarity is that in the neurosurgical procedures, it is much less or rare, only 0.6%. It's yet not known why the neurosurgical procedures carry less risk of venous thrombosis than in comparison to other cases. Is it the hemodynamic instability or the fluid electrolyte management or any other thing or the sepsis incidences? I don't know, but the literature doesn't clarify yet. And of course, in the lumbar puncture patients can have 1.9% in the study published. What are the various clinical presentations? The most common is, of course, headache, which is seen in around 80 to 90% of patients. And the other clinical syndromes that they present are either seizures or idiopathic intracranial hypertension features like headache, altered sensorium, diplopia, papilledema, or bilateral or unilateral sixth cranial palsy. And they constitute around 37 or 40% of patients of the all CVT cases. And the focal deficits are seen in 20 to 40% of patients, and encephalopathy or presentation of the altered sensorium is seen in the 20 to 30% of patients. So if I look at it, the headache and seizure are the most common one, but the most common clinical scenario that we face more often is the idiopathic intracranial hypertension cases. There is a hemorrhagic conversion in 40% of patients in cases, particularly those who are of older age group, more common in the females, and if the disease onset is very acute. If we localize around the sinuses and their possible clinical features, superior sinus can present with headache and seizures. Transverse sinus can present peculiarly with the earache or mastoid pain and cranial nerve 7th and 8th nerve palsy. Transverse sinus, if it is on the left side, they can have aphasia. Sigmoid sinus can again present with 7th and 8th cranial nerve palsy. Inferior petrosal sinus can present with 6th cranial nerve palsy. So any patient with a 6th cranial nerve palsy with a headache or somebody has come, then you can suspect clinical that probably has got an inferior petrosal sinus. Cavernous sinus, most of you know how it presents with the chemosis, exophthalmos, 3rd, 4th, 5th and 6th cranial nerve palsy in various combinations. Cortical veins are more prone to present with aphasia or hemiparesis or seizures. Straight sinus can present with encephalopathy, and vena blava, if involved, causes hemiparesis with aphasia. So this is in nutshell a small glimpse about how the clinical features are pertinent to particular thrombus. Headache, as I said, is seen in 80 to 90% of patients. International study on cortical venous and dural sinus thrombosis study was the largest study in the features of the venous sinuses and venous thrombosis. Again, it was there in 90% of patients. It can be diffuse, progressive, and it can be subacute. It can happen in the days to weeks, and it can present with a chronic headache. If a chronic headache patient is evaluated to found to have got transverse sinus thrombosis or chinking of the transverse sinus. I'll come up with these slides. Sometimes it presents with a migraine-like features. And because of the trigeminal vascular sensitization, again they present like migraine, and it sometimes gets confused with the patient. So any patient who presents acutely with a headache, which is a migraine-like features, please do not jump into diagnosis of migraine. Please rule out a venous thrombosis. And the headache worsens with the lying down, and it may be associated with rhinitis and fullness in the ears. As I was saying about the patient with headache or patient who presents with headache can have various presentations. Here what we see is the patient, 46-year-old male patient, presented with a headache and was found to have hemorrhagic infarct in the left temporal lobe, what you see, and his MR venography showed thrombosis of the transverse sinus. So again another example where patient can present with headache, but patient had got a hemorrhagic infarct and patient has got a venous sinus thrombosis. The more common scenario is a young female coming with headache, which is more like migraine or more like a thunderclap headache or intermittent headache with a continuous headache. All kinds of combination of headache can be presented in a patient with thrombosis of the venous sinuses. The MRI brain shows, here we see the optic nerve, the perioptic nerve space is dilated or tortuous, and MRI is showing the chinking of the transverse sinuses bilaterally. Again, a case of idiopathic intracranial hypertension. So as I said, headache is the most common presentation. So very often in the clinical practice, we deal with the cases of headache which have been misdiagnosed as sinusitis, psychiatry patient or kind of migraine headache. They can come up with a venous thrombosis. Second most common presentation is the seizure. As I said earlier, it is in around 40% of patients. In such patients, the generalized seizure is more common than the focal seizures. In the Chinese population, Chinese Han population, the study published in 2016, they had taken up 151 patients, and 40% of them, nearly 40% of them presented the seizure, and 80% of all those seizure cases were generalized rather than the focal. Because normally one would think that if it is a venous thrombosis, then this will have a focal seizure, but more often they present with the generalized seizure. And who all are the, have got the worst outcome? They are male population, those who have the focal deficits, those who have a parenchymal lesion, or if there is a superficial thrombosis, they are more prone to have seizure-like presentation than the other groups. And patients, those who have seizure, are more likely to have worse outcome than the other group. The most important and vital in the venous thrombosis is about the role of the females, or in the role of venous thrombosis in females. So if we analyze it further, it is the most common risk factor is probably the oral contraceptive pills used. And in one of the meta-analysis, it was suggested that those who are taking OC pills, the females are 6 times more higher chances of having venous thrombosis than those who are not taking it. And there is an increase of CVT in pregnancy and puerperium is less, it is more common in the less developed nations like the countries or third world countries or African nations because of the associated hygienic issues, infections, and increased pregnancy rates. It is also diagnosed in association with ovarian hyperstimulation syndromes resulting from in vitro fertilization. So one has to keep in mind while dealing with the females with neurological complications, venous thrombosis makes a role to play. In another study where they had taken 88 patients, the females having a single center experience of postpartum cerebral venous thrombosis, they had taken around 88 patients, out of which 10% were the postpartum category. And they had evaluated about the patient, those who have the seizure, those who have the venous thrombosis and those who don't have. And those who have the postpartum, they had a presentation of more common with headache and seizure than those who are in the non-postpartum. There is no reason behind why it should be more common in the postpartum area. Probably hormonal changes, acute or sudden change in hormones, and the infection is probably the highest cause, the greatest cause for them. And the acute presentation again is more common in the postpartum patients than that of the non-postpartum patients. So in a case where we have reached to a reasonable doubt of a venous thrombosis, what all investigations one need to conduct? Besides CBC and complete metabolic parameters, PT, FPTT, and viral serology, one has to go for the further hypercoagulable testing like protein C, protein S, antithrombin, APLA, anticardiolipin antibody, prothrombin G20-210A mutation, and factor V platelet. And if infection is suspected in a patient, then obviously blood culture and other fluid culture is to be sent. If a malignancy is high on the cards, appropriate investigation to reach to the conclusion of the, because if you unless you treat the primary pathology, the venous thrombosis treatment will not be adequate. And of course, the next most important is the neuroimaging. So very often a question comes into mind, do I need to advise D-dimer test in such patients or not? D-dimer has got an excellent negative predictive value, around 99.6%. That means if a patient who has got a headache and if you have sent a D-dimer which is coming very low or negative, then probably the chances of not having a venous thrombosis is high. Second, the specificity of D-dimer in such patients are 91% and sensitivity is 97%. In a smaller study, however, it has been reported that false negative rates are less than 10% in a patient, those who have an isolated headache. So, if a patient has come with an isolated headache and you have sent the D-dimer test, the false negative rate is only 10%. So, you can be reasonably sure if the financial constraint is there or the facilities are not there in an area where you are working, still you can think of sending a D-dimer. The positive correlation is there with the D-dimer level and the extent of the CVT. So, if the CVT is very severe and very prolonged or very extensive, then the D-dimer level can be high. And of course, it has a negative correlation with the duration of the symptoms also. So, if it is a chronic and if it is delayed one, then probably the D-dimer levels can be fallacious. I need not speak much about the role of CT venogram and MR venogram and CT and MRI in this gathering because it is a wastage of time for all people. Because it was being presented somewhere else, which is not a radiologist gathering, so I had picked up this one. However, to say that wherever available, MRI is most important. However, if the facilities of MRI is not available, you can still make a diagnosis of venous sinus thrombosis reasonably correct if you advise for the CT venogram along with the NCT or contra CT. Here's some of the findings that, well, the transverse sinus thrombosis, the hemorrhagic info with edema, and the superficial sinus thrombosis. The CT in the deep vein involvement leading with the bilateral thalami infarct and, and various combinations of hemorrhages and hemorrhagic infarcts can be seen in the CT. And equally in the MRI is more useful, more prudent, where besides the parenchymal lesions, one can reasonably say what are the venous sinuses involved or the cortical veins are involved. If I have to come to the differential diagnosis, if such a patient has come for the young learners, one needs to keep in mind about the idiopathic intracranial hypertension. Obviously, I am emphasizing it because most of them come with this kind of headache. Besides that, intracranial tumors, brain abscess, ICH, ischemic stroke, meningoencephalitis, autoimmune encephalitis, paraneoplastic syndromes, neuromyelitis optica, all these things should be kept in mind while approaching a case where you are not reasonably sure that the imaging has not proved that it is a venous thrombosis. Coming on to the treatment aspect, I would say it is constituted into 4 categories, particularly the anticoagulants, anti-edema measures, and the symptomatic treatment, of course, surgical and the endovascular treatment. So far as anticoagulants are concerned, there is a great debate whether to go for unfractionated heparin or low molecular heparin. And in the study published in Stroke 2010, the ISCVT that I was discussing earlier, that they had 90% of headache, it's the same study, which was a landmark study, of course. And it gave the idea of whether to go for a low molecular heparin or still stick to unfractionated heparin. They had taken up 624 patients with the primary aim to see for the functional independency at the end of 6 months with the MRS score of 2 or less. And the secondary endpoints are about the complete recovery, mortality, and the newer ICH if they have developed. That in the 2 groups, the low molecular heparin group was the 28% of patients received low molecular heparin and 72% received unfractionated heparin. The functional independent at the end of 6 months were equal or little better statistically than the unfractionated heparin group. And the newer ICHs were also less in number. So it was concluded that probably low molecular heparin has a better efficacy and safety than unfractionated heparin. But because the size of the study population is less, so it is yet very clear. But however, most of us are right now switched over from unfractionated heparin to low molecular heparin because the age of advising it and not to monitor the APTT frequently. Similarly, once the patient is on the oral, injectable anticoagulants, then now to switch over to oral anticoagulants. So what is the role of the newer oral anticoagulants that have come to the market? Are they safe? When to give? Can it be given or not? And what is the outcome in such patients? So here is a study published in 2020 or 2021. It had the systematic review consisting of 33 studies, out of which there was only one randomized trial, because the incidences of venous thrombosis is less, and such patients getting in the randomized trial is again a difficult job. And 5 observational and 27 case series were there. They looked at the rate of the mortality, ICH and other adverse events in such patients, and what is the rate of recurrence, recanalization rate and disability in such patients. So it was found that they had taken 279 patients in the newer oral anticoagulant groups, whereas 315 were in the standard treatment, 41% and 47% were the dabigatran and rivaroxaban groups, and the other ones were the smaller ones, and the mortality rate was same in both the groups. So there was no difference between the mortality as far as both the groups are concerned. The new ICH and the recurrent CVT were lost, not very significantly present in patients who were in the newer oral anticoagulants, so direct oral anticoagulants. So, and they had got a better, favorable modified Rankin scale score, and the evidence, even though the cases are less in number, but still it shows that it is still safe and efficacious in patients with venous thrombosis. Similarly, RESPECT trial, which was a phase 3 prospective randomized open label multicenter exploratory trial with blinded endpoint adjudication, they had taken dabigatran versus warfarin, and they had 108 patients, out of which 55 were in the dabigatran group, 53 were there in the warfarin group. 60% on the dabigatran and 67% of the cases in the warfarin group improved. So there was no difference at the end of the 6 months. The recanalization rate was similar and the outcome was similar in both the groups. So it is needless to say that probably newer oral anticoagulants are safer and easier to administer. Only point against is the cost of the therapy. Similarly, neural anticoagulants have been trialed in patients, pediatric population with various thrombosis. That includes the venous thrombosis, venous sinus thrombosis also. And it has shown that the major or clinically relevant non-major bleedings were there in both the groups were more or less the similar. So it is safe in pediatric population also. Role of surgery, if I have to discuss about the role of surgery in such patients, it is particularly useful in patients those who are impeding herniation, low GCS and rapidly deteriorating condition. And hemicanectomy is advised, which is ideally centered on the site of the largest hematoma and the venous infarcts. However, the poor outcome is expected in patients those who are more than 50 years of age, the midline shift is more than 10 mm, and there is effacement of the basilar cisterns. If there is a deep venous system is involved, and if the lesions are bilateral, then probably surgical outcome can be poorer. Tomorrow you have an excellent talk tomorrow morning about the endovascular therapy in the venous thrombosis. I had just picked up one article which is the TWACT trial. I won't go into it, but the conclusion came up in such group of patients is that they had randomized it into 2 groups. The control group was the standard therapy and the interventions group, and there was no difference if the patient is on endovascular therapy. At best, the endovascular therapy can be offered to patients those are rapidly deteriorating, facilities available, and if it is mortality rate is expected to be high in such patients. Another controversial area is the role of steroids in CVT. Many of us do wonder whether to give steroids or not to such patients. In the ISCVT trial, they had studied about the steroids, role of steroid. They had taken 624 patients in the steroid group and 150 were not in that group, not given steroid. And it was based on the risk factors and the other parameters are more or less similar in both the groups. However, the physician's choice of giving steroid was taken into account in such patients. However, it is seen that those who were treated with steroids had the similar characteristics so far as the controls are subjected, except that there are fewer increased incidences of vasculitis in such patients, and the physicians prefer to administer steroid in such cases. At the end of the 6 months, it was found there is a higher risk of death and dependency in the steroid group than the non-steroid group. Only if there is a parenchymal lesion with high vascularity and high edema is there, one can give it for a short period of time depending on the physician's choice, but long-term use or routine use of steroid is not recommended. If I look at the prognostic factors and what is the outcome in such patients, the early deaths are seen in 3 to 15% of patients. So most of the patients do have a good functional recovery. So any patient who comes with a venous thrombosis needs to be taken care of properly because the outcome is good. It's one of the treatable conditions. And the complete recovery is seen in around 79% where MRS score is 0 to 1. And the delayed death mortality is in patients those who have got severe infection or the underlying malignancy. And the vision impairment, particularly of the patients who have IIH or patients who have got raised ICP, optic nerve fenestration or the shunt is useful in such patients. Those who present with the low GCS, those who present with the encephalopathy, those who have deeper venous involvement, right side of the brain involved, and those who have got posterior fossa lesions have got an increased mortality and have got a poorer outcome. And most of the cases, the cause of the death is mostly there's a transtentricular herniation and the diffuse cerebral edema. So those who have poor outcome are the male sex with the older age group population, those who present with the lower GCS, patients with a massive intracranial hemorrhage, deep venous system involvement, infections or malignancies or the other associated conditions make a role to suggest who are going to have a good or those who can have a bad outcome. So the key points, venous sinus thrombosis is a rare disease in comparison to the arterial stroke, but most commonly the patient, those who come with the venous thrombosis, many of them they come with a simple headache or seizure, so one needs to be very prudent to evaluate such patients. The prognosis is good. The prompt diagnosis and treatment is the key to this management. Anticoagulants should be utilized or used in all the patients where there is no specific contraindication of the coagulation. If the patient has got parenchymal bleed also, such patients should be advised to take oral injectable and oral anticoagulants. Accordingly, one should not stop anticoagulants in such patients until unless there is a massive bleed with impeding herniation. Such patients are subjected to the surgery and then subsequently can be put on the medications. Endovascular therapy can be kept as the reserve therapy and best can be used in severe and specific cases. And with that, I would like to thank you all for inviting me for this talk. Thank you.
Very excellent review of the literature. Very informative, sir. Thank you so much.
Thank you. So we can close the session here. You have a question?
Question?
Because you have a question.
Good evening, sir. Often we find it challenging to diagnose cortical vein thrombosis. Any tips on diagnosing that, sir? Because even after discussion with radiologists also, sometimes we are still in a fix whether there is cortical vein thrombosis or not. Any tips on identifying cortical vein thrombosis?
As a neurologist, how can I answer this question?
Sir, no, I'm a neurologist too, sir. That's the dilemma.
Is up to you. I'll come to you to ask the same question.
Sir, I'm a neurologist too. That's why I'm asking.
Then ask this guy who is sitting there. They are committing mistake. Ask them, not me. I think tomorrow you have a endovascular therapy. I think he will probably being the radiologist.
What is the question?
He says sometimes the radiologists are doing mistake in diagnosing and picking up the venous thrombosis.
I'm sorry, I
No.
didn't say that, sir.
The question is how to identify isolated cortical vein thrombosis. As a radiologist, we see SWI. Most of the time we miss in all the other sequences, including MRV, because it's isolated, no major dural sinuses are thrombosed. If you see the source images of SWI, you will pick up a card sign. That is the only sequence and the best sequence to pick up isolated cortical vein thrombosis on imaging. Otherwise, there are no other modalities. SWI is the key, which we have picked up. Isolated vein of Labe, isolated basal vein, isolated cortical vein, all things can be picked up on SWI. Not on the routine gradient, but SWI is a very good.
Thank you, sir. Now I would like to extend my sincere thanks to the chairpersons and the speakers for the insightful discussions in the previous session. Now we'll move to the further sessions for today. And I would like to call Dr. Azmi sir and Dr. D. Rajashekar sir, Dr. Devra Anil sir, Dr. Divya Rani ma'am to be on the stage as the chairpersons for further topics. Welcome. And I would like to call Dr. Chandra Mohan sir to be on the stage to speak about radiation safety in neurointerventions.
Good evening, everybody. First of all, I would like to thank Dr. Siba for this invitation and also ISNR for the opportunity to discuss, share some facts about a topic which is of great importance but less talked in our forums. So I thought we'll look at the relevant aspects as far as radiation safety is concerned and try to improve our practices if we can inculcate them, and also in the end make a request to our leadership in various interventional societies to focus on certain aspects where we can lead being interventionists for the country also. So, see, actually, before we started having, initially when we started our career in 80s, early 80s, there were hardly any exposures coming. We were doing fluoroscopy in the dark rooms, only diagnostic studies were being done. The exposure to the patients as well as to the staff was minimal. Then came the era of intervention radiology in late 77. I think it took everybody by a lot of interest. Procedures increased, technology was not very refined at that point of time. Even catheters were very crude, but people were very enthusiastic and a lot of cases were started doing. And that increased the dose substantially, not only to the operators, to the staff, also to the patients. And this field has been evolving since then at a very rapid pace. And then complex cases are being performed routinely. The technology has gone way ahead. The equipment has become very good, even the hardware. So that has made life quite easy. But does it solve our problem? Because if we look at still the data, it is the third largest source of fluoroscopic radiation. Even we look at the data from the other countries, diagnostic studies, especially the CT studies, are increasing rapidly. Conventional remains at number 2, and the third largest cause of radiation is the interventional procedures. So it is said, if you look at, this is especially for the younger generation, it is said that people who stick to only diagnostics are going to be actually phased out very soon, because they have to move out from their comfort zone, and because a lot of things are going to be taken over by the AI. So what is anticipated? It is anticipated that interventions are also going to increase rapidly, and that will be our area of interest and development. And also the theranostics are coming. I think it will take a while for the brain theranostic therapies to come in a regular manner, but at other intervention systems, it is already in pipeline. So when it comes to radiation, we are very happy doing a lot of complicated cases, but we look at the other way. This is especially true of our non-trained colleagues in imaging. the other specialists who are practicing this intervention. Not really true for people who have gone through the formal structured training of 3 years in MD and also in super specialization. So when it comes to neurointerventions, do we talk of this topic in a forum like this where highly skilled, qualified team is there? Does it matter? Because it is not going to be appreciated. We think that it's too minuscule a risk to be discussed in a forum like this. But earlier we always thought that stochastic effects, they only manifested very late in life because the radiation dose was very low over the years, and it took many years, may not manifest during the lifespan of the individual. But the life expectancy has increased, and the philosophy is changing now. The cataract formation, which was initially thought to be dose dependent, now there is evidence that even a very low threshold of radiation can induce cataract changes in an individual. So this changing role actually alarms us that what we have been thinking and practicing may not hold true for future. We are actually more focused on patient safety and clinical outcomes. We are not focusing on the radiation safety. We are actually very enthusiastic to do more and more complicated cases. We do not see the effects. Even if we do cross our borderline, we cross the boundaries, immediate effects are not seen because it will take a while for them to manifest. Even if they manifest, we actually don't identify them. So we'll come to these 3 or 4 areas one by one, which I just want to re-emphasize today so that we look at this regularly in our clinical practice. This, in the bargain, what we are doing, we are ignoring our safety and safety of our staff. Look at the health issues which is affecting the people who are working in the interventional suite or the cath labs. Skin lesions, see the frequency as compared to people with no exposure, 8.6 versus 2%. Thyroid, we know so many examples. Interventionists have developed thyroid carcinomas, and we have just looked the other way. This is 7.5 versus 3.6. Cataract and lens changes. How many of us regularly undergo critical lens analysis? Look at the posterior capsular densities which we are developing, which is not a typical cataract which one develops with age. Similarly, the role on the reproductive system, pregnancy is well documented. Another area is the cancers. Now this is a cause for alarm. The prevalence of cancers is quite high, though it was not considered to be significant. I have quoted 2 or 3 studies, but if you look at real-time data from many studies, which I'll be sharing with you, everywhere increased incidence of certain types of cancers have been reported. So this, unfortunately, when I look at the guidelines, they are coming from other societies. Plenty of literature from Cardiovascular Society, and then now lately, the Endovascular Society has come out with the 2023 guidelines on radiation safety. Fantastic document, 23 authors. It is worthwhile to go through this, how seriously people are taking radiation safety as an issue. It is expected that one receives 20 to 30 millisieverts to the head and neck per year, and the lifetime dose to the head, 500 millisieverts. That is our threshold to develop problems. The exposure is 2 to 10 times more as compared to the people who do not work in the radiation. The left side brain tumors are seen approximately in 86% of cases. Left side breast cancer, similarly left lobe of the thyroid involvement, melanomas. There is a definite relationship between low dose radiation exposure over many years with these problems. The medical workers who are exposed, as I said, they have a 20% increased risk of cancer. Now, a lot of studies have been done to see the effect of radiation per se on the brain itself. Now, I've just highlight 2 or 3. Rogin, he's studied a cohort of 43 patients. Out of them, 33 were intervention cardiologists. He selected 6 intervention radiologists, 2 from the electrophysiological and 2 nurses. Look at this. He followed them up for 12 to 32 years with a mean of 25.9 years. And what he found, it was a retrospective study. He picked up people who had long-term exposure in the cath labs and then who had developed malignancy. Out of these cohort, 22 had glioblastoma multiforme, which accounted to 55% of the cancers, 2 astrocytomas and 5 meningiomas. And in 85% of cases, it was restricted to the left side. Now, this is another landmark study which Rajaram et al. Had done. He selected, picked up the cath lab staff. Look at the numbers, 91,000. And he followed them up for 7 to 8 years, a 4-year period, but followed by 7 years. And then he reported that risk of brain cancer was more than twice in this 91,000 cohort group. And there was definitely moderate increase in the risk of melanomas and breast cancers. So this is why he analyzed why it happened. The focus is on the radiologist or the operator himself. Not much focus is paid to the staff protection. So there is a suboptimal radiation protection. They spend actually more time in the cath lab than the operators. Operators come and go. These staff hardly changes if you look at their schedule. So they spend a lot of time, get more exposure, and they don't have that proper tailored radiation device. We have some protection being senior people, but look at the numbers we have in the lab. Not many adequate hardware is available to protect them. And of course, very simple principle of not following the distance is not adhered to. Now, this is another area which I think I would like to mention, is the behavioral and neurological effects of radiation. I used to wonder actually, some of the people I used to encounter who have been senior people, very eccentricity of mood you will find. Suddenly they are very nice, and then suddenly you find they are very, labile mood changes. But look at the study. This Andresi found 6 times more self-described anxiety and depression in the staff of cath lab. Of course, we understand there is a high stress situation. They work for long hours. There is a psychological drain on these people. But look at the lifetime exposure. It is said, and it is documented, lifetime exposure of 1 to 2 sieverts has a detrimental effect on the hippocampus. That's why they have these labile and mood changes on the neurogenesis, neural plasticity, and have a negative effect on mood stability and psychiatric morbidity. Another worker, Mazzati et al., he compared the neuropsychological scores in 83 cath lab staffs and compared it with a control group, same age, sex, and weight matched, who were non-radiation workers, and he found they had a lower memory and lower recall performance. I mean, it is very alarming if you go through this data. I'm not saying numbers are very significant, but they can happen to anybody who has spent 20 years plus in the cath lab. Here the things are changing. Earlier, the IRCP had laid down a threshold of 500 millisieverts. Now they have come down to 150 millisieverts. Now cataract is one which is gaining a lot of attention in radiation exposure, because radiation causes post-capsular densities. Now they are very difficult to pick up unless and until one goes for a checkup at a specified interval, one is not going to detect. And why it should be done? I will come to this medical examination importance later on, because you can pick up, one can be cautious and change his practice and carry on for a longer period of time and prevent the cataract formation. See, evidence suggests, this is what I was saying. Initially, we always thought cataract is deterministic effect of the radiation. It is dose dependent. Actually, it is not so. Even a very small amount of radiation dose, very low dose, can change this, cause damage to a single cell and induce the cataract formation by post-capsular densities. So this is what is changing now, and that is what has led to a lot of screening. Why we are having cataract? We always have lead glasses, only 1 or 2 in the cath lab, but we don't wear them because most of us, as we grow, we have powered glasses. It's very difficult to wear these lead glasses unless and until you get it customized. So they are very expensive because the number will keep changing. Changing these glasses is an issue. So we tend to avoid using these glasses. And another problem is, even if younger people, this is my message to younger people, please start using these lead glasses. Even if they cause you little discomfort, because this will protect you a lot from cataract formation or changes in the lens. We tend to ignore it because we feel it's very uncomfortable, and then we don't use the dosimeters. I mean, this is one area which I would like to stress today, is the dosimetry. And of course, there may be some lack of safety knowledge. 3 times these densities in the posterior capsule are more in the interventionist, and we can reduce it by 75% if we use lead glasses. Look at the tremendous benefit. And then threshold levels, as I told you, has been coming down because of these low threshold effect of the radiation on lens. So this is another important study. Vano et al. Studied which all procedure caused more radiation. And he found cranio-neuro malformations, highest incidence of radiation exposure, 11.2 millisieverts. Spinal neuro malformations, 11 millisieverts. TIPS, at one point of time, I remember when we started in 80s, TIPS used to be the highest among the radiation exposure. See the number, it has come down drastically. It has become much, much safer as compared to some of these neuro procedures. Vertebroplasty, still, because of sometimes we have to use angulations, and we must remember steep angulations, especially LAO, is going to cause a lot of radiation, so we should use it carefully. Protection by the lead glass, 35 to 95%. A lot of studies I've gone through, the range is very big, but it is a significant reduction. The problem is there is a gap. Still, if you wear the glasses, there is some gap is there through which radiation can still go, but that we can control it by using the ceiling mounted glass appropriately. We don't use it appropriately in the cath lab. This we used in our initial practice. We saw some of the skin changes. Equipment was not very good. The resolution was not good. We were using, same area we were exposing again and again for neuroembolization, and one odd patient did develop alopecia, but they never came to us. They went to the dermatologist. Why? We never told them that, look, we have exposed you and you might have some adverse effect on your skin or the hair loss. So patient and the dermatologist will treat them like any other alopecia areata. But very characteristic, there has to be a radiation exposure of significant magnitude, and then it takes a while, few weeks for it to develop. It is between 2 to 5 grays. People will have a temporary loss of hairs for 3 to 6 months, but they will grow without any treatment because we have removed the cause. But they keep shuttling, and they never share with you when they come for follow-up, look, this has happened, because they think it is not your domain. This is what I want to send a message to convey this to my younger colleagues. Please be very careful with exposure dose to your hands, feet, and lower legs. The upper legs are covered by the lead apron. The lower legs, if you look at people who are working in the cath lab, you will find loss of hair on the dorsum of their hands, forearms, the lower legs, and the feet. And their skin is very loose, brittle, and shiny. and the nails are sometimes brittle and they may have pigmentation. The worry is these pigmented nails can be a manifestation of melanomas. So be very careful. The picture which I have taken from the net to show you, I recently met a colleague of mine who has a very aggressive intervention radiologist, and when I looked at his hands, severely pigmented, atrophic, shiny, and his all nails are discolored. So I told him, he says, what should I do? I says, please get biopsies done at a regular interval. It may not manifest in the first biopsy, second biopsy, but be very careful. Now, we have gone through 2 biopsies. Fortunately, there are some ATPR cells have come out already, but no malignant change, frankly, discovered. So basal layer can be involved, the nails can be involved. So this aspect, please be very careful when you are exposing your hands to radiation in the zeal to do more and more cases and do complicated stuff. In foreign countries, we don't have this luxury. In India right now, ring dosimetries have also come, and people who actually do a lot of radiation work, they are using a single company, very costly. I think if the associations can take up and consider, though it will not be very cost effective for our setting, but yes, people who can afford it must use it. But problem will be monitoring the dose, who will do it. So another aspect before I go on to the other areas is the biological effects. Even small amount of radiation will cause DNA damage and the repair process will start. It's very easy to detect the response of body to the DNA damage by 2 proteins. These are the 2 proteins, histone H2AX and phosphorylated ataxia telangiectasia mutated protein. These 2 proteins are seen in the lymphocytes. Immediately within few hours, if you take the blood of these patients, within few hours you will see the response. But they always don't do the repair correction. Sometimes misrepair can occur. Now this misrepair is an issue. It might cause micronuclei and dye-centricity. Now these are the 2 areas which are going to create problem, because they will lead to unregulated microRNAs. Now this is a problem. The effect may not manifest now. It may take years to come, but you can detect this very, very early. So is there sometime if you feel you have had enough at a periodic interval, should we get our lymphocytes done? And then it might give us a clue that we need to look at our practice carefully. People who undergo CT angiographies repeatedly, we have found that even their blood has these aberrations. So this is the recommendation. You must have all be very clear. But what is justification? Now justification, one aspect we don't deal. We tell the patient this procedure is required, there is a definite benefit versus risk ratio, but we don't talk to patient about the radiation. That this procedure will involve the radiation and these are the effects of radiation you might have. So optimization, we are very good. We take care of our equipment. We take care of all protocols in the lab to reduce the exposure by using various techniques. And dose limitation. I think in India, this dosimetry, we are not serious. Though we are wearing this, we are not monitoring it carefully. So what is the updated guidelines internationally? The guidelines are now that we have to be careful for the increased protection to the lens, and we must include in our consent that we have briefed the patient about the radiation risk also, that we will be using the radiation. And third, we will record the dose which we see it after the end of the study on the monitor in his report. These are mandatory law which they have made it. All ICRP, National Council for Radiation Monitoring and Measurements, the Endovascular Society 2023 guidelines, they have made it a law. In India also, it is there, but we don't practice it actually. So consent has become a law, we should endorse it. Dose management. We know that if you buy a very good equipment with latest technology, ultra low dose management, we can control the dosage in the lab. But this is not true for my younger generation. They shuttle from one place to another place for practice. They don't get the best of equipment. They might have to work with the substandard or the compromised situation like C-arms. Be very careful, protect yourself as well as your staff from radiation when you are using the angulations. We don't have proper shielding there, and sometimes operating these heavy C-arms is pretty difficult. But we are so enthusiastic, we don't want to leave any case. So a lot of equipment technology companies have come out with these features, which I think as an interventionist, we need not go into. What I would like to say is the great switch technology. When you're buying the equipment, please see if you can buy this technology, because there is a soft radiation at the trailing and the ramp effect is there. The grid switch removes these soft radiations and give you only the useful radiation, even in pulsed fluoroscopy. So you can actually further reduce the radiation dose if you use this technology. So this is imaging chains. They have become so good. Now you don't need to magnify more and more and increase more, scatter more radiation. This is a very good summary which I've been provided by one of our trade partners. They have come out with this smart beam. Look at 3 components. Sorry, it's not going back. Smart beam by these features, then better awareness. This is what I was saying. In the radiation room, you are getting the dose. You must record it at the end of procedure. And then include this in your report, that how much exposure we have given to the patient. And of course, we have a lot of controls where we can control our radiation doses. So we are already using these long tubes to be away from the patient. We know the scattering. We are quite aware of the shielding. Now, shielding is also not done properly. There is a ceiling mounted glass. We just put it on one side. There is a specific way to protect yourself from the shielding. Not only you, your staff has to be protected very carefully. So this rad pad actually is very good. I mean, we did a lot of cases with rad pad. We measured the doses. It reduces by 20 to 30% of the radiation. Unfortunately, in a private sector, it adds to the cost. So that is what is a constraint. But if you ask me, if you can afford, you must use this. Short-heighted people versus long-heighted. I think here, short-heighted people are at a little disadvantage because they get scatter on the left side, temporal area more as compared to the tall people. And anesthetist colleagues, I think it will interest them. They are integral part of a neurointervention suite where a lot of procedures are being done routinely under monitored sedation or GA. And unfortunately, we don't have so much of PP equipment for them as well as for their staff. We should have long tubes. We should have monitors. They should be sitting outside. They should not be in the cath lab unless and until it is essential. But in practice, and they don't have a control. I mean, they are dependent on the operator, and they don't have controls with them. This culture we have to stop. These people watching, without any reason, they are standing in the cath lab looking at the procedures. I think if we can stop this, we can reduce the exposure to our staff. A lot of equipment is available, but do we use it? First of all, there is an issue in India about adequate availability numbers. Number 2 is the maintenance. You go to any lab, you don't find after the procedure also everybody taking care to hang it properly. They just throw it, the lead gets cracked, and then it trickles down. It doesn't give you any protection. Do we do QA checkups? We must do a digital scan or a CT scan once in a year, or maybe 6 monthly, one scan, to see any cracks have developed or not and discard them. There is a need for customization. I think this is for female operators. They must have felt the need at some point of time or the other. These axillas, they get exposed. They are not, shoulders are not covered. So there is a need. We should customize some hardware for them also. So what is the guideline? These guidelines says we should categorize individuals into 2 groups who are radiation workers. Category A, who are receiving 6 millisieverts per year or 15 millisieverts to the lens, 150 millisieverts to the skin. Monitor these patients carefully. Monitor their doses carefully. Subject them to yearly medical examination. Apart, the second category, who has less number of exposures, can be monitored by dosimetry alone. Pregnant staff is an issue. Actually, there is lack of awareness. First trimester, we have to be very careful. But after that, if we take precautions, the dose to the lady as well as to the fetus can be controlled and kept within limits. Now, newer aprons have come, which are lightweight, zero lead apron, then this hanging protection shield, what we call it, zero gravity systems are come abroad, not in India easily available. It will take a while, but they will make life much easier. TLD batch, this is what I wanted to highlight. We are not serious about it. How many times we have seen how much cumulative dose I have received till today? I have asked this question many people. Nobody has been able to give me answer how much is their cumulative lifetime dose. How are we going to monitor? We send this for some authorized lab by ARV, get the report quarterly, it is kept with the radiographer. We are not told, but let me give you one instance before I close. One of the hospital almost got shut down during COVID time because 3 people had the TLD batches, 80 millisieverts, 92 millisieverts, and 123 millisieverts. Reports came. It went to the ARV and they said, we'll shut down your hospital, investigate before we go further. And that was the peak COVID time. We had to actually tell them to give us some time to control it, go through what has happened, whether it was deliberate or misuse, wrongly storaged, kept. So all these issues one has to be investigated, and 3 TLD batches were lying in the radiography room, Almira. So we actually had to scientifically prove them with the help of a medical radiation physicist, put our processes in place before they agreed to allow us to continue to work. So real-time dosimetry has come. You can wear it. You can actually see it real time now in the cath lab, not freely available, but they can be used again and again. You need not send them for reading. Of course, we have to do a course correction. How many of us have a medical radiation physicist available, that luxury? We have a RSO who is either class 1, class 2. How many of us go through what processes they are following, how much training we are doing? Nothing. So even we have not shifted. We are so comfortable by direct puncture. I mean, I'm not saying we use our hand, but for younger colleagues, sometime in enthusiasm, wire is not going, you tend to switch on the fluoro. Use ultrasound, and it makes your life much easier. So how can we optimize? Fluoroscopy settings, filter options, all this we are doing as an intervention radiologist. Nothing new for us, but for our non-intervention colleagues, they are very important. So these are the already we know. We should try and restrict to the minimum, use acquisitions wherever essential. Even fluoroscopy, we should use filters, we should use all low-dose protocols. When we buy the equipment, already some protocols are there by the company. We should sit down and make our customized protocols where we can use lower MA and control the radiation dose further. So zero-dose positioning, we are already using virtual collimation, and positioning is already there. Now, fusion. This is this is study of 2013. Imagine 10 years ago, they have tried this and found it very useful. So a lot of things are in pipeline. We have to be very careful. I was doing a lot of craniofacial malformation in neonates, very small babies. I think that group needs special attention, not only from anesthesia point of view, nasal intubation, because for GA, because they are all over the pharyngeal mucosa, pharynx, buccal mucosa, you cannot do per oral intubation, and they also get exposed to radiation because they require repeated sittings. So people, certain group, we have to be very careful. And this is another technology which has come for body imaging. Maybe in due course of time, we'll have it for neuro also. That is fiber optic real shape technology superimposed over 3D navigation. So there is no need, once you have taken a 3D navigap, you take this through fiber optic technology, no radiation is involved. So I'm sure this will also be coming very soon. robotic systems, MR guidance. Because of shortage of time, I'll skip. So this is what I think is the future. We might see it in our just 2 minutes clip before I close. This video is not playing. See, this augmented reality is going to take over. We will not have the need to have large monitors. We can create our virtual screens, magnify, play with it, do whatever interaction you want to do, even by gestures, by voice. And this is what I wanted to show you over 2 minutes. Already this is in pipeline.
But AR in the operating room is about so much more than
Can you
holograms.
increase
Let
the
me show
volume?
you. Here you can see how AR allows me to place my own customized screens exactly where I want them. It's perfect for ergonomics. In fact, every doctor, every technologist, every nurse that's in that operating room can have their own customized screen with data relevant to their needs. We no longer have to share looking at one big 60-inch monitor that's broken up into multiple tiny little windows. By the way, it's a monitor that never finds itself in the optimal position for everyone. Our hands are busy during the procedure, and being able to control the system with voice commands, that lets me keep focus on the patient. And because our bodies are 3D structures, it's so much more insightful to see anatomy in a hologram rather than on a 2D screen. I need to interact with all sorts of data during the procedure, and being able to control our system with eye tracking, with intuitive gestures, that allows me to keep focus on the patient, not think about the buttons. The operating room now truly feels like an extension of my hands and of my mind. AR will even allow us to beam in an expert from the room next door or even continents away. So when you put it all together, AR is not just a replacement screen. It's going to help your surgeon better understand your anatomy in 3D, interact with all sorts of relevant data. It lets the surgeon keep their focus where it matters most, on the patient and not on the equipment. And when you add in computer vision and artificial intelligence, we see even greater opportunities.
This was Dr. Amit Gupta working with the Philips. Philips is already working on this system. So what is last point is quality assurance. This is one I will request my colleagues to focus and not leave it to the radiographers or the lab in charge. We should see that every equipment undergoes this quality check at least once in 2 years. These are the guidelines of AERB also. They look at various parameters, most importantly radiation leakage. We had one of the hospitals recently, lot of leakage from the tube, a new machine. So there was alarm raised and immediate action had to be taken because it was vigilant. That is why it could be detected. This slide summarizes the whole lecture. I think it is key to have a good team, train them well, work them for a longer period of time, develop safe practice both for the operators, the staff, as well as for the patients. And it is very important to maintain this long-term association and also record doses of radiation in the documents. So education and training is the crux which we need to do and focus more. And then last thing is my suggestions to the interventional societies. I think we should have structured training programs not only for our operators, also for our paramedics who work with us, including our anesthetist colleagues, their ORAs, sisters in the cath lab. Everybody should undergo this training. People who are working many years must undergo a regular checkup. In armed forces, we had a system initially every 3 months. Now it is every yearly for every radiation worker, it is mandatory. So informed consent has to be introduced. We must record those in the patient record dose, and we must be very careful when we are doing up cases where repeat studies are being done. With that, I wish you all very safe interventions for many decades in future. Thank you very much.
Any questions? Thank you, Chandramohan sir, for a very relevant and informative talk. I hope it is aptly followed for our safety and for our good. Thank you.
Thank you, Chandramohan sir, for the wonderful presentation. Now I would like to call Dr. Gunadhar sir to speak about intensive care for stroke patients. Welcome, sir.
So, first of all, a very good afternoon, and I express my sincere thanks to the Indian Society of Neuroradiology to giving me this excellent platform to speak on the intensive care management. I think most of the things has been discussed in the morning regarding the care pathway. So as an intensivist, my job is to summarize the overall care of a stroke patients. So in this heading, I will proceed like epidemiology, the strokes type requiring the ICU admissions, the different intensive care issues, dilemmas, standard of care, the recent advances, and of course the evidence-based medicine. I hope this will be a very interesting topic to all of us, because this will summarize the overall care plan in the ICU. So all of us know this regarding the simple statistic like the disease burden and about the brain. So almost 20% of the total body oxygen consumption is being taken by the brain, and almost it utilizes 25% of the body glucose utilization. So that is why hypoglycemia is one of the very determining factor. And whenever the patient with altered neurological state comes to us, I think hypoglycemia should always be ruled out. And disease burden is very severe. Almost in the morning, the speaker has shown like one of the 4th leading cause of death, 5th leading cause of morbidity in India, 40% more in males, the 60% sometimes. This is a very contrasting thing in the females, and 1 in every 18 deaths belongs to the stroke patient. And we know there is a time window, is the golden hour, time is the brain. So that is the reason we have to be very careful. Our actions should be based on the appropriate timing to identify the stroke and to treat it. And this is the different categories of stroke extensively discussed in the morning, like starting from the etiology to the vascular system classification, whether it is arterial stroke, venous stroke, the pathophysiology, whether it is an infarct or hemorrhage, or whether it is the site of the lesion, like whether it is anterior circulation, posterior circulation, whether it is an intraparenchymal bleed, or it is a like subarachnoid space bleed, or the like according to the clinical classification, like whether it is a lacunar infarct, or the common pathophysiology, whether what is the cause, like white stroke, red stroke, embolism, thrombosis, small vessel occlusion, and of course the dissections. So these are the very important points for an intensivist actually matters, because unless until we know the type of the stroke, the cause of the stroke, the management is sometimes a little different, and we actually cannot focus on the care plan. That is why this slide summarizes overall the classification, and this is basically the pathophysiology. So what happens in a stroke? Like one is the tissue injury, second is the hypoperfusion, third is the hypoxia, and fourth is the generation of all these oxidized free radicals which causes the brain damage. So there are a lot of these free radicals and lot of generation of the anaerobic metabolic pathway leading to lactic acid production, and that actually contribute to the morbidity, mortality, and the poor outcome. So that is the reason. So we have to maintain the appropriate oxygen saturation and prevent lactic acidosis, whether it is in the brain tissue or overall in the body. And now the excitatory neuro markers like the glutamate and other things also now it has been found to contribute to the injury of the stroke. So the focus on is to prevent this excitatory free radical generation, and that is why a lot of trials are being conducted over the neuroprotective agents. Though right now there is no major literature which suggests that they are helpful, but I am sure going ahead further, there are definitely drugs which to be administered early, and actually it is going to change the outcome, and that is one of the focus area in the future. So this is basically a simple thing like you have to act fast. These are the simple signs, warning signs of stroke. So like the facial deviation, the arm drift, the speech abnormality, and time is very crucial. Of course, these are the different pre-hospital stroke screening tool, because the intensive care job not only start from the ICU, but it is the pre-ICU care and the post-ICU care. So as an intensivist, you have to focus actually starting from the time of the stroke in the emergency, and before the patient reaches hospital, if any information is available to us, it is always better. That is the reason this scoring system is sometimes very important, and of course these are the 8 Ds of stroke care, starting from the detection of the stroke to dispatch to the stroke centers, dedicated stroke center. In the morning we had extensive talk on the stroke mobile unit, which is very important. The delivery like prompt transport and pre-hospital notification to the hospital, the door like giving the appropriate thrombolysis agent in time, the data collection, of course the rapid AI has evolved in a bigger way, the decision making whether to go for thrombolysis or mechanical thrombectomy, and of course the drugs like anticoagulants, therapy induced bleed, which is to be treated by appropriate reversal agents, or if there is ischemic stroke, we have to treat with thrombolysis. This is the AHA guidelines. So what I just want to show you the timing. So you can just note the timing. So the time of arrival, the stroke happens, the ED arrival, in the 10 minutes you have to perform the general assessment what the AHA recommend. So immediate general assessment and stabilization has to be completed within 10 minutes. Within 20 minutes, the immediate neurological assessment has to be done by a trained person like a neurologist or a ER physician, like few pertinent history, establish the time of symptom, perform a neurological examination, NIH scoring, which is very important, and of course the Canadian neurological scale if some hospital follows. And of course, within 45 minutes, the CT scan has to be done, and you have to interpret the CT scan within 45 minutes. So these are the standard recommendations. There is no deviation. The hospital emergency room has to follow it, and this is the standard of care and the guidelines what suggest. Similarly, if the CT shows hemorrhage or no hemorrhage, so if it is a no hemorrhage, it is called ischemic stroke. So the appropriate thrombolysis window should be done within 1 hour if the onset of the stroke is known. And of course, if it is not a candidate for the thrombolysis, then particularly the patient should go to the ICU or OT, depending on whether it is a intracranial hemorrhage or your other venous infarct. So the purpose of showing this, time is very vital. So every hospital should have a stroke code. So whenever there is a stroke in our hospital, particularly we announce the code stroke 3 times so that everybody is becoming alert, whether it is a night time or daytime. And this is the stroke scale, that is called the NIH scale we usually normally follow in the ER when the patient comes. And as per that, we take the decisions of thrombolysis, like whether it is a high grade, if the NIH scale is 0 to 4 minor stroke versus almost 5 to 15 moderate stroke, 16 to 20 like moderate to severe stroke, and almost if the NIH score is more than 20, it is a severe stroke. We know that any severe stroke will require ICU admission, and sometimes moderate stroke, which actually require thrombolysis, will require sometimes the ICU admission. So these are the 3 kind of stroke which go to the ICU, NIH score more than 5. And this is the stroke unit, I can say the stroke team. The stroke team consists of the, starting from the ER physician, neurologist, neurosurgeon, the intensive care physician, the ER head, the radiologist head, one of the administrator, which should be alerted through the your code stroke, and sometimes the specific message also goes through the rapid AI system, so that they may be alerted in the time that some patient has come and now we are taking the patient to the MRI scan. So core and penumbra, very, very vital. Core is already damaged tissues and penumbra is the tissue which we want to save. So our goal is to focus on, is to protect the penumbra area as much as possible, as early as possible, and this is called the tissue window. So compared to the time window, so we know that if normal tissues, almost the blood flow, you can see the 200 grams per minute, 200 ml per 100 grams per minute to the penumbra area where the blood flow rapidly and significantly decreases to the range of almost 10%. Okay, so it is 20 ml per 100 gram per minute to the infarcted score where the blood flow is almost, you can say, the negligible, and this is the dead tissue. Similarly, the oxygen extraction fraction. So this is basically the pathophysiology, like immediately there is a stroke like atrial occlusion, there is a hypoperfusion. That leads to anaerobic glycolysis. That leads to increased oxygen free radicals. There is a cellular sodium influx, excitotoxicity, and the tissue infarction. So ultimately this leads to the core. So initially the tissue at risk, this is called the penumbra, and we can detect it by angiography, perfusion gated imaging, or by MRI scanning or pH imaging if the facility is available. And of course the core tissue, there are very limited modality like diffusion flare mismatch, which has been discussed extensively, and as per that the rapid AI you have to take a decision whether to take the patient to the cath lab or to not to take the patient to the cath lab. So this is our stroke pathway, like clinical stroke pathway, what we follow, like particularly this is the recent 2023 stroke pathway. So we can see these pathways are being taken from the American Heart Association guidelines on emergency cardiovascular care 2019 and National Institute of Health Stroke Scale 2013. And this is the thing we do, plan, do, check and act once the patient arrives. And this is our window time, like between 4.5 to 6 hours, vessel imaging to be done, and up to 4.5 hours, we know that the patient can be thrombolized. Between 4.5 to 6 hours, depending on the large vessel occlusion, the patient to be taken to the mechanical thrombectomy. And between more than 6 to 24 hours, of course, if we establish the penumbra, here is the challenge. And here actually the role of the rapid AI, which actually tells us that you have to take a decisions. And this rapid AI can tell us about the aspect scoring, and it also guides us whether this patient is going to benefit by doing a mechanical thrombectomy. So this is the stroke seat basically which we follow. So this is called the stroke pathway. This pathway continued up to the ICU, then to the ward until the patient get discharged. So this is what, if the patient is a candidate for thrombolysis, the TPA should be given as early as possible, preferably within 3 hours, if not 4.5 hours, and as soon as possible. Two types of TPA, I can say the altiplase, retiplase, and tenecteplase. More commonly used altiplase and tenecteplase. Lot of debate and discussion has happened, so I'm not going into that area, but only thing I can say that if you have a facility to have a tenecteplase, use it. It is very fast, simple, and a single bolus dose is effective. It is also cost effective, helps the patient, and without any significant difference in morbidity or mortality. And these are the different comparison trials. Today morning we had a discussion regarding 0.2 milligram versus 0.25 milligram. So normally the standard dose what we use in our setup. And these are the different indication. I think the only message I want to share here is that unless until there is a bleeding diastasis, you can use TPA as far as possible. So there are very few relative contraindications, but of course you have to document it in the paper if you are not giving a TPA, because most of it has been found that almost in 90% of the patients the TPA is going to help. The ECAS 3 data, the ECAS 4 data is now going on. So every trial has shown that the window can be extended. Now the extension of the window is going up to 16 hours for this thrombolysis. So I think in the future we may get a better window for the stroke patient. And this is the different guidelines for the patient with intracranial hemorrhage. So the evidences and what we do basically immediately do a non-contrast CT to establish the hemorrhage. If it is a lobar hemorrhage or if it is a hemorrhage which is more than 30 ml and 1 centimeter from the surface, ideally this should be evacuated immediately if the patient has a signs of increased ICP. So there are two things. One is called the hematoma expansion and second is called the spot sign. So any patient who comes to you with a small size hemorrhage, there is a chance of hematoma expansion. So never ignore a small size hemorrhage. Second thing, if the patient is on anticoagulation or antiplatelet, there is always a chance of hematoma expansion. So those patients should be very, very carefully monitored. We have a different set of drugs to rapidly reverse the action of anticoagulation if the patient was taking previously. And these are the drugs actually, I can say. So available reversal agent. So in all the cases, now the standard of care is to give a 4-factor prothrombin complex concentrate. It will reverse the action of vitamin K within 30 minutes compared to the FFP. It is very rapidly acting. But if you have a facility to give idarosizumab, particularly for the dabigatran-induced bleed, you can go ahead. We have never used it, not yet used it, but these are being described in most of the European centers. Similarly, like particularly another drug, which is called your adenexate alpha. This is particularly useful for patients who are taking factor 10A inhibitors like apixaban, endoxaban, and rivaroxaban. So we have a specific antidote for apixaban that is called the praxibind. This is readily available. So these drugs should be always be there in a patient in ER, because we don't know if the patient has taken an anticoagulation, he has a bleed and he comes to the ER. These drugs actually serves the wonderful journey in managing the stroke patient. So these are the different comparative trial of different antidotes, so idarosizumab versus the adenexate alpha, but the 4-factor PCC is readily available and one can use it. These are little costly agents, particularly the cost of a 25 units vial is 45,000, around 40 to 45,000. So normally the patient has to spend around 70 to 80,000, but this definitely matters a lot. For an intensivist, the more important part is the blood pressure control. We know that there is a fluctuation in the blood pressure and the BP shoots up when the patient has a reactive ICH or your stroke. So the trials which shows that you can safely come down to the BP up to 140, the INTRACT trial and the ATTACH trial. So almost the sample size is almost around 500 patients, and they have found that if you safely reduce the BP up to 140, there is no difference in the mortality. So the BP target should be kept between 140 to 90. And these are the agents which are useful for that is particularly the labetalol. We use labetalol, or there are studies on the nicardipine also, but we found comfortably labetalol, and we used the labetalol in a continuous infusion form and titrate the BP, because it has been found that more is the blood pressure, more is the chances of reperfusion, your bleed, and if the patient has already undergone some procedures like thrombectomy, if there is a reperfusion, that can cause the reperfusion bleed. So that is why this is the recommended blood pressure management trials. Similarly, if the patient has a severe ICH and the patient has already been on the severe rise in ICP, you can go for something called as the ICP monitoring and the ventriculostomy. So after that, these are the different ICU care issues. So one is, the most important is the cerebral edema. Second is called the rise in the ICP. Third is called the seizure and refractory seizure. Something called as hemodynamic instability, prolonged ventilation, weaning failure, poor prognostication, ethical dilemmas, and prolonged rehabilitation care. So basically, these are the different complications was the stroke patient who are on the ICU they encounter, starting from the bacterial pneumonias, systemic infections, sepsis, depression, anxiety, mania, dementia, and cognitive impairment. So we have to treat every element. Cerebral edema is very, very common. So this is the one of the most important issues to be addressed, because after a stroke, major stroke I can say, or a major decompressive craniectomy, so if the patient comes to the ICU, for first 2 to 3 days, I can say 3 to 5 days, the patient is at risk of cerebral edema. So, and this leads to devastating complication like different kind of herniation. So it has to be controlled by appropriate therapy. And the therapy starts from tier 0 to tier 3. So this is called the Columbia stepwise approach, where we have to put the patient on ventilator. You have to absolutely sedate him, ventilate him with ICP monitoring devices, like keeping the head end of the patient elevated, monitoring the EtCO2 in the range of 30 to 35. Hyperosmolar therapy, either 3% NS or mannitol. So we give continuous infusion of 3% NS in the range of around 20 to 25 ml per hour initially, followed by a slow gradual reduction of the as per the sodium load. And sometimes the CSF diversion. If the patient already has an EVD, then probably sometimes we may have to drain a CSF to reduce his ICP. Second is sedation and analgesia is very, very important. The patient should be in a deep plane of sedation. There should not be any cough. The patient should not be fight, agitate, buck on the tubes. He should be absolutely paralyzed for 2 to 3 days, at least in a low level of paralysis. This is just to prevent any kind of herniation and acute rise in the ICP because of the cerebral edema. Temperature is very important. You have to monitor the normothermia. Now the trials are coming up where they have found out that hypothermia is sometimes going to be useful, but till now the studies small, the sizes are, the sample size is very small. That is the reason. So normothermia is till now recommended. And of course, if there is a malignant rise in the intracranial pressure, sometimes you have to take the patient for the decompressive craniectomy and clot evacuation, and then followed by the proper ICU ventilation, and you have to sometimes keep the patient on the deep plane of sedation by monitoring different sedation score. So this is what basically the classification of the cerebral edema, starting from the vasogenic edema to cytotoxic edema, and so these are the different etiology of the edema. But whatever may be the etiology, so the therapies are only either mannitol or 3% normal saline. So mechanism of action, mannitol basically decreases the cerebral edema by causing the osmotic diuresis, whereas the hypertonic saline that directly increases the serum sodium, and this reduces the your cerebral edema by preventing your translocation of the water. The efficacy, of course, the mannitol initial effect is more pronounced. So mannitol causes initial rapid reduction on the ICP. So when the patient comes to the ER or ICU, we tend to give a 300 ml of dose of mannitol, followed by maintain the patient on the 3% normal saline. And the limitations are many, because we know mannitol causes lot of electrolyte imbalance. It is not good for patient with renal failure, cardiac failure. We have to monitor the osmolality. We have to monitor the other things like CVP. But in case of 3% in normal saline, it is safe. There is no such issue except the sodium monitoring. It is almost safe for other kind of patient, and it is safe for the patient with kidney injury, safe for the patient with cardiac injury. But only thing is, it sometimes lead to the severe volume overload that we need to careful about. So in one aspect, mannitol is sugar, or 3% saline is a salt. So which is better, which is not better, it is always a debate, but we found 3% saline to be more comfortable, and monitoring is much better easy, and that is the reason we use in our center 3% normal saline. So prolonged ventilation, we know that stroke leads to a lot of systemic inflammatory response syndrome. There can be secondary lung damage. There can be organ-organ crosstalk because of the brain. The lung suffers and the heart suffers. Patient have came to the ER with ST elevation MI, found then the emergency physician sometimes diagnose the patient as MI, but actually there is a stroke. So sometimes the brain injury can lead to injury in the heart. That is the reason evaluation of every system is very, very important. And of course, these patients, they require prolonged ventilation. We anticipate the average ventilation time of 3 to 5 days. So that leads to your ventilation-induced diaphragmatic dysfunction, muscular atrophy, critical illness, neuromyopathy, and other mechanical ventilator issues. So like ventilator-associated pneumonia. So prevention and treatment of all these entities is very, very important. And there are a lot of risk factors. So now the trials have shown that if your patient, once the cerebral edema part is subsided, the ICP comes under control, you have to consider them from early tracheostomy. So the trials are more favoring towards early tracheostomy. You do a tracheostomy, wean them off, do a physiotherapy, mobilize, and then the patient will get better rather than continuing with sedation, ventilation. So the concept is the less is more in now in the critical care. So the early you wean them off, the better. So these are the different malignant stroke, like with malignant cerebral edema, where the patient has gone for decompressive craniectomy after a procedure or sometimes because of the stroke itself. And the trial has favored that only in case of where you suspect there is a malignant rise in the ICP, those patients you subject for your decompressive craniotomy. So there are causes of seizure, whether it may be early onset, late onset. Sometimes early onset seizure is because of the physiological changes or pathophysiological changes. The late onset seizure is because of the lot of structural changes. Sometimes the stroke patient can throw seizure after 3 weeks, 4 weeks, or sometimes after a month. So those cases are because of the meningeal cicatrization or gliosis. So those cases are only secondary anti-epileptic prophylaxis is indicated. The primary seizure, we have to treat with midazolam or short-acting drugs and then maintain with the levetiracetam and monitor the patient with the EEG, continuous EEG monitoring. So management of hemorrhagic transformation, lot of has been discussed in the morning. So my only thing is whenever the stroke is big, whenever the blood pressure is fluctuating, and whenever the patient is on antiplatelet therapy, those are the patients who are high risk of getting this hemorrhagic transformation. Be closely monitor them. Probably they are the candidate who go into the hemorrhagic transformation. And of course, some patient, in spite of the best effort, they don't, neurologically they don't get better. Ultimately, sometimes there is a progressive element to the stroke, like we have discussed, rapidly progressive stroke, which leads to sometimes brain death. And ultimately, the patients, we have to counsel the family further the end of life care or whether for the organ donations and other like ethical issues, ethical dilemmas. Now, small thing about the neuromonitoring. Now, these are becoming more and more coming into the neurocritical care. So, the standard basic monitoring to the advanced system of monitoring. So, the ICP, which is initially monitored with your invasive monitors, ICP monitor, to now the non-invasive ICP monitor like transcranial Doppler or optic north-south diameter. So I insist all my fellows and all my juniors to keep the ultrasound probe and echo probe in their hands so that they can easily monitor the optic north-south diameter. And any optic north-south diameter more than 5 to 6 millimeter, it usually points out to the rise in the intracerebral pressure, intracranial pressure. Then that is a very good, simple, handy tool, bedside, and they can monitor every frequently in the every shift. And that actually sometimes leads us to a very good outcome. Similarly, the other like transcranial Doppler, we don't have a facility, but yes, of course you have you can monitor the flow, you can monitor the velocities, and this also is one of the very good tool in the intensive care, which is coming in a big way. The other monitors like BIS monitors, which actually shows us the level of sedation, whether the patient is in the deep level of sedation or the lighter plane of sedation, you can monitor by applying the BIS monitor. Similarly, the near-infrared spectroscopy, which actually monitor the cerebral metabolic rate and cerebral oxygen consumption. So now the concept is like there are localized reperfusion and your hyperperfusion in the areas of the brain. So you have to monitor the every areas of the brain. So these are the three monitors, like one is needs cerebral microdialysis and cerebral oximetry, which actually has changed this concept. And by this we can monitor the regional circulation of the brain. So particularly the cerebral microdialysis and cerebral oximetry. So it is just simply like a dialysis machine, like there are a very handy portable machine where a small probe is being inserted into the brain and a dialyzed fluid is being flown to your brain through the ventricular catheter, and the collection material which is collected out is being analyzed, and we analyze basically the pyruvate and lactate pyruvate ratio. And if the lactate levels are high in the efflux fluid, that is a poor predictor that this patient is actually not doing good from the neurological point of view. So these are the monitor which will tells us about the prognostication for a patient who are on the intensive care unit. Like this is one of the monitor which is called the Lycox monitor, which actually monitor the regional brain oxygen saturation just like a pulse oximeter. So like if the certain areas of the brain are hyperperfused and low oxygen extraction is happening, you can easily put this probe and you can see that here the value is 33 and this shows actually the brain oxygen tissue saturation. This is called PbTO2. So similarly we interpret how we interpret the pulse oximeter reading. And of course, stroke is not a single system disease, it is a multi-system disease because stroke leads to systemic inflammatory response syndrome. There are initial 2 to 3 days, there is a cytokine storm which happens in the body because of the massive stroke. That leads to organ dysfunction, pituitary dysfunction, adrenal insufficiency, stress cardiomyopathy, conduction abnormality in the heart, acute lung injury, infections, ARDS, neurogenic pulmonary edema, venous thrombosis, thromboembolism. It's a hypercoagulable state. You have to give DVT prophylaxis. It's a state of disseminated intravascular coagulation. And if the SIRS response predominant, it may lead to liver failure, peptic ulcer, hypercatabolic state, and ultimately leads to your malnutrition, kidney failure, and electrolyte disturbances. So we have to think from all these aspects. That is the reason we have developed this protocol of fast hug and BID. So every patient who are on ventilator, stroke, major stroke, we have to monitor their feeding, analgesia, sedation, thromboprophylaxis, head of position, ulcer prophylaxis, glycemic control. We have to give them spontaneous breathing trial. We have to take care of their bowel care, indwelling catheter care, and de-escalation of antibiotic. So we have to monitor their glucose load, their nutrition, their protein load, caloric load. So normally we give 25 to 35 kilocalorie per day. We have to give them adequate sedation in the night and in the evening, and every morning we stop sedation and give them spontaneous breathing trial. We consider for them early tracheostomy, give them a ulcer prophylaxis in the form of pantoprazole because it's a stressful condition, so they are very prone for developing stress ulcers. We have to keep them always in the propped up position to prevent the aspiration and your ventilator-associated pneumonia. We have to monitor their glucose level between 140 to 180 because it has been found that high glucose as well as low glucose both are dangerous and not good for the brain patient. Optimum fluid balance is very, very important. We have to start with hypotonic, not hypotonic fluid particularly normal saline or hypertonic fluid. That is better. So dextrose fluids are being avoided and dextrose containing solutions are not given as a IV fluid therapy. As soon as possible, you have to de-escalate the antibiotic. And there is no evidence that giving a prophylactic antibiotic when the patient is on ventilator actually helps the patient. Artificial intelligence, already I think we had a session, so how this artificial intelligence is coming in a big way for the stroke, like starting from the rapid AI to starting from the artificial ventilation, starting from the artificial monitoring of the different brain parameters, detecting the cerebral edema and the intracranial pressure. So these are the artificial intelligence in stroke. And now the post-ICU care in the form of robotic-assisted neurorehabilitation. So here we basically have different devices like Locomat or Erigo, where we take this patient on the daily basis and perform these exercises to prevent the critical illness, neuromyopathy, and critical illness myopathy. We also do speech and swallow assessment and therapy, and these are the different devices. So this is one of the devices, Locomat and Erigo device, where the patient, they walk on such devices. It is a robotic-assisted technology. So now that is where the stroke care has gone from precision medicine to the personalized medicine, and actually a good stroke unit actually leads to a better outcome for the patient. And this is one of our patient actually where he is performing this Locomat device. He is having one-sided weakness on one of the lower limb, but with the robotic-assisted technology, he is doing this Locomat device. So this is normally what we encourage once the patient's trunk control is achieved, once the patient is out of a ventilator, is out of the oxygen support, then you taken them to this rehab care and we train them. We have like most of the literature which in the world they says that this kind of rehabilitation sometimes actually improve the much outcome. Neuroplasticity, of course, now it has been a renowned fact that the area of the brain which is damaged, sometimes the normal brain can take over if we train them. That is why this rehabilitation program and neuroplasticity enhancers are now coming in a big way, like the training and the other therapies, and these are actually the now going to be the future. So in my conclusion, so the initial assessment is very important, rapid evaluation of neurological status, identification of the stroke type from the intensivist perspective, whether ischemic, hemorrhagic, vital signs monitoring, early thrombolysis, continuous monitoring of the blood pressure, heart rate, respiratory rate, maintaining vital parameters, ensuring a patent airway, early ventilation, and continuing the ventilation and early tracheostomy whenever is appropriate, fluid management, administering the thrombolytic agents in time, anticoagulation, and of course DVT prophylaxis. Sooner the better. Now, and it has been a recognized fact, even if the patient has a intracranial bleed, you can start with the DVT prophylaxis in the current standard recommended dose after 48 hours. So normally we give after 48 hours very low dose of low molecular heparin to patient. So frequent neurological assessment by expert neurologists to detect any deterioration of improvement, temperature control, normothermia, early initiation of enteral feeding, and addressing pain, early involvement of rehabilitation specialist actually improves the outcome of stroke patient. The psychological support to the relatives are very important, and of course repeated imaging wherever is required is almost the standard of care. And this is a team effort, and the team consists of all these, starting from expert neurologist to neurosurgeon, intervention radiologist, to the primary care providers, to the expert intensivist. So thank you.
Raghunathan Padi, for your extensive talk on intensive care for stroke patients.
Thank you so much, sir, for sharing your insights on intensive care that we have to take for stroke patients. Now, I would like to call Dr. Rinoy R. Anand, sir, to share some of the complex cases out of his experience. Welcome.
Very good evening to all. Myself, I am Dr. Rinoy R. Anand, and before talking, I want to thank Shiba sir and the ISNR Society for giving an opportunity and conducting such a wonderful event. And also, I would like to thank all the speakers who had presented very nice talks, especially the previous talk by Chandra Mohan sir. That was clearly an eye-opener. And I will not take much time. This is already late, so it's hardly a 5 minutes talk.
You can take time, Rinoy. Rinoy is a brilliant interventionalist, and he does some fantastic cases I have seen. You take your time. Don't worry.
Yes, sir, sure. Actually, most of the brilliant cases were shown by Dara sir and Jenny ma'am. They were much extensive. I'll just show only 2 cases. So the first case is a 16-year-old child, 16-year-old lady who had no past history. She came to us at 5 hours of onset with severe hemiplegia and drowsiness and also dysarthria. Actually, the first respondents thought it was functional disorder, and there was slight delay in diagnosis also, and the second diagnosis was a seizure, but both were negative. When we did an MR, we came to a shock that she had a massive infarct in the right MCA tertiary, and as well as few of the infarcts in the AC tertiary also. So this was the MR angio, which shows the MCA occlusion. The right ACA also is not changed. What we are seeing is the left ACA. And this is the corresponding DSA, which shows a flame-shaped narrowing at the ICA top, and PCOM is seen there. And what could be the etiology? We were thinking of vasculitis or dissection, considering her age. She is 16 years. But thanks to a talk by Sharat sir, now we know that is probably focal cerebral arteriopathy. She did not have any history of any COVID at the time of admission. So considering her NIHS was around 20 and 16 years, we don't have any data on thrombolysis. So we discussed with the neurologist, and then we proceeded with thrombectomy. So this was her initial angio. You can see there was no significant pile collateral supporting the MCA tertiary. So we reassessed her before proceeding with thrombectomy on the cath lab table. Her NIHS was still higher. She was very drowsy, not intubated, but severe hemiplegia, power was 0, and dysarthria was progressing into an aphasia, and eye opening was slightly decreasing. And so we did a thrombectomy. Solumbra technique was used, cerebase guiding catheter and a REACT 71 aspiration catheter, and an embotrap stent retriever was used. This was the first attempt, and actually first attempt did not open. We did a second attempt. Second attempt I replaced the REACT 71 with a CAT 6 because I thought that REACT 71 was pretty large diameter for her sized vessels. So after the 2 passes, I was very happy. The MCA has opened. It is pretty good flow into the MCA territory. There is some thrombus sitting there at the proximal M1, which is the laser actually. You can see some thrombus sitting here at the MCA wall, but this happiness was short-lived. You can see there is some spasm developing, probably this is actually catheter-induced spasm at the cervical ICA, but you can see some recoiling at the MCA also with thrombus building up. So what we did is we give intra-arterial nimodipine, and after nimodipine, the cervical ICA spasm has completely relieved, but the MCA is still becoming worsened. There is thrombus building up, there is recoiling. So what we did is, we did a repeat thrombectomy, and then we started intra-arterial nimodipine, and then we gave intra-arterial tirofiban. Tirofiban 12 ml was given through a microcatheter placed at the ICA top, and then we followed it up with IV tirofiban 7 ml per hour. And this was what is shown here is the time. So after tirofiban, it was stable like this for quite some time, for 1 minute or 2 minutes. Then again after 2 minutes, there was slight progression, but the flow into the MCA territory was quite good. About 12 minutes later, there was complete shutdown. So this is the case. We have done thrombectomy 2 or 3 times, and then tirofiban was given, nimodipine was given. Still, it is not opening up. So what to do? The next option is doing a balloon angioplasty. As soon as we pass the wire for a balloon angioplasty, the vessel was slightly open, and you can see some thrombus also there. So anyway, the vessel is getting recoiled. We thought we'll do a submaximal angioplasty. A 2.5 mm angioplasty was done. And after angioplasty, the result was again good. But again, 2 minutes later, the MCA was like looking spasmodic or dissected. We don't know what is happening there. But the flow into the MCA territory, into the M2 and M3 was still patent. It was keeping there. We removed the wire, and we waited for another 4 minutes. That MCA is slightly better, but the flow was still patent. And again, after about 6 minutes, it is still patent. But what happens at, so this is at 6 minutes post angioplasty. The M1 looks bad, but MCA is spasmodic, but there is some flow. So we just waited. We were giving intra-arterial nimodipine as well as tirofiban. Tirofiban was given IV. Initially, it was given IA and then converted into IV. The MCA perfusion was quite okay. And 15 minutes later, it just shut down. So what to do? So this is a 16-year-old female. We don't know what is the etiology, first of all. Probably focal cerebral arteriopathy, probably vasculitis, probably dissection. We have already done 3 passes of solitaire and suction, the Solumbra. Intra-arterial nimodipine was given. Tirofiban was given. Balloon angioplasty was done. Ongoing tirofiban, and everything was done. So what is the next step? In an adult, we'll directly go ahead and put a stent. But in a 16-year-old lady who is very active, no past history, I was perplexed. I was actually much worried to put a stent. And finally, since there was no other option, I just carried on with a stent placement. I did not have any self-expanding stent in shelf, so I placed a coronary stent. And there was this mid part of the stent was not initially opening, but it later opened in the same balloon. And this was the angiogram after stenting. There was some slight size mismatch at the ICA top. So I post-dilated with the larger balloon and then matched that ICA. I was not happy at all on placing a stent in a 16-year-old lady, especially in whom we don't know what is the etiology. So this is what it was looking like in the end. There is some thrombus at the distal end of the stent, but altogether the flow was okay. Especially the MCA territory was filling. There was no much delay. And I just dropped it there. I don't want to meddle too much because, first of all, we don't know what is the etiology. And immediate post-procedure, we took a CT. She did not have much improvement. Immediate post-procedure, since there was no bleeding, we loaded with 300 mg aspirin and tirofiban was continued. We didn't load with Brilinda because we were not sure about how it will respond in a young brain. And there is some edema, but altogether we just waited. A patient was not intubated. Patient was she was conscious, slightly disoriented. And 6 hours later, to our miraculously, she improved. She started speaking, she started moving her limbs, she became much more oriented. But anyway, we wanted to rule out if she is developing any early bleed, and because tirofiban was running. And we did a CT. Actually, there was some mass effect. The ventricle, the right ventricle has effaced and basal cisterns has effaced. But when we discussed with the neurosurgeon, he told since the patient is improving, we'll just wait and watch. And we were actually happy because she was identifying the relatives, she was talking, she was moving. And we left her like that, but in the midnight, a nurse called, patient is not responding. We shifted to the CT immediately. The edema has increased, there is midline shift, and the pupils have started becoming anisocoric. We stopped the tirofiban, we called the neurosurgeon, took for emergency craniectomy, but she didn't recover after that. Her pupils became dilated, and she did not have any response, and she ultimately succumbed. So this is a post-procedure CT. So there are several questions in my mind. Few of them are, first one, should I have deferred this case? Her NHS was 20s and she was less than 18 years. What is the data on mechanical thrombectomy? What is the data on lysis? We don't know. And what is the strategy for a mechanical thrombectomy if there is any vasculitis or dissection or any arteriopathy like this? Should we not meddle too much with these diseased vessels? Should we just do and adapt and not using a stent retriever because we are irritating the intima and media when we are deploying and pulling the stent retriever? And if there is reocclusion, should we just stop at submaximal angioplasty or should we stent? So these are the questions. I could not find any good answers. Shiba sir?
Generally, what have been done, I have presented such a case in long back, 10 years back, Dr. Rajesh, me and Dr. Arvind have done in Seven Hills Hospital. We have shown it in complication meet in Europe. So there were many suggestions that has come out of that meeting, that some people have suggested that you should have your solitaire open because already antiplatelets and terofibans are going on. You should keep it open and leave it for half an hour because anyway you're not deploying a stent. So once half an hour is passed, the kind of spasm and thrombus load will reduce, then you can retrieve the stent. So here you are not deploying a stent who is below 18 years, number one. Number two, there is no need to continue tirofiban or antiplatelet because you have not deployed the stent. Next one, you have given the brain vasculature a good half an hour time to recover if there is an intense spasm. So that is one suggestion that can be looked into.
Fine. Thank you, sir.
You have one more case to serve? Or this is the one?
Yeah, one more case, but...
Yeah, please.
Can you hear me? What happened to ACA? You see, there's lots of ACA territory infection.
Yeah, ACA also was occluded, but since the stent was placed, we didn't have any other option.
No, then ACA is occluded and then MC is occluded for a long time. Then there's no collateral. Patient will develop massive infarction and then that's expected, no?
Yeah, but
no, opposite A1 was there or not there?
Yeah, opposite A1 was there, but the collateral was not good. ACOM was there actually, but I don't have the images. But I didn't attempt for an ACA this thing. Anyway, before that I have placed a stent.
I realized the ACA was gone after the first pass only.
Yeah.
then you should open the AC. Otherwise, there's no collateral. MC is occluded for a long time and your AC is also occluded. There's no collateral. Neuron will die in 5 minutes.
ACA was already occluded before and the CT was already showed ACA infarct.
Yeah.
If I see the first CT, the ACA was already gone. And ACA never opened all throughout the procedure as well.
Then this is
The first
futile.
diagnostic angiogram, we were seeing ACA or not? On
No,
the
no, no
ACA
ACA.
was never there.
No ACA. Even in
ACA
MRI
was
it was
never
not
there.
seen. It was occluded in the first.
Then this is futile attempt. I
But
never
16
opened well.
years, but yeah, 16 years we have to.
Let's go on to the next case.
Next is an unrelated case, and a 60s male, he came with a severe stroke, NHS approximately 18, aspects was 7. He came at 3 hours, we have lysed and shifted to cath lab. So he had an M2 superior division occlusion. You can see the occlusion here. And this is a usual case. We did it was actually a tortuous anatomy, cervical anatomy. We used a cerebase up to here and then a React 71 and then further upwards we used a stent retriever. This is not the final picture of stent retriever position. Actually stent retriever was pushed into the M2. I don't have that image. And the stent retriever which I used was a 3rd generation stent retriever. And while retrieving, there was movement of the stent retriever wire but not the stent retriever tip. I thought there will be, when we are removing the solumbra, always there will be some redundancy of the stent retriever wire. First it will come and then both the systems will come. But when I'm checking the fluoro, only the stent retriever wire has come. That means this is the proximal end of the stent retriever. You can see the stent retriever here. The proximal marker is here. That means clearly the stent retriever has got detached within the MCA, M2 MCA. So this is the stent retriever, and actually the proximal end of the stent retriever is coming up to the mid M1, and this is the aspiration catheter, and this is the wire of the stent retriever. And disclaimer, this is not a new stent retriever, it was a reused stent retriever. At least 3 passes was used in previous other patients. This was an ETO case, and because of affordability issues, we have reused that stent retriever. And this is how the angio was looking. You can see the distal marker of the stent retriever. The stent retriever is actually lying here up to the proximal M1. The proximal marker is not very clear here. And what to do now? So this is actually a 3rd generation stent retriever which has got an outer cage as well as an inner core. So the idea was to retrieve this stent retriever. So we deployed another solitaire. The major difficulty was to cross a second microcatheter into this stent retriever and distally. So it was very difficult for us because the inner core was there. It was not allowing us to pass a micro wire. But ultimately we passed somehow. So this is how we took an O14 wire and another O21 microcatheter. O27 microcatheter was not going through that. So we took an O21 microcatheter and deployed another stent retriever. And both were retrieved. And finally, along with that, the clot also came. So this patient had got good recovery. TK3 was achieved, and he was discharged 3 days later. Thank you.
Thank you, Dr. Yundai.
Thank you, sir.
As Dalai said, it requires a lot of courage to show those complications. Good job.
Thank you, sir.
Kavya, please go ahead.
So with this, we are going to conclude today's academic session. I would also like to conclude the memento distribution to all the speakers as well as the chairperson, for which first we would like to call upon Dr. Chandramohan sir onto the dais, please. Requesting Dr. Sharat Kumar Jiji sir to the dais. We will deliver it to his room.
Thank you so much, sir. For
Then
your,
calling upon Dr. Jenny Gandhi ma'am towards the stage. Thank you, ma'am. Next, I would like to call upon Dr. Dharav Keradia, sir. Next, I would like to call upon Dr. Bikash Kumar Mishra, sir. Next, I would like to call upon Dr. Rajesh Venkat, sir. Thank you, Chandra Mohan, sir. I think you can remain on the stage. Now we will ask Dr. Swati Halbe, madam, to come to the stage and hand over your memento to you, sir. Next, I would like to welcome Dr. Gunadhar Padi, sir, onto the dais. Ma'am, next we would like to call upon Dr. Rinay or Anand, sir. Thank you, sir, and thank you, ma'am. Now I would like to ask Dr. Azmi, sir, to do the honors. Sir, so Dr. Azmi, sir, will be presenting the memento to Dr. Anil Devarakasi, sir. Then the next moment will be presented to Dr. D. Rajashekhar, sir. And the next memento to Dr. Divya Rani, madam. So with this, very good evening to everyone who's been with us all the way. And hopefully we'll see you all tomorrow and even more brightened and freshened up. Thank you.
So faculty dinner here at the same venue, 7:30 p.m. today with some rocking live music. So all the faculty, chairpersons, moderators are invited to join. Thank you.